I would like to express our deepest gratitude and appreciation to all the eminent doctors and delegates from home and abroad for accepting our invitation and blessed us with your gracious presence after the era of COVID-19 here at Pan Pacific Sonargaon, Dhaka, Bangladesh. It's a matter of great pride for all of us that Bangladesh Society for Breast Cancer Study organizing the Breast Cancer Conference for the fourth time at Dhaka. Efforts rendered by Professor Dr. Kamruzaman Chaudhary, President, Bangladesh Society for Breast Cancer Study, and Dr. Mohammad Selim Reza, Vice President, has made it possible for us to be a part of this remarkable event. Breast cancer is one of the most common malignancies in female worldwide, which is preventable and curable if diagnosed at the earliest. Hence, we need public awareness and modern treatment facilities for battling against breast cancer. In today's program, at first we'll be having two scientific sessions before the inaugural session. It brings immense pleasure to let you know that the chief guests of today's program will be Professor Dr. Don S. Dejan, Director Medical Oncology, Rhode Island Hospital. He is also the Professor of Medicine and Professor of Surgery, Brown University Lifespan Cancer Institute and Ligorita Cancer Center, USA. Professor Dr. Mohammad Robert Amin, Line Director, Non-Communicable Disease Control Program, Director General of Health Services, and Professor Dr. Shapon Kumar Bandyopadhyay, Director, National Institute of Cancer Research and Hospital, will be present as special guests. Now, I request Dr. Arunanshu Das, General Secretary, Bangladesh Society for Breast Cancer Study, to come to the dais and say a few words and start the session. Dr. Arunanshu Das.
A very good morning to all. On behalf of Bangladesh Society for Breast Cancer Study, this is our fourth breast cancer conference. After a break of COVID pandemic, we are starting again. We hope it will be a very wonderful session. We have 16 delegates from around the world, very eminent presenters who will be telling about the recent update in breast cancer management. They have come from long way, from 4 continents of the world. So we are expecting a wonderful session. So again, on behalf of the Society, Bangladesh Breast Cancer Study Society, I am requesting all of you to join our session. Welcome to Bangladesh, welcome to the scientific session. Thank you.
Thank you, everyone. Please be seated. We are going to start our first scientific session now. We begin our first session today with hormone receptor breast cancer. This session will be chaired by Professor Dr. Parveen Shahida Akhtar, ex-professor and head of the Department of Medical Oncology, National Institute of Cancer Research and Hospital, Dhaka, Bangladesh. The panel of experts for this session will be Professor Major General Dr. Mohammad Azizul Islam, Brigadier General Dr. Mohammad Kudroti Ilahi, and Dr. Firdaus Shahriar Said. Our moderator during the discussion will be Dr. Shafatul Jahan, Associate Professor, Radiotherapy Department, Chattogram Mao Shishu Hospital, Medical College, Chittagong, Bangladesh. I request the chairman, panel of experts, and the moderator to take their seat in the dais and start the session. Ladies and gentlemen, there is a slight change in our first session of today's conference. Professor Shahida Daud is unable to join with us due to some unavoidable situation. Instead of her, we'll have the speech from Professor Dr. Paul Manwari. Thank you.
Distinguished guests, Assalamu alaikum and a very good morning to you all. Welcome to 4th Bangladesh Breast Cancer Conference 2022 arranged by Bangladesh Society for Breast Cancer Study. I am Dr. Shafatul Jahan and it's my honor to be the moderator of this session. So I am going to introduce the experts of this session. Today we have Professor Dr. Parveen Shahida Akhtar as the chairman of this session, and she is the chairman of Medical Oncology Society Bangladesh and ex-professor and head of the Department of Medical Oncology, National Institute of Cancer Research and Hospital, Dhaka, Bangladesh. As panel of experts, we have among us Professor Major General Dr. Mohammad Azizul Islam, Consultant Physician General, Medical Oncology, Director General of Medical Services, Ministry of Defense. We also have among us Brigadier General Dr. Mohammad Kudroti Ilahi, Professor and Head of the Department, Medical Oncology, Cancer Center, CMH, Dhaka. And we have Dr. Firdaus Shahriar Said, Senior Consultant and Coordinator, Medical Oncology, Evercare Hospital, Dhaka. As we move along to the session, we will be hearing presentations from Dr. Paul Manwari during this session. Dr. Paul Manwari is co-founder and CEO and chairman of Gene Technologies, Associate Professor, University of Queensland, Australia, and he was the former consultant medical oncologist, Icon Cancer Center, Australia. So I would like to request our Dr. Paul Manwari, please come to the dais and to deliver his speech.
Assalamu alaikum. Did I get that right? Trying to get the pronunciation right. Good morning, everybody. Thank you to the organisers and the scientific committee, to our honourable moderators here for the opportunity to share with you some thoughts about the management of the most common form of breast cancer, hormone receptor positive advanced disease in this country. I'd like to acknowledge that because I have a commercial background, I'm going to not talk about any conflicts of interest. And I'm grateful to my colleagues who shared with me their slides over the last 24 hours to put this presentation together from around the world. So when I was doing my thesis in London last century, we were very interested in understanding how estrogen drives the biology of breast cancer. And most of you are aware that it derives from cholesterol, converted into the androgens and progesterone, and the most important step was understanding the enzyme aromatase. So we were using tamoxifen then, but the aromatase inhibitors, AZD1976, was the first class of aromatase inhibitors, and we started doing clinical trials with it in 1994, before many of you were born. And the aromatase inhibitors caused a dramatic shift in our understanding of how to improve both response, progression-free, and overall survival. And by understanding that biology, the next generation of selective estrogen receptor degraders, SERDs, ICI 182780 we called it, fulvestrant is what you know it, really caused profound understanding not only of the protein level but also the changes at the transcriptional level. And these are important foundations for the next generation of medicines I'm going to share with you now. And the other important pathway is the PI3 kinase, AKT, P10, mTOR pathway. And the reason that this pathway is important is it's the second most common pathway that is aberrant across all cancers, and in particular, ER-PR-driven biology. More importantly, in the last 5 years, we understand how important this pathway is in the immune cell metabolism, but that's for another topic. So I'm very pleased to share with you the concept of inhibition of CDK4/6 inhibitors, because an Australian, Rob Sutherland from the Garvan Institute, with Elizabeth Musgrave from the Welsh Cardiff Institute, described the first overexpression of cyclin D as a driver of breast cancer. But targeting cyclin D proved too toxic in the mouse models and in the cell lines. So the pharmaceutical interest shifted towards the partner proteins, the cyclin-dependent kinase. So you all remember those horrible diagrams from medical school where we have to learn about anaphase and metaphase and telophase. And the important thing about those is you learn them the night before the exam and you forget them the day after. Now at my age, I've been teaching my children to go through and understand that. And one of the crucial points that was, for which an Englishman got the Nobel Prize, was understanding the restriction point. Cells have to understand whether they're going to live or die or grow. And that restriction point between G1 and S is crucial in ER-driven biology. It is controlled by the retinoblastoma protein complex. RB loss is very important in a huge range of cancers, particularly breast cancer, but lung cancer. But again, it itself cannot be targeted because it's a tumour suppressor gene. But by blocking the cyclin DC4/6 protein complex, preventing it from allowing cyclin D to drive retinoblastoma protein growth, we had another option for treating breast cancer. And as you know now, this is a standard of care globally. But not all patients respond. Some patients, about 10 to 15%, never respond, and particularly the luminal B cancers. Why is that? Well, here are two summary graphs which I think are very powerful to help understand. So on the left-hand side, you can see that we've got the income or the input of the estrogen receptor 1 driven pathway, and that drives progesterone receptor and in turn it drives ER biology. You've got the second pathway, the MAP kinase pathway. You've got the highly proliferative c-MYC pathway, and there are others, such as FGFR1, etc., that are coming on board, the smaller potential targets for the next generation of molecules. So de novo resistance clearly occurs in those who have retinoblastoma protein loss. But how do we measure that? We do not have accurate measurements because of the complexity of the biology. For de novo and resistant disease, even simple things like immunohistochemistry cannot reflect the biology because it's too complex. Overexpression of cyclin E, another driver in cell biology, is clearly associated with resistance by an alternate pathway, as is, I mentioned, FGFR1. The reason I mention these molecules, these pathways, is because there are molecules coming into the clinic in the next 12 to 18 months. When the FDA grants a drug accelerated approval, we know that there are relevant phase 3 trials that are near completion with confirmatory studies ongoing. So we can see where the pharmaceutical industry and the research community is driving, pun intended, the next generation of molecules. So keep your eye out for some very exciting drugs coming in this space. So I'm not going to go through the panoply of studies. Hopefully, the pharmaceutical industry here has gone through those ad nauseum with you. But what is really exciting, whether it be abemaciclib, palbociclib, or ribociclib, they all have very, very similar hazard ratios. In fact, there are 2 more CDK4/6 inhibitors that have gained recent approval, and they are going to be extended into diseases outside breast cancer, such as pancreatic cancer, which is quite interesting. So the dramatic improvements in progression-free survival that we saw from these original studies were amazing. We were sitting there in the clinic, women with livers full of metastases, with painful bone metastases, coming back 4 weeks later, asking to come off their opiate narcotics, asking if they can go out and play golf. And so we knew then that this was an exciting new class of compounds that are coming along. And despite the ability for getting access to these and other drugs later on, there is an overall survival benefit. So what that means is the new standard of care has to be finessed, has to be curated around the patient, not so much about the drug, but about the toxicities or the comorbidities. So if you have cardiac issues, you need to be careful with ribociclib, and you need to measure QTc prolongation. And in the original studies, I remember sitting there every clinic with my nurse, Kate, bringing me in the ECGs and measuring QTc and counting the small squares. Because there wasn't a reliable measure at that stage, but the QTc prolongation had been identified in the earlier studies. Palbociclib has higher rates of neutropenia, but you don't get febrile neutropenia. Why is that? Because although it inhibits the proliferation of the neutrophils, they don't damage the gastrointestinal tract, so you don't have that risk of febrile neutropenia. Abemaciclib has some very big structural differences. So its major toxicity is the diarrhea, which is easily preventable with prophylactics. So it's important when deciding which drug for the patient to understand their comorbidities. So we've got this combination, endocrine therapy, CDK4/6 inhibition. Does the backbone matter? What are the implications of mutations in the estrogen receptor gene? What about the next generation of SERDs? So I'm going to reverse the story here slightly and talk about Nick Turner from the ICR. Nick was in shorts and long socks when I was at the ICR last century. He was a highly intelligent resident, and when we did the ward rounds, you had to make sure that you knew more than the resident because he's super bright. So Nick initiated this extraordinary study using a technology called ddPCR, digital droplet polymerase chain reaction. Suffice to say, you can capture a small amount of DNA in a lipid droplet and do millions of experiments at once. So what they took is women who were on an aromatase inhibitor plus palbociclib and followed the ESR mutations in the blood. This is extraordinarily expensive technology. It is not ready for prime time. But what they did then was randomise women who went from their baseline reading, saw an increase in waiting for standard clinical progression or switching them early. And what you can see from the top graph on the right here is that those women who had the mutation did poorly. Those women who didn't have the mutation did well. And this is an important point because measuring ESR1 now is part of routine clinical care if you can get access to this technology. And we know it's not available here yet. So, understanding that switch, what is the correct switch? And this is a combination of 2 studies, one led by my friend Stephen Johnston, who shared these slides with me, where they put 2 trials together, Sophia and Effect, and looked at which patients did worse and with which drugs. So I'm going to ask you to focus on the bottom pink graph here. And the bottom pink graph is the patients who had mutations in ESR1 and exemestane. Because when they had mutations in ESR1 and were switched to fulvestrant, their survival improved. So this is the most important clinical evidence that using a selective endocrine response drug can overcome ESR mutations. So we've got this paradigm now of we understand the endocrine, AI plus CDK4/6 inhibitor on progression of ESR1 moving to a SERD. What do we do about the CDK4/6 inhibitors? Do we need to change them? Do we need to change drug? That's very, very different. You know, normally if you change a drug, you change from a one class, you don't keep the same class going. Or if you're super selective, if you've got slowly evolving women who've been on the combination of an AI and a CDK4/6 inhibitor for say 3 years, and they slowly develop small volume liver metastases or a few new bone metastases, what do we do with those patients? So in this study called the MAINTAIN study, a very tiny phase 2 study, so I'm not saying this is ready for prime time yet, but 86% of women were on palbo plus an AI. And then they were switched upon progression to ribo plus changing the AI, changing the endocrine therapy, or placebo with a switch. And what they were able to demonstrate again was it was the women who switched to a SERD that gained the benefit, and you could maintain the CDK4/6. So that's really, really important for helping set the ground for the next generation of studies that I'm going to share with you. So it's not so much keeping the CDK4/6 going, it's about switching the endocrine therapy. Why is that important? Because if fulvestrant is the new gold standard of second-line therapy, we know how painful, pun intended, fulvestrant is. Particularly when you have the 500 milligram starting dose, one in each cheek of the bottom. It's a tough challenge. And when we were doing this in the late 1990s, women thought we were crazy, saying we wanted to inject them with some oily substance in their bottom. The new formulation is a lot kinder. So in the EMERALD study, we've got a new oral tablet versus standard of care in HR positive, HER2 negative advanced breast cancer that's progressed on a CDK4/6 inhibitor. And clearly you can see here that this is a new paradigm coming through. What does that mean, Paul? Because the next generation of phase 3 studies are going to be a combination of endocrine therapy, oral, plus CDK4/6 inhibitor, oral, plus potentially bone-modifying agents with a subcutaneous. So we can treat 70% of advanced breast cancer as an outpatient and avoid the toxicity of chemotherapy because there are more oral drugs coming along. So the other pathway I mentioned was the PI3 AKT PTEN-mTOR pathway. It's quite a mouthful. So when we look at if we go to CBioPortal, which is the big collective database of all the aberrations in the different cancers, you can see that in about 30 to 40% of hormone-positive breast cancer, you have two major sites of aberration in PI3 kinase. And I won't go through a lollipop diagram, but 542K, 545K, 1047R, or 1047L are the four major, that's over 90% within that subgroup. Rarely you can have mutations in the AKT, particularly E17R or 17K and 17R, K goes to an R, and losing P10. Again, we use immunohistochemistry because it's a tumour suppressor gene, but there are many other new ways suggesting that loss of P10 is much more common than we see. Epigenetic silencing through methylation is one, and we can talk to you about that later. And this is a ubiquitous program, so we're going to be learning a lot about this in many, many tumour types. So Fabrice André, head of research at Institut Gustave Roussy just outside Paris, was the lead author on the New England paper and the principal investigator for the SOLAR-1 study. And they took a biomarker positive and a biomarker negative group. So let's just look at the biomarker positive group. Those who had mutations in these 4 hotspots, because they could only measure 4 hotspots on PCR at that stage, patients, so 341. That's a huge number of women to collect. It was a global study, but 60% of the women came from France. And those women were randomised to fulvestrant plus or minus this new PI3 kinase inhibitor, alpelisib. Now, I don't need to tell this audience that we do not understand the application of these molecules on the Bangladeshi female genome. We do not have prospective studies where women from this country were acquired into the clinical trials and investigated as a different group. But we do know from bitter experience with docetaxel, capecitabine, even the CDK inhibitors, that we metabolize drugs in this country differently from a Caucasian genome, from a Han Chinese genome, from a Malay genome. So I would strongly urge the doctors in this audience to think about the patients, and if they are obese, if they are pre or diabetic, start at a lower dose and increase the dose rather than a Caucasian dose. Because the toxicity of the hyperglycemia can be exceedingly difficult to manage. And I remember being dragged into the hospital at 2 a.m. one morning because a colleague of mine was away on holiday. A patient was in the SOLAR-1 study and had a blood sugar of 40. And we had her on an insulin pump, we had her on metformin, and she was still in a ketosis, and we had to send her to the intensive care unit. So it's not a trivial toxicity and has to be managed with foresight and care. But overwhelmingly, we could see very early on in this graph, look at how quickly the survival curves separate at the first analysis, that adding this drug to fulvestrant, if you have a mutation in this pathway,
so we have 5 minutes.
Progression-free survival. So here's the toxicity. So the FACTION study now looks at fulvestrant, but an AKT inhibitor. And again, from Nick Turner's group, we can see a benefit for this combination. And the phase 3 trial of capi plus fulvestrant versus placebo plus fulvestrant has just published a press release saying that it has met its progression-free survival benefit in the biomarker positive group. And indeed, we're now looking at triplet therapy, but that's just to put in the back of your memory as opposed to worrying about that coming to the prime time. So the other important issue is the Angelina Jolie effect. When she underwent her double mastectomy and bilateral oophorectomy by TARI, the number of women being referred for genomic testing went through the roof across the globe, and one of my friends, Sunil Verma, has actually published on that. And we now have an expanded portfolio, BRCA1, BRCA2, RAD51C and D, and PALB2, that should be routinely tested, and there's a conflict of interest there from our company. And what we've demonstrated is that in the vast majority of women hormone receptor positive disease, we can double that number, but in triple negative disease, we can increase that number 4-fold, who are susceptible to therapy using PARP inhibitors. So from the Olympiad study and from the BRCA study, they clearly have a survival benefit, and it's very hard to argue not giving these women these drugs. So the new algorithm is starting to be driven by molecular diagnoses. We start with a combination of an AI plus the CDK4/6 inhibitor. We wait till they develop resistance that we can measure. We switch the endocrine component. We start thinking about PI3 kinase and mutations, and of course, we have to measure their germline. So my final slide is going to be the most complex one. And please don't think that you have to write this down, okay? But there will be a test on it later. But the exciting thing about the biology of this area is that by molecular dissection of the understanding of this disease, we can shift from shotgun chemotherapy to de-escalating the toxicity, to improving the benefit, improving the therapeutic ratio with targeted therapies. Thank you for your attention.
A lot of thanks, Dr. Paul, for your excellent presentation. So, it's time for the question answer session, and I request the audience to ask your question if you have any. Then we will proceed for the discussion and the comments from the panel of experts.
So phenomenal presentation, Dr. Paul. Thank you so much. This is Dr. Shahida from National Cancer Institute. So much and so good data. So it is crystal clear that CDK4/6 inhibitor and a hormone partner is the standard of care, first line, second line, in the hormone receptor positive metastatic breast cancer. But what about the subset of patients who are ERPR low, that behave more like TNBC, or the LUM-B, which is more chemosensitive than hormone sensitive? So for this group of patients in metastatic setup, what would be the right way to go?
Thank you so much for that difficult question, and we could be here all day discussing that. So, as we know, in Bangladesh now, you're getting access to good immunohistochemistry. So, as part of a routine, Nick and I in Australia, we see Ki67 reports with every woman with breast cancer. But we all know that the ability of a pathologist to read Ki67 has about 75% only correlation between world experts. Mitch Dowsett and
Sir, so what should be the protocol in this kind of patient? On hormonal therapy, like 1 to 2 years, and now they want to complete their family.
That's a great question. So, you know, DCIS is not malignancy. DCIS2 has a broad spectrum. We use the Van Nuys criteria, a broad spectrum of pathology. If she's been on tamoxifen for prevention, I wait a minimum of 3 months, preferably 6 months. Tamoxifen actually has quite a long biological half-life on the ovaries. Okay? It can interfere with the cycling. The average woman is born with 400 eggs, and tamoxifen can actually cause quite a bit of challenge depending on their age. So I'm quite comfortable stopping a minimum of 3 months before they would start to try to get pregnant. But I think that's perfectly safe. And in fact, in the Journal of the National Cancer Institute, JNCI, just a couple of weeks ago, there was a fabulous review of this area. So it'd be worthwhile having a look at it.
Thank you, sir.
Can I ask you a question? Sorry to interrupt you. Your question is really that you want to know whether DCIS patient who had mastectomy and on tamoxifen. Do you routinely give tamoxifen after mastectomy for DCI patients here in this country?
Sir, if hormone receptor is positive, sir,
I mean,
strongly positive.
I'm talking about DCIS patients. DCIS patients, even if ER is positive or HER2 positive, I don't know whether there's any point other than risk reducing for the other side. We don't give any tamoxifen at all. There's no need. In the United Kingdom, I've never given anybody after DCIS surgery, when mastectomy has been done, completely removed, there's no indication unless you do only for risking of the other side. And that is also not very popular. In America, it was quite popular at one point, but it's actually going down. But is there any indication for that? Where did you learn it from?
Sir, basically, we want to follow the NCCN guidelines, sir, and it is the NCCN recommendation. So that's why the patient was given. But sir, if the scenario is different, that the patient was a case of carcinoma-based ductal cell carcinoma.
I'll ask Paul, what is your practice in Australia? Do you actually give? Or?
So that's right. So it depends on what type of DCIS. Was it low grade? Was there
intermediate or high grade?
How extensive it was, but more importantly, what age?
Yeah.
Is there a family history? I mean, you would treat a 35 to 50-year-old differently from a 50 to 55-year-old. And so you need to put the factors in. But we all know in this room that we are not using enough preventive endocrine therapy for patients who are at risk, where we still do not understand what's going on. And maybe in the future, polygenic risk scores will help identify those patients. But for now, it is very much an art form.
Thank you very much.
Thank you. So it is the end of the question answer session. Now it's time for the comments from the panel of experts for today's session. I would like to request Professor Major General Dr. Muhammad Azizul Islam Sir to put your comment on this topic.
Bismillahirrahmanirrahim. Respected chairperson of this session and the organizer of the conference, and my dear colleagues from home and abroad. Assalamu alaikum. Actually, Dr. Paul, today's speaker, he has presented nicely regarding the management of the hormone positive breast cancers. I appreciate Dr. Paul for his valuable lectures and very rich lecture. Moreover, I express gratefulness to Dr. Paul. He is working to develop the molecular lab facilities in our country. He has visited Combined Military Hospital several times. So on behalf of all the audience and all the oncologists, all peoples of Bangladesh, I convey my thanks to Dr. Paul. However, Dr. Paul has educated us by enlightening his knowledge and experiences, particularly in the hormone-positive breast cancer, by using the hormones SCRD, AI, SCRM, and his experience will make all of us highly knowledgeable. But what we have learned that in Australia and in other European countries, there are a lot of drugs and the agents which are used as a targeted management of the breast cancer. But in our country, we are still lagging behind in producing the drugs. But we must try, we must advise our stakeholders and the authorities so that newer drugs can be made available in our country for the better prognosis of the patients. Thank you very much.
Sir, thank you. Now I would like to request Brigadier General Dr. Mohammad Kudroti Elahi sir to put your comments on the topic.
Bismillahirrahmanirrahim. Today's chairperson, organizer, and today's speaker, my colleagues, Assalamu alaikum, good morning. In the management of hormone receptor positive breast cancer, CDK4/6 inhibitor, it is new frigate in the cancer on world, so that we can use these drugs for in different settings. This CDK4/6 inhibitor, all of we know that it is used in especially metastatic setting, palbociclib, abemaciclib, and ribociclib. All these drugs are available in our country, including original molecule. But the one thing is very special for our medical oncologist, that is the side effects. Palbociclib we have used a few patients, main issue with the diarrhea and neutropenia. This is the troubleshooting for us. Again, one thing we may forget for ribociclib, that is prolonged QT interval. In our ward and for our patients, we must check cardiac status and regular checkup of ECG so that we can address its early stage, because if we do not address QTC interval prolongation early stage, patient will die cardiac arrest following torsade de Pontis and VT. So we are going for treating a patient, but a medical emergency may happen. Regarding this drug, all of you know that it is especially for metastatic setting, but nowadays it has been recommended for adjuvant setting. That is with aromatase inhibitor plus abemaciclib for those patients who have lymph node positive, especially lymph node 4 or lymph node 1 to 3 with grade 3 staging, and size is more than 5 centimeter, and Ki67 more than 20%. So this is a new information for us. After this medicine, what we will do? Another horizon is that for those patients, low positive, HER2 positive, low normal HER2 positive, we can use trastuzumab deruxtecan in case of hormone receptor positive breast cancer in metastatic setting. Also, we can use sacituzumab govitecan for these patients, those who are HER2 positive, hormone receptor positive patients. And if some patients, those who are BRCA1 and 2 positive, we can use also olaparib, that is PARP2 inhibitor. So all these are new information for us, and we can use in our country almost all the drugs other than very recent one. Thank you very much, dear speaker, for enlightening us. Thank you very much.
Sir, thank you. We are running short of our time. Now I am requesting Dr. Firdaus Sharia Said, Senior Consultant and Coordinator. Please put your comments on the topic.
Good morning. Dr. Paul, it was an excellent presentation, and I thoroughly enjoyed your presentation. And a lot of things we learned, I'm sure. One is, molecular level, you talked about biology and all those things. And then there are so many molecules that we were not that much aware of. You covered them nicely for us. We're very grateful for that. And thing is that I'm just going to cover the practical aspect. We now know that, side effects, comorbidity, all these things, when we have to choose a particular drug. The drug may be the first choice, but may not be the first choice for that particular patient in front of me. So these are the things that we practically face when we treat the patients. And apart from that thing, we have to remember that one thing we don't have in this country, we don't have NGS facility. So that is the thing that I found out, that it's very important, that we have to know that which particular drug is suitable or is useful for this particular patient. And there are so many molecules are there, and we have to find out this, all this molecular status. So in your scenario, you are from a very advanced country, and you may have these facilities maybe covered by the government, so that, patient's burden, financial burden is not much, I'm sure. But here, everything comes out of the pocket of the patient. And these are very expensive. One thing is that NGS facility is not yet available in Bangladesh. Second thing is that, you have to send this to some other country, and these are expensive. Not all the patient can afford. So we have to improvise sometimes. We have to just, use our wit to choose the next option of treatment. So this is the thing that we are facing here, practically in Bangladesh, when we treat our patient. So I don't know how to overcome this thing, and we are quite judicious when we change from one molecule to another molecule when the tumor progresses. But we cannot actually pinpoint the treatment that that particular patient requires. But from your presentation, it's very clear for all of us that you have tools to know that, yeah, this patient will be requiring this particular drug at this point. And that's the thing that, I'd just like to mention, that, we have to improvise sometimes. So, often we have to improvise due to the lack of that thing, and due to the unavailability, and due to the expense of NGS. Thank you.
So thank you. Now I request Professor Dr. Parveen Shahida Madam, the chairman of the session, to put the comment and end the session.
Thank you. The president of Bangladesh Society of Breast Cancer Study Group, and today's presenter, Professor Dr. Paul Manwaring, panel of expert, moderator, distinguished guest, and delegate from home and abroad. Assalamu alaikum. I'd like to give my thanks to Professor Kamruzzaman Choudhury and the organizer of Bangladesh Society of Breast Cancer Study Group for arranging this such important conference. And I'd like to give my gratitude to them to select me as president of the chairperson of this session, of the important session, Hormone Positive Advanced Breast Cancer. The breast cancer, advanced breast cancer is the most common presentation in Bangladesh. It comprises of more than 50% of the patient. And today's presentation is management of advanced hormone positive advanced breast cancer. And usually in postmenopausal lady, the hormone positive cases, the hormone therapy, endocrine therapy is the most important driver in these cases. And today's presenter, Professor Paul Manwaring, successfully and very beautifully give the presentation and showing the different pathway of sensitivity of hormone and the different studies. So we get much more information, and really and definitely we are enlightened from his presentation. And our panel of experts give their experience, so this is much more information, and we get benefited from their lecture. And present moderator, Dr. Shafa Jahan, nicely conduct the session. Thank you very much for your cooperation. Thank you.
Madam, thank you. Now, I request Dr. Latifa Apo to start the crest giving session, please.
Thank you. Thank you, everyone. Now we're going to start our crest giving ceremony. We have Professor Dr. Sanoor Hossain, legendary professor and the patron of Bangladesh Society for Breast Cancer Study, among with us. I would kindly request Professor Sanoor Hossain, sir, to come to the dais and hand over the crest to our respected speaker, Professor Dr. Paul Manwaring. Also, I request Professor Sanoor Hossain, sir, to hand over the crest to our chairman of this session, Professor Dr. Parveen Shahida Akhtar. I also request Professor Sanoor Hossain, sir, to hand over the crest to our chairman of this session, Professor Dr. Parveen Shahida Akhtar. Thank you, sir. Now, I would request Professor Hafizur Rahman Ansari, ex-director, National Institute of Cancer Research and Hospital, to come to the dais and hand over the crest to our panelist. Now, Professor Hafizur Rahman Ansari, sir, to hand over the crest to our first panelist, Professor Major General Dr. Muhammad Azizul Islam. I also request Professor Hafizur Rahman, sir, to hand over the crest to our next panelist, Brigadier General Dr. Muhammad Kudrati Ilahi. Now, Professor Hafizur Rahman Ansari, sir, will hand over the crest to Dr. Firdaus Shahriar Said. I humbly request Professor Hafizur Rahman Ansari, sir, to hand over the crest to our moderator of this session, Dr. Shafatul Jahan. Thank you, everyone. Thank you for hearing. Now we'll go for a short tea break. We'll start our next session sharp on 10:20.
Professor Dr. Don S. Dijon on management of triple negative breast cancer. Professor Dr. Don S. Dijon is Professor of Medicine and Surgery at Brown University and also in Lifespan Cancer Institute and Legoret Cancer Center, USA. I am requesting Dr. Professor Don S. Dijon to come to dais. Now I am requesting Professor Dr. Manjur Kadir sir, Head of Radiation Oncology, Delta Medical College, to come to dais as panel of experts. Sir. And also Professor Dr. Anwar Hussain sir, Professor of Surgery, to come to dais as panel of experts. Thank you, sir. Now we are going to our first presentation on management of triple negative breast cancer. Thank you.
Thank you very much. I feel like I know many of you in the room. It's been a pleasure getting to know the cancer community in Bangladesh over the last, I think, 5 or 6 years. And I really want to give thanks to my colleague, Dr. Das, for the invitation and for introducing me to your society. I was asked to talk about the management of triple negative breast cancer. You're going to see several themes that will be expanded upon by other people during the day. The overview I will give you will focus on the genetics and the epidemiology of triple negative breast cancer, which was mentioned by Dr. Mainwaring. We'll talk about the initial diagnosis and the treatment medically of triple negative breast cancer, particularly the role of neoadjuvant chemotherapy, and then following surgery, how to manage our patients who have residual breast cancer. And then I'll quickly go to the treatment of metastatic breast cancer, focusing on these 3 areas. So in terms of definitions, these are tumors that are ER, PR, and HER2 neu negative. What constitutes HER2 neu negative, as Dr. Mainwaring mentioned before, is a moving target. In many of our studies, ER expression of less than 1% constitutes an ER negative tumor. PR positive, ER negative tumors are oftentimes also considered as a hormone receptor negative tumor, and in more contemporary studies, ER expression of less than 10% may qualify as triple negative. We have a study ongoing at the Dana-Farber where the criteria for triple negative uses that 10% line. It accounts for about 15% of all breast cancers. It's mainly a disease that happens in younger versus older women, and women with breast cancer under 40 are 2 times as likely to have a triple negative breast cancer compared to older patients. And as was mentioned earlier, 1 in 5 women with a BRCA mutation will be diagnosed with breast cancer as triple negative. The global prevalence is here. It's 2 times more common in Black women in America. But also, if you look at outside of America, West African and Ghanaian women compared to other women of African descent have a much higher prevalence of this disease, up to 50% for women from Ghana. There's limited data here in Bangladesh, but at least one study I saw is actually alarming. It can be up to 1 in 5 women in Bangladesh have triple negative disease. We're also learning more about the genomics of triple negative breast cancer and now realize it is not a single entity. There's basal-like triple negative disease and there's non-basal-like disease as well. Lehman and his colleagues have gone in to try to differentiate the different types of triple negative breast cancer. This is their more recent paper, which distills it from 6 subtypes to these 4, and shows that there may be a prognostic stratification, meaning basal-like 1 breast cancers not only seem to have the best prognosis in red, but are also more likely to respond to neoadjuvant chemotherapy. Basal-like 2 breast cancers, on the other hand, have the worst prognosis, as noted in the blue line in overall survival. And then there's mesenchymal as well as luminal androgen receptor breast cancers. Luminal ones tend to be lobular in histology. So in terms of seeing someone with triple negative breast cancer, the first thing that comes up for many medical oncologists is this a person that should receive chemotherapy rather than surgery? So I thought it's worthwhile to point out 3 things, which again, I believe there is a talk later on surgery after neoadjuvant chemotherapy. We'll expand on this. Neoadjuvant chemotherapy affords the same survival advantages as surgery followed by adjuvant treatment. There is no detriment that you are not harming patients from doing neoadjuvant chemotherapy first. This was best shown in a trial called B18 in the United States. Among people who are looking at a mastectomy, neoadjuvant chemotherapy affords the option of less surgery. And in a meta-analysis published in 2007, it's almost up to 20% a reduction in modified radical mastectomy with no difference in local regional recurrence. And then among people who have node-positive disease clinically, there is growing evidence, and I'd be interested to hear what our surgical colleagues feel about this, there is growing evidence that these folks who clear the axilla clinically may not need an axillary node dissection. However, this is a caveat in that second bullet from Sloan Kettering's experience. If you have isolated tumor cells after sentinel node or microscopic nodal disease, that should be N1 MIC, there is a high incidence of positive nodes in whom the standard of care is still axillary node dissection. So really, what did I not say about neoadjuvant chemotherapy for triple-negative breast cancer? I did not say everyone should get it. All right. So how do we approach neoadjuvant chemotherapy in my center in the United States? It changed because of Keynote 522. This is pembrolizumab with neoadjuvant chemotherapy. The volunteers on the study had stage 2 or stage 3 triple-negative breast cancer. The intervention was a significant lift. It was pembro with carboplatin and paclitaxel for 4 cycles, followed by pembrolizumab and dose-dense AC for 4 cycles, followed by maintenance pembrolizumab for 9 cycles. This is a lot of treatment. It is a kitchen sink approach to triple-negative breast cancer. The comparator was carboplatin Taxol followed by AC, maintenance placebo to maintain the blind. And compared to the placebo arm, there was a higher PCR rate with pembrolizumab, which was significant. We lowered the rate of progression at 15 months, also significant. You'll note by the 95% confidence interval, which does not cross 1.0. But it was also at the cost of significant toxicities, although I will show you here. In the arm that did not get pembrolizumab, 3 out of 4 people still experienced severe toxicity. So carboplatin-based therapy followed by AC is a very toxic regimen. So instead of showing NCCN guidelines, which I think most of us are aware of, there is a process in the United States afoot to do pathway-based care. So pathways is where a group of us, just like in this room, we get together and we decide, what did the studies show us as benefits? What did the studies show us as toxicities? And where they seem to be equal, which one makes the most sense fiscally to avoid financial toxicity for our patients? So this is our pathway. It's called VIA. And it's for triple-negative breast cancer. We look at size and we look at nodes. Node negative and over 2 centimeters, or node positive and a small tumor, we are recommending Keynote 522. If that patient, for whatever reason, maybe it's lung disease, maybe it's a very severe diabetes, maybe it's pre-existing adrenal disease, it's not a candidate for pembrolizumab, we're doing the control arm of Keynote 522. We're giving platinum, we're giving AC. And if where patients are not a candidate for carboplatin, maybe it's due to frailty, we're giving AC dose dense, followed by 12 weeks of paclitaxel. So this begs a question of why use platinum at all in triple-negative breast cancer. And this was the Prospero meta-analysis, which was just published in Breast. And it looked at the 8 trials that looked at the comparator of standard chemotherapy versus including carboplatin. There were 8 trials, over 2,400 people in those trials. And compared to the standards of care, if you use carboplatin, you improve disease-free survival. And if across the studies, the way we figure out whether the studies are some things we can trust, we look at something called heterogeneity. And the statistic for that is called I-squared. At 40%, it's moderate. You like to see it below 40%. So the I-squared here was at 41%. So the studies were sufficiently different that the conclusion may not be something that strong. At the trial level, so when you looked at the individual trials, there was also a survival advantage. So using carboplatin in triple-negative breast cancer improves overall survival. Now, when you looked at the studies, they were able to segregate the studies that looked at treatments every 2 weeks, which is dose-dense, versus the treatments every 3 weeks, which is standard. The dose-dense studies were very different from each other. The I-squared here was 71%. So that tells you that even though the survival advantage is seen, you can't really say it supports a dose dense to show that because the studies were so different from each other. And if you look at the individual, how did the individual patients do on these studies, there was still an overall survival advantage and there was an improvement in PCR. This is the data that we use to support using carboplatin in triple-negative breast. So let's say we give people chemotherapy and then they go to surgery. The next point where medical oncology is going to ask is what do we do for the folks who have residual disease after neoadjuvant chemotherapy? And I'm probably going to start a huge controversy by saying we don't know. So this is the 3 studies that ask the question of capecitabine for residual disease. Everybody points to CREATE-X. That is a Japanese trial, randomized trial, of nothing versus 9 cycles of capecitabine. And at 5 years, it's improving relapse-free survival, it's improving overall survival, and this will set the standard of care globally. The problem is, there was another randomized trial called Saboma. This was a European trial, very similar to CREATE-X, capecitabine versus observation. It did not confirm those benefits. So 5-year survival, disease-free overall was the same, but they were able to show if you're using IHC stains and can find that non-basal-like triple-negative breast cancer, there may be the benefit to capecitabine in that circumstance. That was exploratory. And then the 3rd study was done in the United States called ECOG Akron 1131. Again, triple-negative breast cancer, residual disease, a little bit more aggressive and a larger burden of disease than seen in CREATE-X. It was carboplatin was the investigational arm, and capecitabine, based on CREATE-X, was standard of care. You'll note there was no difference in disease-free survival, but you'll also note they did not see the same benefit to capecitabine as was shown in CREATE-X. So what does this tell us? It tells us that this is not, that the standard of care of capecitabine is not conclusive. It also tells me it matters who you enroll on your trials. There's sufficient data that people in Japan metabolize drugs differently than people of European descent. We're seeing that play out with capecitabine. I think it would be very important if this study of CREATE-X could be done in Southeast Asia as well as the Indian subcontinent to see where we fall into this. But at this time, the data establishing capecitabine is weak after neoadjuvant chemotherapy. We will suggest it. We'll say, we think about this. You could do it if you want, but it is not a very strong recommendation. Dr. Paul Waring also mentioned olaparib and the management of residual disease. This is the Olympia trial. It was an adjuvant trial of a PARP inhibitor, olaparib, or placebo in people with a BRCA mutation. It included people who received neoadjuvant chemotherapy and had residual disease. And for triple-negative breast cancer, it had to be at least 2 centimeters and or node positive. And at 3 years, olaparib improves disease-free survival. It improves distant disease-free survival. And among the group we're talking about with residual disease and triple-negative breast cancer, again, you're seeing that improvement in disease-free survival. So the availability of a PARP inhibitor is important, especially for people with BRCA mutations. And if you have such a patient, it should be recommended for residual disease after neoadjuvant chemotherapy. So this is our approach currently for residual disease per the pathway I mentioned, VIA. If there's residual disease and someone was treated with Keynote 522, you continue pembrolizumab. We do not add capecitabine. We do not switch to capecitabine. If pembrolizumab was not administered, we offer capecitabine. And if pembrolizumab was administered or the patient has a BRCA mutation, we give olaparib. So what about the approach to recurrent and metastatic triple-negative breast cancer? First, the question comes up in terms of the pathways. How do we give chemotherapy? It's not even should you give chemo, but chemotherapy is the only thing we have. So for a local regional recurrence, the question is based on what did you give before? Did she or he get anthracyclines? If not, we give dose-dense AC. If they did get an anthracycline previously, we go by the treatment-free interval from taxanes. And if it's greater than 6 months, we give taxane plus carboplatin. And if it's less than 6 months, we give capecitabine. The question that we all struggle with is for someone who has a local regional recurrence or in people who are presenting with stage 4 breast cancer, should we address the primary mass that has relapsed, or should we address that primary breast cancer? This is a study that was just published. It's from the Eastern Cooperative Group of the United States. It was led by Seema Khan, who's a surgeon. And she looked at how to approach women who have an intact primary breast cancer, stable disease on treatment for at least 4 months. The intervention was to stop the treatments and do local regional care versus just continuing systemic therapy. And at 3 years, there was no change in overall survival. There was no difference in the median overall survival, but there was an improvement in local regional progression. So this tells me it might be reasonable to do, but it is not a substitute to systemic therapy. When it comes to distant disease, our pathway tells us to get NGS, next generation sequencing. And if we find MSI, if we find mismatch repair, or if we find tumor mutational burden that is high, that patient is a candidate for checkpoint inhibitors. On the rare circumstance you get quote unquote lucky and you find an NTRK gene fusion protein, there is treatment for that as well. And then Dr. Waring mentioned about genomic sequencing for BRCA mutations as well. If we find one, we offer olaparib. Should Bangladesh invest in NGS in this way? These are the reported rates of those in triple-negative breast cancer. They're not common. This is the needle in the haystack. So next generation sequencing in breast cancer only makes sense if you have access to those targeted treatments. And I will suppose, and we can discuss, it only makes sense if your other priorities in treating your patients have been satisfied. But Keynote 355 established pembrolizumab as a treatment in metastatic breast cancer. This again was done before Keynote 522, which pushed up pembrolizumab into the neoadjuvant approach, but it tested triple-negative breast cancer previously treated to pembrolizumab with chemo versus chemotherapy alone. And this is how they stratified the results based on the combined positive score for PD-L1. They looked at it was 10 or higher, 1 or higher, and then the intention to treat. I think we will all agree on that left screen that CPS greater than or equal to 10 showed the best stratification of outcomes. And if you look at their subplots here, they also show that the best predictor was at CPS of 10. What else do we have to offer patients who have metastatic triple-negative breast cancer? In the United States, the FDA approval was obtained for sacituzumab govitecan. This is an antibody-drug conjugate. The target is trophoblast cell surface antigen 2, and it is linked to a very toxic chemotherapeutic, the active metabolite of irinotecan. In the ASCENT trial, it was tried in metastatic triple-negative breast cancer. One could have stable brain metastasis, and there was no line limit here. So the comparator was chemotherapy, either eribulin, vinorelbine, gemcitabine, or capecitabine, and the results were impressive. So sacituzumab shifted the progression-free and overall survival to the right. So you're seeing a pretty significant advantage. If you look at the medians here for progression-free survival, is a benefit for about 4 months median, but in median overall survival, the benefit was up to 6 or longer. In terms of the full population here that got sacituzumab, again, this was progression-free overall, and this is the overall population here, showing again about a 3-month advantage to sacituzumab over chemotherapy. So here's a summary of the efficacy results. The main bullets you should know about are in red. The progression-free survival was improved over in the population with brain metastases, as well as in the full population. It might be better in patients who had brain metastases in terms of that therapeutic benefit. The objective response rates were significantly higher, 80% responses versus 11% with standard chemotherapy. The clinical benefits favored sacituzumab in both groups, and the durations of response, you're hitting 6 months, where with chemotherapy you're about 3. So that is actually something that I do tell patients if I'm starting them on sacituzumab, that this, you can get 6 months or longer benefits with this drug. What were the adverse events? Hematologic, gastrointestinal, fatigue, as well as unlisted nervous system disorders. So again, there is a cost to even antibody drug conjugates. This drug is dapotamab deruxtecan. It uses that TROP2 as the antibody and is currently in testing in tropion. Now, the results in triple-negative breast cancer were presented by Ian Kropp at San Antonio in 21. Among 44 people with triple-negative breast cancer, the overall response rate was 30%. Common side effects were nausea, mucositis, fatigue. You're going to hear much more about this. Dr. Mainwaring mentioned HER2 low, but it is a new way to think about metastatic breast cancer based on Destiny Breast 04. I'm going to go through this very quickly because I think it will be covered later. HER2 low, as discussed, is what we used to consider HER2 negative. So it's IHC 1 plus, IHC 2 plus, in situ hybridization negative. The problem was also mentioned earlier, our colleagues in pathology don't have a standard way of calling something 1 plus or 2 plus. This is TDXD. It uses HER2 as well as a topoisomerase 1 inhibitor payload with a bystander effect, which is mentioned here on the graphic. So T-DXd binds HER2, internalizes it, releases the topoisomerase 1, kills a tumor, and then that payload can go to adjacent tumor cells and kill them too. Destiny Breast 04 looked at people with HER2 low disease. I'm going to focus in red on the 10% of that population who had triple negative breast cancer. For all patients, it was an advantage for about 5 months compared to standard chemotherapy. But if you look at the results in ER negative disease, it was impressive. Again, 10% of this group had triple negative breast cancer. Progression-free survival went from 5.6 to 8.5 months. Overall survival was almost at 10 months. If you compare the response rates to what we saw in hormone receptor positive disease, it's actually quite similar. So the response rate, about half of your folks with HER2 low triple negative breast cancer responded to this drug. In terms of the treatment adverse events, I would just point you here. This does cause pneumonitis. It was seen earlier in the clinical trials. And in the studies, we were doing either chest x-rays or CAT scans at very frequent intervals to check for pneumonitis. And at the sign of pneumonitis, radiologically, the drug was recommended to be stopped. So here you're seeing that grade 1, which is really radiologic CT evidence of pneumonitis, happened about 3.5%. But the overall incidence was over 10%, so 1 in 10. And I think in the United States, there is some reluctance on treating people with T-DXd because of the risk of pneumonitis, which can be potentially quite serious. Grade 5, by the way, right, means that people were hospitalized and died of this disease, this complication. Having said that, Destiny 4 sets a new definition in breast oncology and breaks down HER2 for us. And the question is, do you even need to test HER2 now? But I think you do. HER2 low is predictive of this new class of drugs. It does change the standard of care beyond hormone receptor and HER2 stratification. The challenge for all of us will be pathology. I have been serially biopsying people who are called HER2 0 to try to get them reclassified as HER2 1. That has proven very difficult. The words of advice I got recently is that if you're trying to find this, try to biopsy a node versus the liver. That may be more productive. But again, the testing only makes sense if the drug is available. And I think kudos to your community and your country for having drug development here that is able to provide these very expensive drugs. And then finally, just reminding all of us that the biology does drive the treatments. My slides just went out. My slides just went out on the screen. So biology does drive treatments, and just remember that triple-negative breast cancer is not just one disease. 1 in 5 people, though, will harbor a BRCA mutation, and this does, I think we need to work towards having this, we have to work towards getting our countries to cover genetic testing, which is an important initiative of the Global Cancer Institute that we're hoping to launch with Bangladesh. The therapy in the US and Europe requires the use of somatic testing, and that immunotherapy plays a very big role in how we treat triple-negative disease. And then global access, obviously, is essential so we can achieve equity for everyone with breast cancer. With that, I will close. Thank you so much for having me.
Thank you so much, Professor Dr. Don S. Dijon, for your excellent presentation. Now, moving on to our next speaker, Professor Dr. Alphonse Taghian, who will present on lymphedema after the treatment of breast cancer, overview and new approach to an old problem. Professor Dr. Alphonse Taghian is Professor of Radiation Oncology at Harvard Medical School.
Thank you very much for the organizers, Dr. Das, Dr. Chaudhry, for inviting me to give this talk. All right, so all of us in this room, we know what lymphedema is, but what we don't know is what lymphedema means for patients. So this is something I started to look at, and I asked patients, actually many patients, about how lymphedema impacts their lives. And I put here some quotes. The one which really surprised me the most, I feel lymphedema more than recurrence. And not only one patient told me that, it's many patients. Another one, it has ruined my life. I would almost rather I had died. Now you have a patient who survived breast cancer and would tell you, I would rather have a local recurrence or the cancer coming back rather than having lymphedema. This is how important lymphedema is for the patient. The other thing is that it doesn't affect only the patient, it affects also the whole family. It strangles the mobility and quality of life from my wife and therefore from me. So lymphedema is a crisis of quality of life. Why is that? Because it is obvious to the public. I mean, you can have a lot of complication from chemotherapy, from radiation, from surgery. Everything is hidden. Neuropathy is hidden. Alopecia is hidden. But when you have an arm like that, it is not hidden. It's a constant reminder of the patient that she had breast cancer. And when you look at every impact here, is like documented with data. This is not just like putting a list. Sadness, anger, depression, and anxiety. So basically, your life is upside down. And those patients live for a long time when they are cured from their breast cancer. So why is that? Because for many decades, when we dealt with lymphedema, we used impairment-based model, which means that, let me see the problem. You have a swollen arm, okay, go to see the physical therapy and goodbye, and that's the end of it. And it's always really advanced like that. And we don't take really charge of these complications. What I would like to see, and we started to practice in my institution and few other institutions in the US, we'd like to see a screening-based model, which means that we screen for lymphedema and we catch it very early. We catch it before we see it. And when you look at mammograms, when mammograms detect DCIS before you feel it, before you see it, you have a very high cure rate. The same thing happened here. If we only rely on seeing the arm swollen, it's already maybe 15% relative volume change. But if we can detect lymphedema before we see it, but with some tools, and then we intervene at that time, there is a hope that this can be cured with treatment. Once the lymphedema reaches that level, there is no cure, and we need to know that. And in general, we see 20%, maybe 30% of patients who present with lymphedema. This has been high many decades ago, but with the introduction of sentinel node, it went down. But of course, it depends on where you live and where you work. In developing countries, I would think it will be much higher than that. So it's really rely on what type of surgery is being done. Let's go down to the basics. What is the optimal technique to measure lymphedema? So mostly it's volumetric. The most simple one is a tape, and that's the cheapest one. And anywhere you could do that. You don't need to take the circumferences at 4 centimeters. It takes longer time to do it. It could be more simple, and you could take circumference at only 5 points, and then you transform all these circumferences into volume by using the truncated cones formula, which can be found online without any problem. So that's the most simple thing. Whether you do 5 points or 15 points, there is no difference. You are as good with 5 points, so this can be done rather quickly. So that's with the tape. There are tools like Pyrometer. It uses an infrared, and it brings really very accurate volume. It shows up on your screen, and it can calculate it. And there is something new. It's called Lymphotech. It's a camera which can really look or calculate the volume of your arm quickly. This water displacement has been used in the past. It's just very unhygienic, and you cannot screen with it. And there is a new technology that the bioimpedance coming mostly from Australia, and it reflects the ability of an electrical current to pass through the limb. We are still testing that. Some people use it to diagnose lymphedema. We are not. So this is a different method to calculate to measure lymphedema. Now the very important question, is it necessary to have a baseline measurement? It is very necessary to have a baseline measurement. Baseline means before surgery, and that's why you cannot build a lymphedema screening without the surgeon. If the surgeon is not into it and you miss the baseline, you cannot screen. I will tell you why. Because we looked at 1,000 patients, and we had 35,000 volume measurements, and we found there is an asymmetry between right and left, just without any surgery, of up till 10% increase in volume in 3% of the patient. Now, the definition of lymphedema is 10% relative volume increase. If you miss this information, you will overdiagnose or underdiagnose a lot of patients. So a patient would not have lymphedema, and if you don't have this information, you measure after surgery, you found that one arm is larger than the other, you will label her as having lymphedema and will never respond to any treatment because she does not have lymphedema. It is very important to have a baseline. And then more than 5% we found in 28% of the patients. Now after that, I asked my team, if you miss the baseline, what will happen? Like, what is the level of uncertainty? And I was surprised to see the answer. So in this study, we took 1,000 patients who had all of them baseline. And we had also a post-operative measurements. We called it immediate pseudo-baseline and beyond 3 months, assuming that after surgery you have some swelling due to surgery. And we called it also delayed pseudo a baseline. And we found if you don't have the real baseline, you will overdiagnose or underdiagnose 40 to 60% of the patients. So if you miss the baseline, you cannot really measure the patient after surgery. You will misdiagnose her. So that's how important the baseline is. It's not only our group who found this. There is a British group, very respected group, who studied 1,100 patients. At baseline, they found 8% of the patients, they had one arm larger than the other by more than 200 milliliter. A lot of people consider the definition of lymphedema as 200 milliliter difference. It's also at baseline, the same group, they found that symptoms of swelling and heaviness were found in 8% of the patients. A lot of people diagnose lymphedema by the symptoms, and specifically the symptoms of swelling and heaviness. If you don't have a baseline to know that the patient didn't have it, you will misdiagnose lymphedema. Our field of lymphedema has a lot of misdiagnoses, and this is very important. How do we quantify lymphedema? So we generated an equation, a relative volume change, which is basically based on the baseline measurements. A is affected arm, U is unaffected arm, 1 is the baseline. And this is online and has been validated, and several institutions are using it beside ours. So this is simple. You take the baseline volumes and the volume of the day in your follow-up, and then you plug them in this relative volume change formula, and you get the percentage increase in volume. How do we define lymphedema? And this is a big problem in this field. If you look at all the literature, you will find many, many definitions. So there is no universal standard definition. This means like you have 20 people sitting in the same room trying to talk together about one issue, and everyone is speaking different language. So you have the absolute, three, absolute circumference, absolute volume, absolute difference, percentage, and I will tell you where using absolute is flatly wrong. We use the relative volume change more than 10%. That's mostly the universal agreement in a way to define lymphedema, and there is LD score, which comes from the bioimpedance. Simona Settlement did a meta-analysis and selected the best studies in the literature. All of them were prospective. Half of them were randomized clinical trials, and started to look at them. Almost 15,000 patients. What she found is that the method of measurements was completely different from one to the other. Subjective, arm circumference, not reported even, arm volume. So each one has a different endpoint. I mean, it's lymphedema. If we want to have an endpoint of lymphedema, everybody is measuring it differently, and these are not interchangeable. And the other thing, the lymphedema definition, not reported, self-reported, MD assessment, more than 2 centimeter tape circumference. I think the next step in the field of lymphedema, let's just sit down together and define lymphedema with something which could be acceptable. Why 2 centimeter difference or 200 ml difference is not right? And we have been using the 2 centimeter circumference difference for decades. And I remember when I was resident, I used to have the tape and measure. And I didn't know what does this mean. But until now, this is being used. If you take a 200 ml difference, you take a small arm like that, and this arm had an increase in volume by 180. 180 is not lymphedema, because lymphedema, you have to cross the 200 ml. But with 180, you have 15% increase in volume. So you underdiagnose this patient. You take the opposite, this large arm, 220 ml is lymphedema. What this represents 3.7% relative increase in volume. This is not diagnosed as lymphedema. So you will overdiagnose this patient here. And when you plot this, if you have just an absolute difference, it will represent 15% in some arms and 3% in other arms. So absolute volume change correlates with the arm volume, the patient weight, the body mass index. But what you need is an endpoint which is completely independent from how the patient looks or how the original arm volume is. And that's why using 2 centimeter circumference is wrong and should not be used. So what we are trying to do is a prospective screening program in order to identify patients at a very early stage with lymphedema, before you see it with your own eyes. 7%, not yet lymphedema, but it's close, and you can't see anything. 11%, you could see just a little, but likely curable with conservative treatment, and once it reaches that level or more, that's it. It's going to be just maintenance and palliative. In order to establish an lymphedema screening program, you need to build a team. You cannot do it on your own. You could be a surgeon, you could be a radiation oncologist, a medical oncologist. You could be anything, but you need everybody together. Surgeons are extremely important. And then we usually collect patients' reported outcome, like surveys from the patient. And if you look at the cost, and forget about the absolute numbers here, but in general, and this is just one paper, that when you screen, the cost is much less than when you have a patient with already lymphedema coming back and forth with cellulitis, admission. This will, over time, over the years, will increase the cost. And the important thing is that screening for lymphedema is recommended as a standard of treatment by 5 different organizations. The NCCN organization is very important in recommending the standard of treatment, also the American Society for Breast Surgery. So let me summarize. if you want to plan for a lymphedema screening program, you want to start early, you have to use volumetric method. You need a baseline measurement. You could use the relative volume change formula. The definition of lymphedema is relative volume change more than 10%, and you could integrate symptoms from the survey. So that's the basics for lymphedema. Now, what are the risk factors for lymphedema? And I identified 6. We're going to take one by one. The most important risk factor for lymphedema is very simply axillary lymph node dissection. And you could see here in a study from our group on 1,800 patients followed with baseline relative volume change is used, and we define it as more than 10%. That's the routine in my group. The risk of lymphedema with lymph node dissection was 25% at 5 years. With the sentinel node is actually 8% or 5 to 8%. So you do sentinel node, you bring your risk of lymphedema very much down. You continue to do lymph node dissection, your risk of lymphedema is clearly much higher. And there are also other groups which goes in the same direction. What about radiation? And radiation has this perception radiation can cause lymphedema. So let's look at that. First, there is a difference between just radiation and actually regional lymph node radiation. So this is a study on 1,500 patients from our groups with the same screening program. And what we found is that if you treat only the breast or the chest wall, it's close to no radiation at all. And actually, radiation of the breast does not impact the risk of lymphedema. The only radiation which impacts the risk is basically regional lymph node radiation, either supraclav or axilla or both. And that's the risk. It goes down, look how far compared to no radiation. So very important to know that it's a regional lymph node radiation which increases the risk of lymphedema. And this is the multivariate analysis. Now, the other thing which I really want to underline, what is the contribution of radiation compared to the contribution of lymph node dissection to the risk of lymphedema? So when we compared in the same previous study, the risk of lymphedema with lymph node dissection alone without radiation versus the risk of lymph node dissection plus regional lymph node radiation, there was an increased risk, but the increase was only 5%. So we went up from 25 to 30%. So the contribution from radiation is actually very little. It's not as big as we thought from the old publication. And when you look at the risk from the sentinel node, it goes up from 8% into, when you add regional lymph node radiation, into 11%. The risk is small. So what we learned from here, that the contribution of radiation to the risk of lymphedema is little. So if you want to reduce your risk of lymphedema, I don't think that manipulating the fractionation of radiation will bring any benefit. It's mostly the strategy should go towards surgery. And something very important, a question we raised, when does lymphedema happen? So we looked at 2,000 patients followed with prospective measurements. When you look at lymph node dissection, the risk is rather early. It's within 6 to 12 months. And then when you add radiation on top of the lymph node dissection, the risk peak at 18 to 24 months. So the patient's still at risk on at least 3 years. So if you have a trial that you want to follow patients with an endpoint of lymphedema, following the patient for only 1 year will make no sense, because lymphedema can happen after 3 years or after 4 years. And then it goes down at 5 years. But something very important to know, that lymphedema risk is for life, and you need to know that. But what I see, the risk from the original treatment maybe end at 5 years. After that, the lymphedema, when it happened, there is something which triggers it. Cellulitis can trigger lymphedema after 10 years or 15 years. I have seen that. Trauma or an operation, or the arm is broken and then you do an operation, or I remember a patient who had leak from her implant, just removing the implant triggered lymphedema after 15 years. So you've got to be careful with the patient and informing them about those risks. So in conclusion here, the regional lymph node radiation increases the risk of lymphedema, but the main contribution remains with axillary surgery. Therefore, omission of lymph node dissection, if possible, should be the key prevention strategy. Now, what about the third factor, BMI and weight fluctuation? It is very universally known that high BMI is a risk for lymphedema. And this is something that when you look at every paper, it's there. So we have to be careful. And the BMI could be more than 30. Between 25 and 30 is not real, but it's more than 30. And this is the multivariate analysis. And it's only the BMI at diagnosis. Because when we've done a study, we followed the BMI for 5 years. And just with a common sense, we said if the patient goes on a diet and reduces her weight, maybe the risk of lymphedema will go down. And to our surprise and disappointment, it did not happen. It's actually whether you gain weight or you lose weight after diagnosis, your risk of lymphedema will stay the same. And we are not the only one who found this conclusion. What about chemotherapy? Does chemotherapy increase the risk of lymphedema? Well, it's not really clear. So you will have studies which found association between chemotherapy and lymphedema, and those are the references, and you have other studies which did not find any association. So we really don't know. But Taxol has this sort of perception, or the taxanes, because water retention, and some studies will tell you Taxol increase the risk of lymphedema. Us, in our database, we analyzed 2,000 patients, and we did not find that Taxol increased the risk of lymphedema. What about cellulitis and seroma? Cellulitis and seroma increase the risk of lymphedema. And this is a study. We followed 632 patients. The multivariate analysis showed that lymph node dissection and BMI increase the risk of lymphedema, and we saw also cellulitis. And you have to be careful. Cellulitis is really bad, and you have to attack it right away very aggressively, because I have seen just the arm really increase in volume rather quickly when you have cellulitis. What about subclinical lymphedema? What is subclinical lymphedema? It's basically not really lymphedema, but not normal. So it's a small swelling. And we define this swelling as 5 to 10%. So if lymphedema is 10% or more, the patient can have mild swelling between 5 and less than 10%. So we wanted to know, if we catch this little swelling, can we prevent it from progressing? So we looked at a study with 1,700 patients. And we found that women who had lymph node dissection, 40% of them moved into subclinical swelling. So we continued to watch those patients, and we found that some of these subclinical swelling regressed and others progressed. 40% of them progressed into full-blown lymphedema. And we are trying to study if we intervene with just sleeve for a month or two, at this point, can we prevent the progression of this? So the whole philosophy is, don't wait until you see it, detect it as early as possible, and try to intervene at that time. So here, I would say that patients who experience subclinical lymphedema after axillary surgery are more likely to progress to lymphedema, but mostly the patients with lymph node dissection and early intervention should be encouraged. So how do we avoid or decrease the risk of lymphedema? I think the best way is avoid lymph node dissection. I mean, you cannot do lymph node dissection for negative lymph nodes. It's almost unethical now. And I would rather not do any surgery at all to the axilla than do lymph node dissection when the axilla is negative. Can we avoid doing lymph node dissection for positive lymph nodes? So we all know the Z11 and the Amaros showed very clearly that you don't need to do lymph node dissection if you have 1 or 2 positive lymph nodes. And you could substitute this lymph node dissection by lymph node radiation. We looked at this in our database on the 1,800 patients. If you do lymph node dissection plus regional radiation, your risk is 30%. If you do sentinel node plus regional lymph node radiation, is 10%. So by avoiding lymph node dissection, you reduce the risk from 30 to 10%. And your risk of axillary recurrence is the same. So if you do lymph node dissection or you put radiation there, you will have the same risk of axillary recurrence, which is very low. And this really mimics the data from the Amaros study. So how do we treat lymphedema? So there are a few different approaches. Prevention, conservative and surgical. There is conservative management and surgical management. So very quickly, prevention regarding the conservative approach to prevention. And this is a study which came from the Tata Hospital in India and was in collaboration with a group from Australia, published very recently. 300 patients, all of them had lymph node dissection, were randomized into compression. You just give compression sleeve right away after surgery versus control group, which received the usual care. And they defined lymphedema as a relative arm volume of more than 10%, but also they had a different definition using bioimpedance. They measured and followed their patient for 1 year. And they measured at 1 month, 6 months, and 1 year. And they found that, in fact, prevention sleeve reduced the risk of lymphedema from 25% to 14%. So this study was positive. And they found that the arm swelling developed later in the compression group. So my concern is that it just delayed and did not really prevent, because they had only 1 year of follow-up, and I showed you that lymphedema can show up almost after 3 years. So to look at this study, and I love this study because I'm trying to test this hypothesis in the US, not enough measurements after surgery. When lymphedema was diagnosed, was not confirmed with clinical examination. There is also lack of adherence data. What you need to know is that when you ask the patient, you need to put the sleeve for a month, 12 hours a day. How do you know that the patient does that? We have a lot of compliance issue with that. And the way how they did it, they told the patient, you need to put the sleeve all the way until 3 months beyond your last treatment, with the exception of hormonal therapy. So you will have some patients who did not receive, for instance, chemotherapy or radiation. The patient will have the sleeve for 3 months. And the patient who had chemotherapy and radiation, she will have the sleeve for maybe 10 months or 12 months. So the length of using the sleeve is very variable within the tested arm. The other thing which really, so besides the follow-up was too short, we found that the patients, 40% of the patients had negative lymph node dissection. So this is something is usually not done in many places. You don't do lymph node dissection for patients with negative lymph nodes. So that's the way how you could prevent developing lymphedema conservatively by using a sleeve. The other thing is there are some surgical maneuvering, a maneuver called axillary reverse mapping. So basically, when you do sentinel node, you inject the dye in the breast, and then it goes to the sentinel node. So here, they inject a dye in the upper inner arm, and then the dye will move into a sentinel node for the drainage of the lymph from the arm. And sometimes the crossover rate can vary from 0 to 28%. So it is the same lymph node which really drains the arm and drain the tumor. So what they do, they avoid removing this lymph node. Or if they have to remove it because it is the same sentinel node identified from the breast, they try to recanalize or redo different maneuvering to avoid removing or interrupting the flow. Evidence suggests that sparing non-crossover arm node can be safely implemented, and there is a randomized trial, and this is very important. It's not published yet. It's accrued, and it's going to be published in 1 year. The other surgery is called lymphatic venous anastomosis. So the patient undergo lymph node dissection, and then when this is done, the microvascular surgeon comes in and then start to look at where is the disruption through some imaging, and then they start to identify the lymphatics and try to connect it to a branch from the axillary vein. So they call this lympha. It's starting to gain some traction in the US. Many institutions, they do this to every patient with lymph node dissection. There is no randomized trial published yet. There is one coming from Memorial. It's still accruing. So we'll know at that time whether there is a benefit from it or not. There is some meta-analysis of a lot of retrospective studies suggest that the risk of lymphedema goes down from 30% to 10%, but it's not randomized yet. Now, how do you treat lymphedema conservatively? Through two phases, a reduction phase and a maintenance phase, and you have the manual lymphatic drainage and the compression 24 hours, and the same thing with exercise and skin care, which we all know. That's the standard thing, wrapping. See how painful it is, how every day the patient should do that. And this is regarding the compression option, which just you put the sleeve for X number of days. Now, what about surgical management? Can we treat lymphedema with surgery? Well, there are three different approaches. The first one is the lymphovenous bypass. All what you need to do, so you will look at the at your lymphatic system through a ICG, like some dyes, and then you will look at where it is disrupted, and then you just recanalize to a vein. And it's rerouting lymphatic drainage pathway. Well, it doesn't take too much time in the OR, and some people do that, but what you need to know, it is not curative by any means. And every paper will tell you that. What is important that most patients will report symptom improvement. All their symptoms will improve, but they will still need to continue with sleeves. And so that's the first one. The second one is basically vascular right lymph node transfer. And some people reported that when they took the lymph node from the inguinal area, some patients developed lymphedema in the lower limb. Lymphedema in the lower limb is very nasty. So they stopped doing that, and they take the lymph node mostly from the omentum. And there are a lot of experience coming from Iowa, 1,500 patients, and again, 98% experience subjective improvement. So those surgeries just improve the symptoms, but at the end, you still need to put the sleeve. The swelling doesn't go away. The last one is basically liposuction, and it's a very simple liposuction. This is the arm before, this is the arm after. In the great majority of people who do that, the arm look really very good. The swelling goes away, but the patient will still need to put sleeve because it is not a physiologic treatment. It's just almost cosmetic treatment. So in conclusion, how can we reduce the risk of breast cancer-related lymphedema? Screening program. Get it early. It doesn't take too much. Get the breast surgeon involved with you. And then you could really help patients to spare them the risk of lymphedema. Identify the high-risk patient. The highest risk patient will be a patient with lymph node dissection and high BMI and regional lymph node radiation. So if you have a patient with those three, you've got to really follow her very closely. And as soon as there is an increase in swelling, you just put the sleeve. So the treatment is not that difficult. It's just giving the patient sleeve. And needs counseling and close observation. Avoid lymph node dissection with 1 to 2 positive sentinel node. And I'm trying to study whether can we move up from 1 to 2 into 3 or more. Like really, we want one day that nobody should have lymph node dissection at all. It seems to be a little remote, but if we go step by step, we might reach that level, because the most important factor to increase the risk of lymphedema is the lymph node dissection. Use of prophylactic sleeve to prevent lymphedema needs more studies. I'm not sold with the paper from India, but we need other group to really find out whether it works or not. I would like to acknowledge my group who generated all these data, and thank you for your attention.
Thank you so much, Dr. Tagian, for his amazing presentation. Our next speaker is Professor Dr. Shalaka Joshi, who will be sharing the presentation on evaluation of breast cancer surgery, where we stand today. Professor Dr. Shalaka Joshi is professor and consultant surgeon at Tata Memorial Hospital. Now I am requesting her to present that.
Thank you for having me here. Thank you to the organizers. And we've heard 2-3 excellent talks regarding management of triple negative breast cancer, management of lymphedema, which is a major side effect of breast surgery. And I completely agree with the last speaker that this is a surgical problem, and radiation, if at all, may or may not be compounding the problem, but this is a surgical problem and should be prevented by surgery or by avoiding surgery. So I'm going to take you through the wide spectrum of breast cancer surgery that has evolved over the last 50 years. And my one disclaimer is that this is going to be a little bit from the developing country point of view that I come from. And as I understand, Bangladesh is rather more similar to us, or related to closer to us, the kind of tumors we see, the kind of stage and the kind of grade and the kind of lymph node positivity that we see in our country, and maybe you will relate to me a little better. So needless to say, it's the most common cancer among women in the world, second most common cause of cancer deaths in women, and in India also now we have surpassed cancer of the uterine cervix, which used to be the most common cancer in our country. Now cancer of the breast is the most common cancer among women, as well as among all people put together in our country. Since 2018, Globocan data got published. And the trend is an increasing incidence in the incidence of breast cancer. And as you can see from these registries across various metro cities in India, there is an increasing incidence, and it's an elephant in the room which we can't ignore anymore. We need to tackle it, diagnose it as early as possible, maybe screen the high-risk patients and catch it as early as we can, so that we can avoid extensive treatment, lymph node dissection, extensive chemotherapy, all that can be avoided. So nothing is complete without a quick look in the past, and we know that there was an era where Dr. William Halsted ruled, the Halsted surgery ruled the management of breast cancer surgically, where radical mastectomy was the norm, till we got into this little conservative approach introduced by Bernard Fisher when he called breast cancer a systemic disease, and then we introduced less radical surgeries over the period of time. Modified radical mastectomy was the surgery of choice. It involves removal of the whole breast, and it is still definitive mainstay of surgery in a lot of parts of the world, including where I come from, and I'm sure that's similarly the case in Bangladesh. And it's a one-step procedure for majority of patients who can't either afford or who can't either have access to radiation facilities. There are even today indications for mastectomy, which could be either tumor-related or patient-related. Tumor-related like multicentric tumors or locally advanced tumors, which 30% of our tumors are still locally advanced as compared to the SEER data, which is less than 5%. And there are issues, like I said, patient-related, socioeconomic issues, as well as irrational fears on the part of the patient who still want to or opt for a mastectomy despite of surgeons telling them that breast conservation is safe. This has happened through a number of randomized trials all across the world, where we have really long-term data available, nearly 25 years follow-up data, which tells us that conservative surgeries in breast cancer are indeed safe. So in the end of 19th century, we had two options. We had to just look at left mastectomy and axillary lymph node dissection. Probably surgeons just had to worry about whether it's left-sided or right-sided tumor so that they operate on the right side of the patient. Today, the aims have changed. The breast cancer surgery outcome is not just to look at improving survival and minimizing local recurrence, but also to optimizing cosmesis, which is quite important for the quality of life and rehabilitation of these patients. So breast conservation surgery is the most commonly done surgery at our center since maybe last 20, 30 years. It just involves removal of the tumor with an adequate margin and an axillary procedure. I'm not saying axillary dissection. For node-negative patients, our hospital does only lymph node sampling or sentinel node biopsy procedures. But for node-positive patients, we still go ahead with a complete axillary lymph node dissection. This has again come from multiple trials, not just the NSAP B06, but multiple trials across the world, which have shown that the survival is the same with breast conservation surgery, and the local recurrence rates can be optimized whenever whole breast radiation therapy is combined with breast conservation surgery. We also have a consensus on optimal margin, which is not a centimeter anymore, not 2 centimeters, not a few millimeters, but it's just no ink on the tumor on the pathology. Since ASCO gave this definition of negative margin, I think it's made all breast surgeons happier because we don't need fat fingers to get better outcomes. So again, multiple trials, as I mentioned earlier, saying that breast conservation surgery is safe, and we need to consider appropriate boost treatment whenever we are doing a breast conservation surgery, because that takes care of the local recurrence rate, although it may not have an effect on long-term survival across the randomized trials. So that established the crucial role of radiation therapy in breast conservation surgery, and of course the role that it has even after mastectomy in node-positive and larger patients. However, having said that, we still have a few contraindications to breast conservation surgery, like first trimester of pregnancy, multicentric disease on imaging, previous irradiation to chest wall where we cannot irradiate again, margin positivity after twice re-excision, and patients who are unable to receive post-operative radiation for various socioeconomic reasons. And relative contraindication where the plastic surgery has bailed us out is a breast to tumor size or a ratio which is unfavorable for conservation, and certain other collagen vascular disorders of the skin. So we now enter into the era of oncoplastic breast surgery, where we try and improve the cosmetic outcomes of breast surgery as much as possible. So the purpose of oncoplastic surgery is to prevent a deformity. Like the previous speaker also said, we need to prevent a lymphedema. So we need to prevent a deformity of the breast by properly planning your breast conservation surgery. And this, of course, will improve the patient's psychosocial rehabilitation, is restore a healthy body image, and likely have a better quality of life in these patients in the long term. So there are various classifications of oncoplastic surgery. I'm not going into the basic of all of them. I understand there are a few speakers who are also going to talk about it in the later half of the day. But essentially what the definition that I like is a kind of BCS that includes resection with partial mastectomy, ipsilateral reconstruction using either a principle of volume displacement or replacement, with possible contralateral symmetrization surgery whenever appropriate. I think this is the most complete definition of oncoplastic surgery. So we have really seen in this evolution a reverse spectrum of breast surgery going from radical mastectomy to conservative surgery and to plastic surgery to restore the breast's form to optimal. We know it's safe. We have data from various Western centers like the Krishna Klo, who is one of the pioneers of breast oncoplastic surgery, has published large data sets. Although retrospective, prospective, we are unlikely to have a randomized evidence in this setting. So we will have to do with what is available level 2, level 1 kind of evidence. And that says that it is safe. It also says multiple reviews have happened and multiple studies are put together and considered. And then also we have, I think, enough belief to say that oncoplastic breast surgery seems to be safe with respect to outcomes of cancer, long-term outcomes. So the goals for oncoplastic surgery for us are to maintain the breast shape, size, symmetry, contour, and nipple position to as much what it was earlier, or as much best as compared to the contralateral breast. Scars, no scars is really up to the surgeon, and no scar or a scarless surgery is really a myth. And the dark pigment in our skin does not allow us to have excellent scars, but we can try and do better in that aspect. The basics here are the points to note are the size of the breast, the ptosis or the degree of ptosis of the breast, tumor to breast ratio, the overall clinical tumor and nodal stage of the patient. If you have given chemotherapy, then good response assessment using mammography, contrast enhanced mammographies or MRI, whatever is the institutional practice, to understand where is the defect located, which quadrant of the breast, if there are any pre-existing asymmetries in the breast at all, and to assess the donor site. However, the focus of all this is shared decision making. You need to talk to the patient and understand what she wants from her surgery and make her understand. For a lot of patients in this part of the world, a mastectomy is a very acceptable solution to breast cancer surgery, and they are really not interested in getting complex plastic surgeries done, and we need to respect that sentiment of the patient if that's what they feel for it. However, we need to learn oncoplastic surgery because it's there to stay. Again, Silverstein was one of the founders of this approach to breast conservation surgery, and he says that every breast surgeon will have to learn it, know it, understand it, and try to implement it in their practice. We moved to this pyramid of oncoplastic surgery, which is from a standard breast conservation surgery. We are moving up to level 1 procedures, level 2 procedures, local flaps, perforator-based flaps, and more complex plastic surgery procedures like mammoplasties and mastopexy, etc. A few of the indication would be inner central lower quadrant tumor, somebody who has a poor breast to tumor ratio, is requiring a volume resection more than 20%, has large ptotic breast and has multifocal tumors, and of course still desires to want a breast conservation surgery. The choices are many, based mainly on size, ptosis, and quadrant, and I'm not getting into the details of this, but they essentially depend upon what is the available donor site and what is the surgeon comfortable doing. So surgeon preference, how I do it, what is my technique, and how I have, what are the institutional policies, they actually may make a difference in your choice of oncoplastic procedure. But as you know, as many surgeons, as many plastic surgeons, those many approaches and those many procedures. And really one needs to look at it from this point of view, what is best in my hands and what I can do best for that patient at my level. For me, the basics are very plastic surgical, basic flaps like rotation, transposition, and advancement of dermoglandular tissue. I divide the regions of the breast into 9 regions rather than calling it 4 quadrants, where central is a different region and upper central, upper inner, lower inner, inner central, etc. These are the areas I categorize them differently when I'm looking at how to plan surgery. So type 1 procedure is often enough for a majority of patients where the breast to tumor ratio is suitable and the tumor location allows for primary closure without puckering the skin, where all you need to really pay attention to is what is your incision going to be and how can you cause minimal nipple displacement. And for a small tumor, post-neoadjuvant chemotherapy placed like this, ERPR positive tumor, when you have a scar like that, which is almost unseen, the patients have a reasonably good cosmetic outcome. Incisions on the female breast are many described in the literature. Langer's line, Krasel's line are essentially very contradictory to each other, and they do not take care of the effect on the breast of age, gravity, and ptosis. So the preferred incisions with respect to degree of breast ptosis, and these should be individualized, and that's the only good way, only way to have a good scar is to avoid perpendicular tension on the scar line by various methods. So 3 years later, for a type 1 oncoplastic procedure, that's the kind of outcome that the patient has. A simple radial incision works well across many parts of the breast when you can see that the breast is adequately sized and is not going to have a big volume defect. Occasionally, you may require a nipple repositioning procedure to get your nipple symmetry right. This is another option, which is a Benelli's donut mastopexy, described very well in the literature, where you could take periareolar incisions and hide your scars. And these are meant for, again, any tumors located in any quadrants of the breast, you could use this for. For inner quadrant, it's always a problem for the surgeon because that's an area where there's the least amount of breast tissue, so you may need to give little more attention. Dermoglandular rotation flap is an often used technique in my hands and works well. I'm not really promising to hide the scar yet because our tumors are slightly larger. The median tumor size is 3.5 centimeters, and 60% of upfront operated early breast cancers are node positive on histopathology. So I would still go for tumors, incisions on the tumor and adequate margin. Another option is thoracoepigastric flap for lower inner and inner central quadrant tumors, which works well. in majority patients, and latissimus dorsi is an option that is available to every surgeon. It's an easy flap to do. It can be easily mastered and can be really a handy flap for any quadrant of the breast. For lower central quadrant, it's really a problem. You get a deformity called parrot beaking, and you need to be slightly more careful in planning surgery for this area, where you may require to use local oncoplastic procedures more often than not. Complex retroareolar inner lower central defects can be done again with various perforator based flaps like LICAP, thoracodorsal artery perforator flap. We describe this local flap technique, which is quite easy to do. It's a random pattern flap, not really based on a known perforator, but it works quite well. And patients have a reasonably good outcome at the end of 6 months. And we are collecting long-term follow-up data on these patients. So, as I said, latissimus dorsi is an effective solution for any quadrant of the breast, lower central, lower inner, inner central. It can really reach anywhere. I might have previously presented this transposition flap for the outer quadrant, which utilizes the lateral chest wall redundant skin and fat. It is a random pattern flap based on dermal subdermal plexus. It works along the chest wall angiosome principle, which has been studied extensively by plastic surgeons across the world. And it avoids the latissimus dorsi. It's easy, quick, reliable. All you need to do is a bit of preoperative planning. We published the initial experience of 40 patients that we had at our center, and we've almost finished another 200 patients after that. So it tells us that this is quite a reliable flap in this part of the world where skin resection and large volume dissections are still mandatory. And these are a few examples of the same. Coming to more complex flaps like perforator-based flaps, they also can be done once the surgeon has acquired the essential skills to do basic local flaps. They can move on to using perforator dissection, using loops or some kind of microvascular magnification, and then doing perforator-based local flaps. For central quadrant, when I was a surgery student, I learned that central quadrant is a contraindication to breast conservation. Just in another 10 to 15 years, we already know that it is not so, and we can offer reasonably good cosmesis even for central quadrant tumors, which requires resection of the nipple areola complex. And you could use multiple procedures, multiple ways of doing this, a Grisoti flap or an inferior pedicle advancement flap, preferably with contralateral symmetrization. But again, in this part of the world, patients don't often agree for multiple cosmetic procedures. Sometimes they come back later and agree for the procedure when they see a point in what the surgeon is trying to explain. The therapeutic mammoplasty or reduction-based principles are very helpful in patients who have large ptotic breasts and who are willing for a plastic surgical procedure. I think that's the best that you can do to them. A lot of them are very happy because they are happy to get rid of these large ptotic breasts. The only concern for the planning surgeon is whether the primary tumor falls in the reduction template or not. Whether you plan inferior pedicle reduction or superomedial pedicle reduction, where the tumor falls matters, and tumors don't know what the boundaries of reduction are, so they lie wherever they want. And then we need to use some techniques to get around this surgical situation, and sometimes still try and provide them optimal cosmesis, tumors closer to the nipple. You may even remove the nipple, do a free nipple graft if you are experienced with those, and try to give them optimal cosmesis. So again, when Silverstein published this, and he was again the founder of this thought of extreme oncoplasty, I would say that's quite a misnomer, because there's nothing like extreme oncoplasty. There is only extreme breast conservation. So as breast surgeons, as oncosurgeons, it's our responsibility to decide when it is safe to do breast conservation surgery for a particular patient, and then use the help of our plastic surgeons in planning plastic procedures which can then maintain the shape, form, size, symmetry, etc. of the breast to the optimal. So various examples I can show you of these therapeutic mammoplasty principles. Now we have acquired enough experience over the last 5 years to be able to offer this procedure to tumors located in any part of the breast, and we are trying to look at a quality of life or patient-reported outcome measure study in this area to understand if our patients are also as happy as we seem to be. And these extreme oncoplastic procedures, again, the patients have to be really keen on it. And this was one lady who had an asymmetry to begin with, had a large excision biopsy scar in the breast in the upper central quadrant, insisted on having breast conservation surgery. That made us think about what we can do to help her and come up with an extreme oncoplastic solution like this. And at 3 years of follow-up, she's doing quite well. Another lady, as you can see, dense breast on mammography, MRI showing multifocal tumors in this part, lower outer quadrant, insisting on breast conservation, getting an LD flap, and a reasonably good cosmesis. Another one with non-calcific DCIs, where all the surgeons know how bad this entity can be and how the imaging can be misguiding. And she wanted conservation. But we could not do it because of persistent positive margins on table. So we ended up in a mastectomy, saved as much skin as we could, and then offered her an extended LD flap with a reasonable cosmesis. She wants me to put an implant on the other side to make it equal to the side of the primary surgery. So as of 2022, we have so many options for breast conservation surgery and oncoplasty. So it's no more just a mastectomy or BCT for me, but I'm looking at various aspects of the tumor with respect to it, the size of the breast, ptosis of the breast, and quadrant where the tumor is lying, and what the available donor site is, and really making a complex surgical decision for her. Even with a few percentage of patients who need mastectomy for some reason or the other, or maybe because they're locally advanced or they're multicentric, there are multiple whole breast reconstructive options available. Autologous tissue is a gold standard in our part of the world. Again, in our hospital, we have a strong microvascular team, and we prefer not to use implants with respect to its long-term complications. However, for some patients, implants, expanders can be a suitable option for those who do not have any bodily fat anywhere else. We have moved a lot from doing radical and modified radical mastectomies to doing conservative mastectomies, where we are preserving the breast pocket and the breast skin so that reconstruction is easier for these patients. We could do an extended LD, like in this thin lady. We could put an implant, change the expander, which was slightly smaller, and the COVID time did not allow us adequate expansion, but she ended up with a good size implant later on, and she was quite happy, and she would eventually come back for nipple reconstruction. A skin-sparing mastectomy, spare as much skin as possible, even in patients who require a mastectomy. Use an extended LD flap, which is an easy option available to you, or a DF flap. If you have plastic surgery help, this is the gold standard, and it also gives the patients a free tummy tuck, so they are quite happy to have this procedure. For those who have BRCA mutation, you could go for a bilateral mastectomy if the patient wants so, and then could plan a bilateral DF in that case. Similar case of nipple-sparing mastectomy on one side, modified radical mastectomy on one side with a bilateral DF, and this is a 2-year follow-up of the same lady. So skin-sparing mastectomies, subacute mastectomies, nipple-sparing mastectomies, wherever indicated, of course, are changing the way we do mastectomy as well. And these are actually a woman who required nipple resection also because of the proximity of the tumor to the NAC, and also because of extensive DCIs, but she wanted free nipple grafts. So these are free nipple grafts on table. We're following her up. This is the last thing that we did a couple of weeks ago. So after seeing all those oncoplastic procedures and options that are available to us, we still need to take all this with a pinch of salt, and to remind us, to a man with a hammer, everything looks like a nail. So everybody does not require complex procedures, and choose wisely, choose minimum that is going to cause least morbidity to the patient. Keep in mind that safety, of course, has to be assessed. We have Western data, but considering our stage, which is higher, and our tumors, which are larger, we need to keep our own data prospectively to understand if it is safe for this size of tumors, and make sure that your adjuvant therapy delays are not a result of a poor surgery or surgical site infection, because chemotherapy, radiation therapy done in good time has an equal importance in getting the patient to that 90% cure rate that we are achieving today. So complications like this, they do happen. There's a good, bad, and ugly, and we all see these as surgeons, and we need to be proactive in managing them to reduce their incidence as much as possible, so that we avoid potential delays in the delivery of adjuvant therapy, because they can be detrimental to the extent that 4 to 8% detriment in long-term outcome can be because of delays in starting adjuvant chemotherapy, radiation therapy protocols. Radiation boost delivery is important to reduce the risk of local recurrence, and we communicate with our radiation oncologist for every oncoplastic procedure, convey to them what has been done so they understand which is the area that needs a boost. And these slides provided to me by my friend Dr. Tabassum, who's here also with us, is that when you do this careful planning with consideration talking to the surgeon, you can often reduce the area of the boost requirement. Because if you are just going to go by the entire mobilized tissue, which is a norm in oncoplastic procedures, you are going to end up irradiating a much larger amount of breast, which would then hamper the cosmesis in the long term. Whereas if you just go by clips, you will probably miss the boost area. So something in between and a good understanding of what surgical procedure has happened will help the radiation oncologist to plan their boost delivery better. And you don't probably have to radiate the whole flap and you could just do some more fancy techniques that the radiation oncologists are good at doing at our place now. So this is a multidisciplinary approach. This is a team approach, and you have to have breast and plastic surgeons involved, radiologists in giving you good imaging to make you understand whether breast conservation is safe and how much is the area involved. Radiation oncologists, they're planning accurate chemotherapy delivery and using all the state-of-the-art drugs that we have today. And I cannot underestimate the value of the physiotherapists, psychologists, breast care nurses that we have at our center. So just to touch upon surgery of axilla, we do need to stage the axilla because we need to prognosticate the patient. We need to take adjuvant systemic therapy decision, and it may even have a therapeutic role. In early breast cancer, we offer sentinel node biopsy procedure to patients. There is no need to do a complete dissection. Low X-ray sampling is one such procedure that we have developed at our hospital. Instead of sentinel node biopsy, just whenever in some parts of the world, wherever radionuclide or radiocolloid facilities are not available, nuclear medicine centers are not available, they can still go ahead with a technique that does not require fancy instrumentation, and you may still be able to do a limited axillary surgery and avoid the morbidity of a complete ALND. So sentinel node biopsy and an anatomical low X-ray sampling are the two commonly done procedures with a good FNR with no difference in long-term outcome. My previous speaker already talked about ECOSOC Z11 study. We have some reservations implementing this as a routine in our country, and this is the reason why, because we still have a lot of lymph node positivity. But whenever the situation is suitable, whenever they are micrometastasis, we have enough confidence from Z11, the IVCHG 023 and the Senomix studies, which tell us that you can conserve the axilla even if 1 to 2 nodes are metastatic, especially if they are micrometastatic. We still see a lot of level 3 involvement, almost up to 25%. This is a 1,600 patients data that got published in 2019 by me, and hence we, as a standard of care, complete the axillary dissection up to level 3. So approach to axilla in the post-chemotherapy setting again is earlier locally advanced. Currently for locally advanced breast cancer, I would say complete axillary lymph node dissection is the standard of care. We have issues doing post-chemo SNB. We have not been able to get a good FNR across the 3 large studies that happen worldwide. So we want to improve the false negative rate of post-chemo sentinel node biopsy by using various techniques like targeted dissection, clipping, putting MAC seeds, radioiodine seeds, etc. And this is work in progress at our hospital still. And we also looked at doing anatomical low X-ray sampling in the post-chemo setting, and there seems to be some promise in this procedure, and we are currently looking at a randomized trial in the post-chemo setting, especially node negative. So even the axillary surgery as compared to 1970s till date, we have seen a huge spectrum towards conservatism, and maybe a few more studies are underway to look at whether we can avoid it completely, especially in the low-risk luminal A, good prognosis kind of situation. There's a lot more of technological advances happening in breast surgery. Fluorescence imaging is in place. We are able to do sentinel node biopsy with ICG dye rather than doing it with a radiocolloid, and this is more easily available across centers. Reverse axillary mapping, we're exploring this right now, but it's not a very popular technique because of the fact that 25% of the times the sentinel node is also the node from the arm, and you need to biopsy it either which way. Perfusion of mastectomy flaps, whenever we are doing conservative mastectomy procedures, we use the ICG dye to assess the vascularity of these flaps and modify them on table if required. There's a whole lot that maybe I'm not a better person to talk about with respect to non-palpable lesions, because we don't really do population-based breast screening. But there's a lot available in the Western world today where you can get away with a biopsy of non-palpable lesion with various ways. So what we need is at least in our side of the world, is dedicated breast oncoplastic surgeons, dedicated breast clinics, training programs tailoring to the needs of breast surgery in this developing country. We need to keep prospective data. We need to plan randomized trials with respect to our needs, and we probably need to think a little out of the box with some more innovative solutions. With this, thank you so much, and thank you for your warm hospitality to all the members of the Breast Cancer Society.
Thank you so much, Dr. Shalaka Joshi, for his outstanding presentation. Due to time constraint, we cannot take any questions from the audience. Now I would like to request our esteemed panel of experts to share their valuable insights on the addressed topics. Now I am requesting Dr. Professor Mofazol sir to put some comments regarding the session.
Assalamu alaikum and good afternoon. I firstly express my deep gratitude and thanks to the organizer for asking me to be a panelist, Professor Kamruzzaman in particular. We have listened to three speakers. The nice discussion and elaboration by Professor Dijon about the triple negative breast cancer, the recent options we have listened, and the second speaker about the lymphedema, which is a very devastating conditions, and the evolution of surgery by Professor Joshi. I will restrict my comments on triple negative breast cancer because I am a medical oncologist. To my experience, the poor prognosis that is always said about the triple negative breast cancer does not conform to our experience in this part of the world. Actually, one of the medical oncologists who is concerned with the triple negative breast cancer study, she is now in Singapore, Rebecca Dent. I asked her, what is your opinion? How do you find the frequency and the treatment outcome of triple negative breast cancer in this region? She also pointed that, yes, probably there is some genetic changes in this region. We have to find it out. The reason our patients do fare well. But unfortunately, those who present in an advanced stage, their prognosis is equally bleak as it is said in the literature. The recent treatment evolution and the molecules available now, we are yet to use all of them, but few are using the pembrolizumab. We usually practice the standard treatment, try to administer neoadjuvant chemotherapy, followed by surgery, in many cases breast conserving surgery as well, followed by radiation and adjuvant chemo. So we have learned the new options in the triple negative breast cancers. We will be trying to adopt all those once the molecules are available and is within the reach of our poor people. I will not put any comment on lymphedema because our other panelists are there. I will hand over the mics to them. Thank you all.
Thank you so much to all speakers, because they have delivered very excellent presentation, very nice talk with evidence-based scenario. First speaker, he has very nicely talked about the triple negative breast cancer. It is challenge for we people who are dealing with triple negative breast cancer. So the newer molecules, checkpoint inhibitors and drug which are as protocol, the anthracycline or platinum group, everything he has very nicely talked with us. Thank you so much for your nice delivery. Second speaker, lymphedema. Yes, this is excruciating symptoms or sufferings for the patient who developed lymphedema. And he has very nicely elaborated the screening program because this lymphedema may be due to malignancy complications or maybe due to treatment complications. So before decision making or before intervention, if you do the screening as patient is having with lymphedema grade 1 to 3, then the decision making will be the perfect and the incidence of breast lymphedema will be reduced. So thank you, sir. And he has also formulated one team who are the actually members for doing the screening for breast lymphedema. Thank you. Third speaker, thank you so much for surgical evaluation. And nowadays, oncoplasty, patients itself, when come to us, they are telling, I am willing to do oncoplastic surgery. So it is a hot talk. If you do and if you can meticulously, these things will be much more pronounced. Regarding radiation therapy to the breast, yes, in case of breast conserving surgery, always absolutely indicated for radiation therapy. Whether we will go for boost to the axilla or not, or whether we go to the supraclavicular fossa or not, this will be very carefully monitored, and she has mentioned. Thank you so much. Thank you to the organizer, Professor Dr. Kamruzzaman Chaudhuri and his dynamic team, and thank you to the moderator, and my dear respected teacher, colleagues, ladies and gentlemen, Assalamu alaikum.
Assalamu alaikum. Honorable Chairman of the session, Professor A.M. Shariful Alam Sir, my respected panelists, and distinguished speakers from different parts of the world, my respected teachers who are here in front of us, and my junior and senior colleagues. Good noon to everybody. We have enjoyed 3 speakers' speeches. These are the people who are very legend in their field of oncology. First of all, I would like to say a few words about the Professor Don Dijon. He is familiar with me. During COVID situation, a lot of webinar I have enjoyed where he has given his views in different discussions regarding case discussion. Today, he has shown the management of triple negative breast cancer. This is a challenge both for the surgeons and also for the oncologists. The recent trend is, even in the earliest stage or stage 1, if it is a triple negative breast cancer and HER2 positive cancer, neoadjuvant chemotherapy is usually given as per the international rule, as because of highest local recurrence, distant recurrence. So to prevent this, neoadjuvant chemotherapy followed by surgery. I do not like to say much more in this regard, as because the dignified person already given his views regarding this scenario. The next, Professor Alphonse Tagian, he has given the information about the lymphedema. This is a very cumbersome situation, both for the surgeons and also for the oncologist. Following surgical intervention, the patient developed lymphedema following radiation. And he has shown the surgical intervention, specifically axillary lymph node dissection, is one of the important factors, though the effect of regional lymph node irradiation is less in comparison to the surgical aspect. But how to measure this? As we have given decision regarding the management of breast cancer in a multidisciplinary approach, here also he has shown the lymphedema needs multidisciplinary team approach beforehand, before the development and following the development of the lymphedema, how to overcome this situation. So starting from the physiotherapy, physical medicine specialist approaches, lastly, the important issue is even surgical intervention in the form of lymphovenous anastomosis and even lymph node placement in the axilla. So there are few centers, they are doing this. I don't know how much it is effective. So he has covered very important issues regarding the lymphedema. The last speaker is the Professor Shalaka Joshi. She came from Tata Memorial Hospital. I also familiar with her presentation, as because I have attended a lot of webinar which is disseminated from Tata Memorial Hospital in the webinar. He has given a paradigm shift from the breast malignancy treatment in the form of mastectomy and lastly breast conserving surgery, not only this, lastly oncoplastic breast surgery. And lastly, about also few cases, scenarios of lymphedema, how to overcome this. So he has covered a lot of things, surgical intervention and its outcome, and the procedure and the recent thought about the management of breast cancer. So thank you, distinguished audiences, and thanks to all the speakers. Assalamu alaikum.
Thank you, sir. Now I would like to request our Honorable Chairman of this session to share his valuable opinion regarding this topic.
Bismillahirrahmanirrahim. I am honored and privileged to be here as the chairperson of this session. Thank you, organizers, especially Professor Kamruzzaman Chaudhuri, President, Bangladesh Society of Breast Cancer Study, for arranging such an interesting and important conference. I am also offering my heartfelt thanks to the speakers who presented their papers very nicely, and they have given some latest information to us. We will try to implement in our daily practice. Also, my heartfelt thanks to the panel of experts for their input. Also, my thanks to the audience for their passion sharing. Thank you all.
Thank you, sir. With this, we have reached the end of this interesting session. Thanks to all for your kind attention. Now the praise giving ceremony.
Thank you, Dr. Sadia Sharmin. So now it's case giving ceremony. So now I would like to request Professor Dr. Kamruzzaman Chaudhuri, President, Bangladesh Society for Breast Cancer Study, to come to the dais. So first of all, I would like to request Professor Kamruzzaman Chaudhuri to hand over the case to Professor Dr. Don S. Dijon. I again request Professor Dr. Kamruzzaman Chaudhuri to hand over the case to Professor Dr. Alphonse Tagian. And again request Professor Dr. Kamruzzaman Chaudhuri to hand over the case to Professor Dr. Shalaka Joshi. Now I would like to request Professor Dr. Don S. Dijon to hand over the case to our Chairman, Professor Dr. A.M.M. Shariful Alam. I also request Professor Dr. Don S. Dijon to hand over the crest to our one of the panelists, Professor Dr. M.D. Mofazzal Hussain. Now I would like to request Professor Dr. Zakirullah sir to hand over the crest to our one of the panelists, Professor Dr. M.D. Monjur Kadir. I also request Professor Dr. Kamruzzaman Chaudhuri sir to hand over the crest to Professor Dr. A.F.M. Anwar Hussain. So now I would like to request Professor Dr. A.M.M. Shariful Alam sir to hand over the crest to Dr. Sadia Sharmin. Thanks everyone. So now we will move towards the inaugural session. I would like to request the event management to arrange the stage for the inaugural session.
This is the fourth event of Bangladesh Breast Cancer Conference organized by Bangladesh Society for Breast Cancer Study. So first of all, here present the dais, Mr. President, Professor Dr. Kamruzzaman Chaudhuri, Managing Director, Austin Cancer Hospital, our Chief Guest, Professor Dr. Don S. Dijon, Professor of Medicine and Surgery, Brown University, Director, Medical Oncology, Rhode Island Hospital. Our respected special guest, Professor Dr. Muhammad Rubed Amin, Line Director, Non-Communicable Diseases Control Program, DGSAs, and Professor Dr. Shaponkar Bandyopadhyay, our Director, National Institute of Cancer Research Hospital, and our patron, Professor, my teacher, Professor Dr. Sana Hussain sir. our invited speakers, faculty members, local participants, delegates, personalities of diagnostic and pharma industries, and also both media, printed and electronic media personalities, all of you, I offer my warm welcome. In Bangladesh, the incidence of breast cancer patient is rising at an alarming pace, especially among women after the cervical cancer. Males also have a probability of developing breast cancer. As a result, we have planned this conference so that everyone may have a thorough understanding of the most recent developments in treating breast cancer, as well as the many aspects of illness management. We are thankful and blessed to have speakers from several nationals participating in this conference who will serve as keynote speaker in various sessions and share their experience in radiation oncology, medical oncology, surgical oncology, breast pathology, and palliative care. Additionally, our home specialist will discuss their methods of treating breast cancer as well as their experience in the field. Ladies and gentlemen, without this outstanding assistance of our stakeholders, organizing a grand event like this would not have been possible. Thus, I think their names have to be acknowledged. All the pharmaceutical companies and diagnostic labs deserve my sincere gratitude for their kind assistance. Moreover, we appreciate the tireless assistance, support, and guidance provided by our committed employees, co-workers, friends, families during the preparation and execution of this event. Besides that, we would like to express the gratitude to the print and electronic media for attending and covering the event. I hope and think that this event will be able to convey broad knowledge to treat breast cancer, and through this dynamic engagement with each other from the various nationalities will inspire the sharing of ideas and knowledge, which I feel is beneficial for all of us. Last but not least, I want to express my hope and belief that we will all enjoy the conference and our hospitality in the stunning city of Dhaka on behalf of the organizing committee of 4th Bangladesh Conference 2022. Thank you all.
Thank you for your welcome address. At this stage, we are now inviting Professor Dr. Sanwar Hossain, ex-President, Bangladesh College of Physician and Surgeon and Medical Advisor, Square Hospital Limited, and also the patron of Bangladesh Society for Breast Cancer Study, to say a few words. Professor Dr. Sanwar Hossain.
Assalamu alaikum and good morning. At the very outset, I congratulate the Bangladesh Society of Breast Cancer Studies, where I is also one of the activists. We have passed nearly half of the decade. I have not addressed these others illuminatories in this sitting in the dais because they have already illuminated today, and Professor Salim Raza has already addressed them. I do the same to save the time. Probably you are aware that throughout the world, two topics are not only important, are puzzling to the scientists and the physicians of this world. One is acute pancreatitis and another is the breast cancers. As you see, every month there is a new information and a new enthusiasm. And that's why the problem is like that of an elephant in a drawing room, but the physicians and the activists of the breast cancer care are not sitting idle. They are bringing the new and the best news every day and these others. Incidentally, I started my career while there was a paradigm shift. Probably you remember 1970 was the time where the paradigm shift occurred for the breast care, from this radicalism to the modern path, and today it is one of the best favored and the most advanced technology and the enthusiasm of the physicians to look after the victims. Incidentally, these victims occurs in your family. Well, it may be your mother, it may be your in-laws, even your wife, and the coming of these children might have the problem with the breast cancers. Unfortunately, physicians often ignores and neglects. I would request at this forum, you have become an activist and enthusiastic for the people of this country and your nation. Please do not forget about your family, because you should start from there. And your perception, your discussion, your care and the guideline will help this type of people. I hope the breast cancer study group will go further to readdress the situations which we have not yet been able to address, like the pregnancy-associated breast cancer. We have also talked about the locally advanced breast cancers, the breast cancers in very advanced stage. Unfortunately, in a country like that of ours, we are to face this type of problem. At the same time, our young colleagues and this activist, I would request to keep pace with the world so that we can ensure the same type of care, at least we can show the paths that is existing and available in the world at the moment. I hope you will remember and you will do much on the way to yet undefeated problem of the society. I congratulate you, the people, and these organizers for presenting us as a so well-organized an event. And over the day, I will hope that you will come not only benefited, but through discussion, you will contribute and will plan further in the progress of the care of the breast cancers in this country. Thank you very much.
Thanks a lot, Professor Sanwar Hussain, for your valuable speech. Dear audience, our next patron of today's conference, Professor Dr. M.A. Hai, President, SARC Federation of Oncology and Chairperson of Oncology Club, Bangladesh, ex-Director, National Institute of Cancer Research and Hospital, is not able to join with us today due to unavoidable circumstances, but he sent a video message to us. Please run the video of Professor Dr. M.A. Hai.
Bismillahirrahmanirrahim. President of the inaugural session of Bangladesh Breast Cancer Conference 2022, Professor Dr. Kamruzzaman Chaudhary, Chief Guest Professor Don S. Dijon, Special Guest Professor Dr. Sapun Kumar Bandyopadhyay, Professor Dr. Robed Amin, Fellow Patron Professor Dr. Sanwar Hussain, foreign and local faculties and friends, members of BSBCS, invited guests, ladies and gentlemen, Assalamu alaikum. Peace be upon you all. I am really very sorry and beg apology from you all for not being able to present physically. It's a great pleasure to see that Bangladesh Society for Breast Cancer Studies could organize Bangladesh Breast Cancer Conference 2022 physically after more than 2 years due to COVID-19 pandemic. Fortunately or unfortunately, COVID-19 has opened a new avenue for us. We could organize virtually a number of webinars, workshops and seminars. You must be aware of the fact that the incidence and mortality due to breast cancer is increasing enormously in Bangladesh and also many other countries like ours. You all know breast cancer is preventable to some extent and can also be treated at an early stage when curative treatment can be offered. But most of the patients come for treatment at a late stage when curative treatment becomes almost impossible. So we have to increase our efforts towards prevention and early detection of breast cancer. Mammography is recommended for screening and early detection of breast cancer, but the facilities for mammography in respect to our population is almost negligible. A tool has been developed for assessing risk for developing breast cancer among young ladies through questionnaire in Bangla. Those who are found to be at risk for developing breast cancer are advised to consult a doctor or go to some hospital, the list of which is provided in the tool for further investigation and confirmation. Through this process, we may be able to detect breast cancer at a fairly early and treatable stage. This tool is now under pilot study. A preliminary report is quite encouraging and found to be about 97% accurate. Developing skilled manpower and increasing ancillary facilities is very much needed. Bangladesh Society for Breast Cancer Study is working hard to this goal. I hope and believe that this conference will open more avenues for control of breast cancer. My heartfelt thanks to all of you. I wish every success of the conference. Allah Hafiz.
Thank you very much, sir. At this moment, we would like to invite one of our special guests of today's conference, Professor Dr. Mohammad Robert Amin, Line Director, Non-Communicable Disease Control Program, Director General of Health Services, for his valuable speech.
Thank you very much for introducing myself. The fourth Bangladesh Breast Cancer Conference 2022, our very respectable Professor Dr. Sonargaon sir, who has been given a highlighting on these points. Professor Dr. Hai, who has given his speech. Very especially to see great to Professor Dr. Shapan Chandra Bandyopadhyay, the Director of the National Institute of Cancer Research and Hospital. Professor Dr. Don, it was amazing to see him, such a global personality in this particular conference in Bangladesh. And overall, Professor Dr. Kamrujaman Chaudhary, who has been the key pivotal persons to bring us all in to be present in this inaugural session. Well, I'm not an expert, so I will not be saying many things about the breast cancer issue, but I would like to address a few very important issues on the part of cancer in Bangladesh. You see, for any national cancer strategy, we need to have a national cancer control plan. But does we have any national cancer control plan in Bangladesh or not? I think the vision was actually started by the Cancer Society during the time of the third sector program, and it was there. A national cancer strategy has been also developed in 2009 to 2015. But very unfortunately to say that these very wonderful documents has not been in place for the implementation in Bangladesh. Why I'm saying this, right now you will find that there's a cervical cancer program going on in a vertical way, and possibly that program will also incorporate the breast cancer as another vertical program. Now, how many vertical programs can we actually take up for every cancer if you consider? We need to know what is the backload of the cancer in our country. We need to have a national cancer control plan. We need to have a very updating, implemented national cancer strategy in Bangladesh if we really want to consider the cancer as a very big problem. And it is a very, very big problem. Why? Because even in the 2013, there was one report that we are having a 1.5 to 1.8 million cancer in a state. And every year around 200,000 of new cancer cases are coming in our country. The BBS actually says the report in 2004 that this is the 6th leading cause of the death. Now our non-communicable disease has done a step survey in 2018 and actually found that the number of the death percentage of the cancer is around 10%. And it was predicted that within 2030 it's going to be around 15 to 20%. Can you imagine that? How many people are actually dying from the cancer? If you consider about the cervical cancer, every year we are considering about 12,000 cases and 6,000 people are dying from there. Nowadays, the developed countries saying there should be some cancer which is potentially curable, and we are counting the 50% and 60% death. Why these things actually happen? Because we do not have any formulated strategy to follow up in a country. Let me tell few details of this one. You see, for a cancer treatment, we follow the radiation as well as chemo and many other new things to development. What about the radiation plan in a country? Is there any radiation plan in Bangladesh happen? I'm afraid not. International Atomic Energy, I think they said that for 1 million people, you need to have a 2 teletherapy machine, 1 brachytherapy machine. If that is a very scientific consideration, I think for Dhaka we need to have at least 20 teletherapy machines. And Bangladesh need to have 300 to 400 machines for that one. How many machines we actually have? I think still it is double digits. And there are so many people actually treated in the public as well as the private section, and with a very high equipment, fine, very good, excellent. But what about the cancer that has been done in the very rural territory, the very, very local territory? Is there any local center to get the diagnosis, get the treatment or not? Have we started any nationwide cancer registry or not? Beforehand, the paper-based registry was happening only in the National Institute of Cancer Research and Hospital and Bangabandhu Sheikh Mujib Medical University. And all the information are a little bit patchy. And even though if you consider that one and then not to take into consideration other places of Bangladesh, then the plan will not be happening. So that's the reason why very recently we have started to develop a national whole cancer strategy to see the things horizontally, so where all the cancer can be addressed. Within a 2 months period of time in 3 hospitals, we found that around 5,000 patients are coming to follow up. Can you imagine? Within 2 months period of time. Within a 2 months period of time, a small private and one small public hospital revealed 1,000 new cases of different kind of cancer. And that actually revealed new facts. The stomach cancer is more common than the esophagus that has been predicted. So that is the reason why we need to have a cancer registry develop as a whole in our country. We are planning to enlarge it by means of doing it in 8 medical colleges, and at least to start one of the, the community-based cancer registry, because the population-based cancer registry is going to be the achievement tool that we need if somewhere the country need to develop the cancer in the country. Thirdly, from our controller point of view, we like to have the updated the cancer strategic plan. The previous strategic plan was not successful because it was not costed. There was no short-term, mid-term or long-term plan. So whenever these things happen, it becomes in the paper. We like to have a committee which will be a National Cancer Control Council, should be headed by the Health Minister. There should be a task force which should be headed by the Director General of Health Services, and possibly the NCD may be a focal person at that time. And then we need to have a divisional, district, as well as upazila level committees, which should be a multifactorial where all the stakeholders can be involved. Otherwise, we cannot actually, plan to make the cancer control in a country like this. So there's a lot to way to go. And I was wondering that because the Bangladesh is a very unique country where there is always a common risk factor like tobacco and other things, I'm not going to say anything. But the risk factor related to the diet, food, and many of the environment must be considered about when you are considering about the cancer issues. You see, our food is actually formalin based right now, the vegetables, fruits and everything. There's many coloring agents has been using in different kinds of foods, even in the vegetables. And these are carcinogenic. It has been proven in the scientifically. Very unfortunate to say that DDT has been banned in Bangladesh, but it has been used. This kind of DDT has been used for many of the environmental issues. So where are actually where? And even puff rice has been said that treated by means of urea fertilizer, which can cause a very carcinogenic. And remember, our soil is having plenty of heavy metals as well as the arsenic, which is also carcinogenic. So these things need to be considered when we are planning for the prevention of cancer in our country. Sorry that I took a lot of time for that one, but this is very important that this initiative for the breast cancer as a part of awareness is very important for all of us to knock that where are we for the cancer in our country as a whole. As a whole, how shall we deal to us? How shall we make our diagnosis? Currently, the molecular basis diagnosis, the biomarkers are coming in the field, and we are far lacking behind. Every day, every alternate day, people are going outside to get a diagnosis as well as treatment. We need to develop a national base laboratory which should be a reference one, where every facility for making a diagnostic tool for cancer with a low cost and affordability should be available. We need heavy equipments where the cancer diagnosis to be set up. And every kind of treatment modality that we are right now facing for the cancer should be available in our country. The good news is that very recently our political commitment through our government is very serious. So we are taking this cancer very seriously. We will be taking the advices from any kind of society, especially for the Breast Cancer Society of Bangladesh, who has done a fantastic job. and welcome all the stakeholders to take your advices so that we can take our cancer control program very positively informed. Thank you very much for listening.
Thank you for your valuable opinion. Now we would like to invite our special guest of today's program, Professor Dr. Shapun Kumar Bandyopadhyay, Director, National Institute of Cancer Research and Hospital, to say some few words.
Good afternoon. Very special and felicitation for the organizing committee headed by Professor Kamrujaman Chaudhuri for bringing people from the many corners of the world, projecting the scientific advancement in a country where the detection of breast cancer is a big question still, as because we prefer from the very beginning of our life, any practicing doctor will be mimicking my voice, that we focused on only FNA diagnosis, fine needle aspiration cytology, and whole scenario starts with that fine needle aspiration cytology. Still, we are not confined ourselves to the core diagnosis, core biopsy from the breast lumps. And the another part is the level of education of our community, our beloved ladies, beloved daughters, beloved moms. They don't feel active to say about any problem coming from their organ of beauty, especially breast. So two ways of communication gap is there. One from the side of doctors, they prefer cytology, and the other part from the other sufferers. Beloved ladies, they feel shy to talk on breast issues. So we are in the middle, the whole dais and the Breast Cancer Study Society and other people who have been engaging and dedicating their lives for the uplift occasion in Bangladesh. They should be bringing these two edges together so that all beautiful presentation. I just was delighted to see a lady from India. She was focusing on breast conserving surgery, sentinel node and other issues. So it was really, really amazing. But when I was thinking that I belong to a public sector hospital where we are, where ladies usually present with a fungating growth, foul-smelling growth, where only palliation is the number one goal for the lives of these beautiful ladies. So all conferences, all scientific people should be thinking, and one moment from my side to Professor Obedamin, he was just addressing the moments where we are, National Strategy for Cancer Control, and that should be very clearly understood by the people who are engaging themselves for long 50 years, especially people with the degree of radiotherapy, because this is the start of the onco practice in Bangladesh starting from 1960. If they will be part of the management in that protocol, they will be better learning and understanding the depth of burden is prevailing in our context, especially in Bangladesh. Another moment I tell every time, the level of education, it is not 1990s, it is not 1970s or 80s, it is the era of science and technology. So every students in medical science, they should have a drive to understand the global development of any scientific issue, whether it has happened with the hands of Dr. Paul from Australia or anybody from Tata Memorial Hospital, and that should be instantly transmitted by application of apps so that our beloved students with their beautiful merits, they can learn it from their rural level, especially some of the divisional headquarters of Bangladesh. This is the high time of technology. If you can find a patient with COVID positive by application of apps, why not a lady suffering from breast cancer would be incorporated within the context of apps so that the national strategy plan could be easily done with the application of IT. So a lot of things are coming forward to do the better management of the breast cancer issues and other cancer issues as well, as because we are having 170 million population. We do have a lot of problems with oncology, but the focal persons are not actively, or they are lagging behind to raise their voice, especially to the people, DGHS, Minister of Health, Secretary of Health, policy making people, Ministry of Education, and every stakeholders are there to combat and to fight against cancer. With these beautiful words, I must congratulate the organizing team headed by Professor Kamrujaman Chaudhuri, Dr. Selim Reza, one of my beloved senior colleague, Professor Sanawar Hussain, the legendary surgeon in Bangladesh, Professor Dan coming from the United States of America, and Professor Rubidamin. He is a very gentle and dynamic and one of the eye-catching medical practitioner in Bangladesh. And lastly and finally, it is the colorful pink audience of Pan Pacific Sonargaon. Yes, you are the people who will be participating in raising the break the silence of the ladies who are surrounding you every time. It is your moms, daughters, and everybody. It is your community, and all of the doctors can play a role like a leader. Thank you so much.
Thank you for your very much informative speech. Now, the chief guest of today's program, Professor Dr. Don S. Dejan, chief guest of today's program, Professor of Medicine and Professor of Surgery, Brown University, Lifespan Cancer Institute and Ligorita Cancer Center, USA, will share his thoughts with us and declare the inauguration of today's conference. Professor Dr. Don S. Dejan.
Thank you very much. First, I just want to thank Dr. Chaudhry for picking a podium that I can see above of, because that's very, very helpful. I'd known the Bangladesh Breast Cancer Studies group now since 2017, and the work that I've been doing with them in the Global Cancer Institute has probably been one of the best experiences that I've had, and it's because we are talking in a very multidisciplinary way, and I'm talking to colleagues. I believe the knowledge and the motivation and certainly the inspiration to treat this community from the people in this room is incredible. I think the discussions I've always had with this group tell me that you know the data as much as any of us, and we engage in conversations that I learn from as much as I hope I'm trying to teach from. I want to congratulate Dr. Amin on really highlighting the importance of guiding what you're trying to do as a country with data. And certainly it is something that I think can guide all of us in this room. The final thing I would say is that, remember, people are diagnosed, they become survivors at the point of their diagnosis, and they last as a survivor of cancer through their treatments, through being without remission, but also when they develop that metastatic disease and ultimately die with that illness. So our job as doctors is to take care of that entire experience, from prevention to diagnosis to survival to death. And I think we need to remember that, and one of our biggest allies are going to be the people who got this cancer to begin with. And I'm hoping with Dr. Das's help and with Global Cancer Institute, we can help you identify those who are going to be at biggest risk of developing cancer so that we can prevent our sons as well as our daughters from having to experience breast cancer in the future. So thank you very much for having me.
Thank you, sir, for your wonderful speech and also inaugurate today's session. We believe your opinions are highly relevant and important. Now, I would request Professor Dr. Kamruzaman Chaudhry, President, Bangladesh Society for Breast Cancer Study, experience with us on the topic and about organizing Bangladesh Breast Cancer Conference 2022.
First of all, thanks especially today's chief guest, Professor Don S. Dejan, our two practon, Professor Sanor Hussain and Professor Mehai, and two special guests, Director of the National Cancer Institute, Professor Shapon Andopadhyay, and Line Director, Professor Robed Amin, for coming and in inaugural session of this conference, especially fourth Breast Cancer Conference, Bangladesh. So we started this journey in 2015 when I was attending a conference where my mentors, Professor Sanar Hussain, said, breast cancer patients, when diagnosed with a histology, this lady gets visa and passport in her vanity bags. It was a gloomy at that time in 2015. So at that time, we 4 people thought what we can do. So we made the society. Thing is that we know in surveillance epidemiological end result study in USA in last 70 years shows that breast cancer mortality is going down due to early screening and high technology using in breast cancer treatments. So mortality is going down in USA, but mortality in Bangladesh is more. So we thought, let's make a society where we can make a platform where we can have the international speakers and researchers and global scientists and regional scientists to speak and to update us so we can use this technology, we can update our residents and train our radiation oncologists, medical oncologists, and also oncosurgeon so that our patient can be benefited and mortality could be down than earlier. So we started this journey in 2015, and we did it is the 4th conference where we ventilate every research work, modern technologies and other things, and a lot of residents have updated during this period. Even we have started the newer protocols that are using in the US and other places. So definitely we got some benefits, and I should thank Sanwar Hossain sir. That time he inspired us to start this society, to start a platform. From the platform, we can update every 2 yearsly about the recent developments in breast cancer. And definitely, we know Bangladesh has a breast cancer mortality is more due to advanced disease. We don't have screening projects, and we don't have a lot of centers where we can treat the patient early at standard times. So that's why we need to start screening programs, and we need to start a lot of centers because Bangladesh has only 20 to 30 centers out of 300 centers. Definitely there should be government, private partnerships, so to start the comprehensive cancer centers. Since government cannot perform a lot of centers in a time, so both government and private partnership can make some benefits, some achievements in the case of breast cancer management. So definitely, we got our line directors. He's planning for that, especially he's planning for cancer registry and population-based cancer registry. He started already the hospital-based cancer registry in 3 hospitals, and he got the data about the present scenarios. And in coming years, he will be able to focus some more data about the breast cancer and along with other cancers. So thanks to Dr. Robed Amin for starting the hospital-based cancer registry. I should thank our special thanks to all the speakers, because a lot of speakers came from USA, like Professor Don S. Dijon, who is a very academic and special person from the ASCO, and he has a very good research work. He trained ourselves for the last couple of years in webinars and other things. Thanks to Professor Don Dijon coming to Bangladesh from a long way, along with Dr. Alponsi, who's a radiation oncologist, has given a nice talk about lymphedema, how we can prevent. And Dr. Hassan Murshid is coming for the couple of years in Bangladesh. And Dr. Nicholas, he participated in all the breast cancer programs starting from 2015 and today's also. Thanks to Dr. Paul and Dr. Nicholas, especially. And thanks to the Tata Memorial Hospitals, especially the Tabassum and Shalaka Joshi participated and helped a lot, especially for the radiation oncology and surgical oncology, how we can update ourselves. And even Dr. Grace from Singapore also attended. I think he will give lectures in this evening. And Dr. Sawanti Lima is coming from Bombay to give a molecular analysis in precision oncology today. So thanks to all the international speakers, thanks to my teachers, thanks to all the senior radiation oncologists, thanks to our Abul Kalam Azad, who is a managing director of Bangladesh Sangbad Sangstha, and for attending this wonderful conference especially, and he also updated about our oncological scenario in Bangladesh. Thanks to all the resident doctors, professors, surgical oncologists, medical oncologists, radiation oncologists, medical physicists, and allied pathologists and allied subjects. Thanks to all the pharmaceutical industry, and thank you all.
Thanks for your contribution and speech. We hope your efforts will continue in future and thus help organizing this type of international conference once again. Now the crest giving ceremony. I would kindly request Professor Dr. Kamruzaman Chaudhuri to hand over the crest to our chief guest, Professor Dr. Don S. Dijan. Now I request Dr. Mohammad Salim Reza to hand over the crest to Professor Dr. Mohammad Rabit Amin. I humbly request Professor Dr. Sanwar Hussain to hand over the crest to Professor Dr. Shapun Kumar Bandyopadhyay. Now I request Professor Dr. Don S. Dijan to hand over the crest to Professor Dr. Sanwar Hussain. I also request Professor Dr. Don S. Dijan to hand over the crest to Dr. Mohammad Salim Reza. And last but not the least, Professor Dr. Don S. Dijan will hand over the crest to Professor Dr. Kamruzaman Chaudhuri. Thank you everyone for staying and showing your presence. I would kindly request all of you to remain seated on the dais, and I would also request our international faculty to come to the dais for official group photo. Thank you everyone for staying with us and showing your presence. Your participation has inspired us a lot for future endeavors. Ladies and gentlemen, I now request the chairman, panel of experts, and the moderator to take their seat in the dais and start the session.
Honorable guests and audience, Assalamu alaikum and very good afternoon. I am Dr. Faria Sharmin, Associate Consultant Oncology, working at Square Hospital Limited, Dhaka. I welcome you all to today's third session, that is plenary session 2, and I'm really feel honored to be the moderator of this session. So it is my great pleasure to invite our first speaker, Professor Dr. Tabassum Wadasadawala. She is the Professor of Radiation Oncology at Tata Memorial Center, Mumbai. She will talk on hypofractionated and ultra-hypofractionated radiotherapy trials for breast cancer. So, Madam, please.
Assalamu alaikum and a very good afternoon to all of you, and I hope I will keep you awake after the lunch session. So at the outset, I would like to thank the organizers, Dr. Chaudhuri, Dr. Das, for having me here and giving me the opportunity to share my experience on hypofractionation of breast radiotherapy, which is a topic very dear to my heart. So in this lecture, I would be concentrating on the recent evidence. So the topic for the talk is fast forward ready for prime time? So in this presentation, I would be talking about the initial, the role of moderately hypofractionated radiotherapy, the UK trials, the Canadian trials, what are the contentions and how hypofractionation has been adopted in clinical practice, and the recent evidence. The main focus of discussion would be the ultra hypofractionated radiotherapy regimens and our initial experience with ultra hypofractionated radiotherapy, and with few concluding remarks. So we all know the history of hypofractionation in breast cancer is of more than 2 decades. It is the pioneers are from UK, where the STAR trials have established, they changed the paradigm for breast cancer radiotherapy, and they have revolutionized the treatment for breast cancer globally. While the UK and the Canadian trials accrued low-risk patients, the more recent trials, that is the import high trials, the Chinese randomized control trial, the RTOG, and the HIPOT trial, which is the Indian study, these studies are accruing patients in involving high risk for recurrence, and because these are the typical patients that we see in our clinical practice. So let us talk briefly about moderately hypofractionated radiotherapy. This is the slide summarizing the UK randomized trials. You can see that the START-A trial maintained the overall treatment time. There was no reduction in the overall treatment time. The fractions were delivered fortnightly, and the dose prescription was 46.1 gray, and the START-B trial was a trial that looked into the reduction in the overall treatment time, and the treatment was reduced from 5 weeks to 3 weeks. As you can see, the mature 10-year results of both the trials have been remarkable. They have proved non-inferiority of both the hypofractionated, moderately hypofractionated regimens compared to standard conventional fractionation. And it is also reassuring to see that there is no increase in the late normal tissue effects with both the regimens. Similarly, the Danish trial also compared, the primary endpoint was not tumor control, it was the difference in the late effects, and the Ontario trial also established and found the same non-inferiority of the moderately hypofractionated radiotherapy compared to standard conventional fractionation. So, however, though these trials have published their results, but there were few concerns regarding few subgroups that were not well represented in these randomized trials, and hence there had been a lag in the adoption of moderate hypofractionation in patients in practice of clinicians who see more of high-risk population, and which is the typical case in India as well as in Bangladesh. So, what were these contentious issues? We will come to the same one by one. So if you have to talk about the large breast size, there is a concern that hypofractionation, with hypofractionation, the outcome would be adverse. But as you can see from this slide, if you have to look at the radiobiological calculations, if you consider an optimal or the realistic case scenario with alpha beta of 2 for the normal tissues and 3.5 for the tumor, you can see, you can compare the BED is of the hypofractionated radiotherapy, it is lower compared to the conventional fractionation. Similarly, if you have to take the optimistic scenario with normal tissues having alpha beta of 3 and for both late effects as well as tumor, in that scenario also the BED of HFRT is lower. In the worst case scenario also, if you have to see considering alpha beta of 1 gray and 5 gray for tumor, in that scenario as well the hypofractionated radiotherapy has a lower BED. So the large breast size is an independent factor for late effects, but it has nothing to do with hypofractionation. So the key idea is to have a tight control on the dose inhomogeneity. So this was a recent study that was published in large-breasted women, and you can see the grades of toxicity. Hypofractionated radiotherapy has less of grade 2 toxicity, and The same thing if they studied with respect to the posterior separation of more than 25 centimeters. This was also, the same finding was noticed. So what the authors recommended was that you have to definitely restrict the Dmax dose of 107%, but it is not only about 107%, you also look into the lower dose levels, that is the 105% and the 106%. And probably, if it is possible, try to achieve these dose levels to as low as possible. So the bottom line is to achieve a tight control of the dose. So coming to the toxicity, there were concerns about it will be more toxic, and the 5-year data was updated. The 10-year data has also shown convincingly, as you can see from the forest plot, all the with respect to all the toxicities, be it shrinkage, the appearance of the breast, the telangiectasias, the forest plot is in favor of hypofractionated radiotherapy. And if you have to look at the values, the figures in light blue, you can see that the absolute figures are very small, and the difference between the two arms is negligible. And either the normal tissue effects are same or they are fewer. So there isn't any concern, or there shouldn't be any concern of increased toxicity. It's not a real worry. Moreover, reducing the number of fractions also reduces the fatigue. It is resource sparing as well as, and hence it improves access to radiotherapy for breast cancer patients. Coming to the subgroup of patients requiring regional nodal irradiation, and I would like to emphasize here that even the START trial had 15% of patients that amounted to around 700 to 800 patients of the entire cohort that had received lymphatic irradiation, and the Chinese trial, which I would be discussing subsequently, also gave hypofractionated radiotherapy to the chest wall as well as the regional lymphatics. So there hasn't been any report of brachial plexopathy, and the shoulder morbidity is also comparable. And in future, we would be also getting the evidence from the lymphatic sub-study, the HYPO trial, and the REAL trial. The high risk in view of young age or molecular subtypes, these subgroups have been underrepresented, but underrepresentation does not mean that it is contraindicated, and hence most of the guidelines, the ASTRO as well as the ESTRO guidelines do not recommend to distinguish based on these high risk features, and it is hypofractionated radiotherapy is advisable irrespective of these factors. Now coming to the post-mastectomy scenario, this was the Chinese trial that had randomized between conventional fractionation versus hypofractionation, and here the dose per fraction was not 2.67, which was used in the START trials, but it was 2.9 gray per fraction, and it was a large trial done in 820 patients, and here RT was given to the chest wall as well as the nodal regions, and as you can see, there isn't any difference in the outcome with respect to the tumor control as well as with respect to skin toxicity and other late effects. The subgroup of patients requiring reconstruction, this is actually not a very common encounter, though in Tata Hospital we do a lot of reconstruction, but overall in the country the same thing would be true in Bangladesh as well. The reconstruction rates are relatively less as compared to the West, and it also depends on what type of reconstruction has been done, whether it is an implant-based reconstruction or autologous reconstruction. So there isn't any randomized data. The studies are still ongoing, but whatever retrospective and prospective data which is available, do hint towards relative safety of moderate hypofractionation for patients with reconstructed breast tissue, because there shouldn't be any biological reason why autologous reconstructed breast tissue should react differently to fractionation changes. And the ongoing trial, one of the trial, which is the ARIA-BR trial, is being done at Tata Memorial Center, and I am the PI on that study. So in due course of time, we should get an answer about fractionation with respect to mastectomy and reconstruction. The another issue is about breast tumor bed boost. So the various trials have studied the boost, incorporation of boost either sequentially or simultaneously, and both in the moderate hypofractionation as well as in the ultra hypofractionated regimen. Because this is a very common scenario in India as well as in Bangladesh, we generally entail giving tumor bed boost to majority of the patients, I would say 90% plus, and hence this is a very valid concern in our practice. So this was the trial, import high trial, that studied the patient-reported outcome as well as the physician-reported outcome, and they compared the results with respect to conventional, with respect to 14-15 followed by sequential boost. And again, there was no significant difference in the two test arms in the patient-reported outcome for toxicity as well as photographic changes. So as I said, the today's standard is moderate hypofractionation, and the uptake has been increasing year by year as we get mature results. Coming to the ultra hypofractionated radiotherapy, the UK FAST trial was the trial that delivered radiotherapy once a week, and the radiotherapy went on for 5 weeks, and in this there was randomization between 50 gray versus 30 gray in 5 fractions and 28.5 gray in 5 fractions, and the primary endpoint was 2-year change in the photographic appearance with several other secondary endpoints. But again, I would like to highlight here that 64% of patients were more than 60 years, 72% entailed SNB or sampling, and very early tumors, which is not like what we see in our country. And when you have to talk about the results of the primary endpoint, you can see that 28.5 gray arm was non-inferior to the 50 gray arm, but that was not the case with 30 gray arm, and hence what is generally practiced is giving 28.5 gray in 5 fractions. And the alpha beta derived from this study was 2.4 gray for the endpoint of photographic change. Similarly, the same findings was noticed in the late effects in the breast, and reassuringly, this regimen also showed a 10-year very low event rate. The 10-year local relapse rate was just 1.3%, which again highlights that this was a very low-risk population that was studied in this trial. Coming to the UK fast forward study, this study again was a 3-arm randomized trial comparing 40 gray in 15 fraction, which is the current standard of care, with 27 gray in 5 fraction and 26 gray in 5 fraction. And here the radiotherapy was given Monday to Friday, 5 days in a week. It was not a weekly fractionation. And here again the primary endpoint was ipsilateral breast tumor control. And again, this was basically 93% patients were BCS, and they were again really early cases. So the acute toxicity, as whether it was measured with respect, assessed according to RTOG or CTCAE, the results were quite favorable. And as you can see, the follow-up of toxicity after completion of radiotherapy, you can see that ultra hypofractionated radiotherapy, the reaction peaked after at 1 or 2 weeks, but it also subsided soon. With respect to the primary endpoint, again, you can see the absolute difference was less than 1%, and the non-inferiority was established, and this was very well welcomed. The study was welcomed because it was during the peak time of the COVID pandemic, and it came into the guidelines also during the pandemic. The late toxicity effect also, you can see that the ones in green, which is the 27 gray in 5 fraction, there was higher concern of late toxicity, but that was not the case with the blue, the figures in blue, which relate to 26 gray in 5 fraction, and most of the toxicities were comparable and not statistically significant. The same thing was noticed with the late toxicity with respect to patient-reported outcome, and the 26 gray in 5 fraction arm was equivalent to the 40 gray in 15 fractions, and the alpha-beta ratio derived from this study was 1.7 gray. So these are the range of all the UK trials that have accrued with different dose fractionation, and the variable, the derivations of alpha beta ratio vary from the endpoint chosen as well as the endpoint with respect to toxicity or tumor control. So one thing, few concerns were raised in the literature, and they said that we really need to wait, and that is actually pragmatic to wait for mature results, 10-year results of the fast and the fast forward. But if you see at how the toxicities progress from 5-year to 10-year, you can see that with long-term, with longer follow-up, the toxicities develop from 5-year to 10-year, but the relative toxicity difference between the two arms does not change, and hence even as we had seen in moderate hypofractionation, the same findings I expect with the ultra hypofractionated regimens at mature follow-up. So coming briefly to the TMH experience, we had the FAST study protocol. We did continue to offer even after the pandemic, and during the pandemic we had treated many patients, all patients in fact, for 1 year with fast and fast forward fractionation, because patients were locked up in Mumbai, they were unable to go, and there were guidelines also from UK that during the pandemic it was okay to start radiotherapy with fast and fast forward fractionation. So the difference from the West was that large majority of our patients required nodal irradiation, including IMN. Majority of our patients require tumor bed boost, which was given simultaneously, and 50% of our patients were MRM. Higher proportion of patients were HER2 high risk, that is HER2 positive and triple negative. So this was the typical population that we see in our clinical practice. And if you have to look at the toxicity, this is the acute toxicity. And there was only one case of grade 3 toxicity. Majority of the toxicities were grade 2 in the fast forward as well as the fast protocol. So we concluded that with FIF, which was the most common technique used in our patients with tangents, it is very feasible to perform fast and fast forward. It results in mild toxicities. There is no incidence of brachial plexopathy, and the follow-up at 2 weeks was also done post-RT, and hence we know that even after patient went back home after conclusion, there wasn't any worsening of toxicity after completion of radiotherapy, and hence it is safe with respect to the acute toxicities. Now coming to the subgroup of this data, this was the data. This was the study which was done in breast conservation, and we were also interested to capture the cosmetic outcomes. So out of the cohort of 400 patients, we did 377 patients with fast or fast forward, and we did photographic assessment as well as subjective assessment done by the physician as well as the patient, and baseline cosmesis was recorded, and we also recorded cosmesis at up to 2 years. So initially the study was up to 2 years, but now I have extended it to capture long-term data as well at 3 and 5 years. And so here I am presenting only a preliminary analysis because the data is still maturing. Not all patients have completed the assessments. So if you see the baseline cosmesis, which is prior to radiotherapy, 74% patients had excellent to good cosmesis according to the patient, and roughly around the same 80% according to the physician. And if you have to see the cosmetic rates of cosmesis at 6 months, it was 79% according to the patient in the excellent and good category, and according to the physician, it was around 70%. Similar data for 1 year follow-up, you can see the baseline cosmesis 74%, it was 81% at 1 year according to the patient, and 60%, and this is attributed to not all patients. We haven't followed up all the patients, and the follow-up is still ongoing, so this will definitely change at once the full data is analyzed. So what we found in our data was that breast size, the breast tumor ratio, the type of cavity, BCS done outside, I meant to say patients who had incomplete excision and required re-excision at our hospital. So that was one important factor that affected baseline cosmesis, and development of post-operative complications. These were these predicted baseline cosmesis, and on follow-up, what was more important was the if the patient had undergone re-excision, patient is receiving hormone therapy, and breast size with a cutoff of around 700 cc, and breast PTV volume as a continuous variable. These were the factors that impacted even at follow-up. So this was our unpublished data, but I cannot complete the discussion without mentioning this study, which is an Indian study from TMC Kolkata, and it is a multi-center study. And this is the study which we are really looking forward to completion, because this is a non-inferiority trial with 5-year loco-regional recurrence as the primary endpoint. And we do have the early toxicity results from this study, and the findings are exactly same as what we had got in our non-randomized data. Overall, there were only 3 patients that experienced grade 3 radiation dermatitis, and there was no grade 3 or higher toxicity in this early report on acute toxicity. So, and this corresponds, this corroborates with with our experience, and the figure on the right-hand side, you can see that the very tight dose constraints were followed, and it shows the quality assurance of the trial, and it is very important to have a good quality assurance, especially when you are doing a multi-center trial. So I would like to conclude by saying that hypofractionated radiotherapy has revolutionized adjuvant radiotherapy in breast cancer. Moderate hypofractionation is the gold standard, and mature data from ultra hypofractionated radiotherapy and SIB are awaited, and ultra hypofractionated radiotherapy is likely to win the race by and large, and it is just a matter of time. Thank you.
Thank you so much, Dr. Tabassum Madam, for sharing your extensive experience and your knowledge with us. Now I like to invite our second speaker, Dr. Mohammad Zakirullah. He is an oncoplastic-based surgeon as well as general surgeon at Phipps Cross University Hospital in Barts Health NHS Trust, London, UK. He will show us light on neoadjuvant chemotherapy for breast cancer and its effect on surgical decisions. So, Dr. Zakirullah.
Thank you very much for inviting me. Thank you, Kamrazaman Bhai. And because this is an oncological society meeting, I'm probably 1% of the audience. I'm one of the surgeons. So you have got so many data. We don't have that many data. We just work, we just cut and find out the things. But my topic today is about neoadjuvant chemotherapy and how this is affecting us. As a surgeon, what do we do and what extra things we're doing. This morning, Dr. Joshi has already spoken to you about different types of surgical procedures, what has been going on. Thank you. She has already done half of my job. So my job would be to explain what is happening, especially after neoadjuvant chemotherapy. So you have already heard that I'm one of the consultant surgeons at Bart's Health NHS Trust, where we have got quite a huge number of breast cancer patients. And now world-leading triple negative cancers lead Professor Schmid is there as well. So we're getting more neoadjuvant chemotherapy patients coming to us to treat them surgically. First of all, we know this neoadjuvant chemotherapy is not a very new concept. We've been using for a long time, but especially for the breast cancer patients, what do you know why it's been used before? There is mainly locally advanced breast cancer, just to reduce the size or just to treat them, and also large tumor, where we can reduce the size of the tumor to make it small so that we can conserve the breast. Instead of doing mastectomy, bilocal excision is the next option we can do. Obviously, certain biology of the tumor we already know. We had only one concept before as a surgeon, the breast cancer is one disease. It's not. We know that there are probably hundreds of different, not 100, at least 10 to 20 different types of subtypes we're actually finding out with the breast cancers. And it's gone into the molecular level. That's why this is changing. And treatment plan is also changing. Sometimes locally inoperable cancer, breast cancer, we can treat them with neoadjuvant chemotherapy. And obviously at the same time, because of the neoadjuvant chemotherapy, we can now reduce the surgery in the axilla. You already know that axillary surgery is quite difficult for the patient in a sense because they get quite a lot of morbidity. And at the same time, the movement of the shoulder, lymphedema, is a really difficult situation to tackle. There's a hypothesis also. We know that the neoadjuvant chemotherapy, hypothetically, if there is any distal metastasis already there, it can kill them off. And you can see when this is responding very well, it means if the tumor is shrinking and the whole tumor is getting almost vanishing nowadays, it means that there's any deposit anywhere in the body should have been responded exactly the same way. That's although the hypothesis, we haven't proven it yet. Another hypothesis is, at the time of surgery, when you're mobilizing all these things, there is a chance that some of the cells can migrate from this cancer tube to go somewhere else. So we can prevent that one as well. And hypothetically, we save that patient. Obviously, we have done several clinical trials that have actually shown some amazing results nowadays. We know that complete pathological response, we can see almost 45 to 90% of the cases is a clinical trial setting. Of course, that could be in case of triple negative cancer and in case of HER2 positive cancers. But role of estrogen positive cancer with neoadjuvant chemotherapy is still very limited, only 10% probably success rate. So that's why you are not very much encouraged to do or send patients for neoadjuvant chemotherapy when they are ER positive and HER2 negative patient group. So we are still going for surgery for this group of patients. So neoadjuvant chemotherapy can be different ways. We all know that. There's more oncologists here. That's why, as a surgeon, we know it could be cytotoxic chemotherapy, it could be some hormonal treatment, or it could be targeted therapies or immunotherapies. There are different types of treatments going on nowadays. But as a surgeon, we all know this picture. I'm sure this is a typical Halsted mastectomy. The concept that time, of course, 100 years ago, 1892, Halsted initially thought this is a local disease, so get rid of it as much as possible. Destroy all the muscle, take everything else, lymph node and everything from chest wall. It did show some respect, some sort of definitely improvement, but not for every patient. And his concept lasted almost 100 years. Recently, when we started to develop, obviously 20s and 30s, 40s time, chemotherapy started to come in, and then concept came and changed completely. It's become more or less systemic disease. So this breast cancer is not a local disease anymore. Now, what kind of surgeries we've been doing for the last many years? Of course, mastectomy is a very common operation, and breast conserving surgery, of course, another options we do for the breast. Otherwise, axillary sentinel lymph node biopsy, and nowadays, axillary clearance has been old, but still sentinel lymph node is coming in practice now. These are the mostly common operations we are doing. I'm going to talk about what is happening with the neoadjuvant era in a minute. But there's some discrepancies we have seen, especially in Bangladesh, because we are doing this conference in Bangladesh. We need to know a little bit of data from Bangladesh as well. Still, mastectomy rate is very high. Of course, it's changing. I'm not saying that's not changing. For the last 5 years, I've been coming here, and I've seen that the breast-conserving surgery is actually now getting momentum. People are actually trying to learn how to do and what to do. And axillary clearance surgery also in Bangladesh is much higher than what is happening internationally. So if I show you a small data, you can see in Bangladesh, breast-conserving surgery is only 5%. That is slightly older data, 17 October time in 17 to 18th October from IPAGMR or the Bangabandhu Sheikh Mujib Hospital. Whereas in the United Kingdom, the mastectomy rate is only 32% compared to 95% in Bangladesh. I'm not saying that we are not developed countries, that's why we cannot do it. I really don't like that because our knowledge is up to date. We can change ourselves very rapidly. So this is only technical difficulty. We have some technical difficulties. We have discussed about radiotherapy. I know that. That is one of the part of breast-conserving surgery. We need to sort out that thing as well. But we can do this operation. It's not difficult at all. Now, there's a concept. It's changing again. I'm saying in Bangladesh, just mastectomy is better than breast-conserving surgery. Is it actually true? There are hundreds of papers. I can show you. These are the papers, all big New England Journal of Surgery and every other journal you can think about. For the last 30 years of pooled data analysis shows actually breast-conserving surgery with radiotherapy is not only equal to mastectomy, it's actually better than mastectomy. This is the real fact. And Professor Mike Dixon, you know this is one of the professors in Scotland, he has got a massive publication presentation. It shows that the present study has shown the high risk of mortality in breast cancer patients treated by mastectomy compared to patients having breast-conserving surgery. Obviously, we are a bit worried to see what kind of comment is coming out. This is true. And not only that, patients going through an attempt of breast-conserving surgery prior to mastectomy had a considerable better outcome than those of primary assigned for mastectomy. There's definitely hundreds of reasons, but we'll find out and talk about that later on as well. Therefore, just remember, while local excision with radiotherapy is not equal to mastectomy, on the contrary, this is better for early breast cancer with stage 1 and stage 2. Now, we already know why. Is it possible to do everybody breast-conserving surgery? No, I'm not saying that. But some tumor size in relation to the breast and also patient acceptance for post-operative radiotherapy, radiation to the nipple areola complex, and also likely to give good aesthetic results, then we'll do breast-conserving surgery. But if it is a big cancer, we have to remove the breast. Of course, I'm not against that at all. Still, in the United Kingdom, 32% of the patients are going for mastectomy because of this, some reasons I'll explain. And this patient was quite a big tumor, about 3 centimeters upper outer quadrant. Just an example. She had another benign lump was the upper inner quadrant. You can see the old scar. And then now she had a just lumpectomy and sentinel lymph node biopsy. And she has got definitely decent sized breast left behind. We can easily remold the breast and create the same breast mount. Now, side effect of axillary clearance. What we are doing all the time here, there are plenty of side effects, but major side effect is the lymphedema. Even for the sentinel lymph node biopsy, I've seen that one professor actually mentioned that about 8%, although in the United Kingdom, we actually found about 2 to 3% of the sentinel lymph node biopsy patients can get lymphedema, but it's quite high actually. But axillary clearance, 30% of the patients are actually getting lymphedema, some form of, or maybe 21 to 30%, some form of lymphedema they can develop. So that is one. Other shoulder movement is a problem as well. And it takes long term to recover from the problem as well. So now, sentinel lymph node biopsy, what is the advantage of that? One is accurate staging can be done. So don't make any mistake. Sentinel lymph node biopsy can actually accurately stage the disease. So it's not that we have to take 4 lymph nodes out, we have to take 10 lymph nodes out. Sentinel lymph node, maximum 2 lymph nodes is fine. Sometimes 1 lymph node, if you know exactly this is a sentinel lymph node, is enough. That will reduce the morbidity for the patients. And of course, some limitations we have got. We have to learn it, how to do it. False negative rate is also can be high for the learners. but may need second axillary procedure. You have to warn the patient that you have to probably have axillary clearance if that comes back as positive. It's very simple. I showed you yesterday. Just inject some patent V and some isotope. Double dye technique is much better than single dye technique. Almost 90 to 95% of the cases, double dye technique can pick up the real sentinel lymph node. Single dye, only about 40 to 60%. So try to avoid that if you have got any opportunity to use double dye technique. You just pick up with the gamma probe and find out how much is the count, and that is the sentinel lymph node. And you just go back, the count will completely go. So what is going to happen? If it is positive, we normally used to send them for OSNA and then find out whether there is any sort of positivity or not. OSNA is a machine where we just put the lymph node, whole lymph node goes inside, and it's actually find out chemically whether there's even micrometastasis can be picked up. But after Z11 study or Z11 study, we are not doing that much of OSNA nowadays because it actually, sometimes we're thinking one or two lymph nodes is positive. Should you do axillary clearance or not? That question will be asked as well. So OSNA is still used, but not the way we used to use before. We do now take the sentinel lymph node out. We wait for the histopathology, and you know that in the United Kingdom, everybody is getting free treatment, so they don't mind to come for second operation as well. Now, clinical implications of primary chemotherapy. What is happening now? As a surgeon, we normally do it first. Of course, they are giving this neoadjuvant chemotherapy for downsizing the tumor and in vivo monitoring of the response. This good thing is, if you give some neoadjuvant chemotherapy to a patient with a large tumor, you can see actually, you can feel. At the same time, you can actually diagnose by monitoring them either with MRI scan or by ultrasound scan or even mammogram. That will actually give you the idea. Of course, we cannot at the same time find out the toxicity of the chemotherapy. If they are toxic, we can stop it and reduce the tumor burden. With the Taxol, we know that about 30% of the paths here for triple negative cancer we are seeing. It might be more in future. And also with Herceptin, about 50% of complete pathological response we are seeing nowadays when we are operating these patients. So there's some benefit to know exactly what is happening with your tumor. Now, type of breast surgeries after neoadjuvant chemotherapy. I just mentioned about what are the surgery we are doing now, but when this neoadjuvant chemotherapy is done, then we do mastectomy. Still we do mastectomy if needed. Breast conserving surgery, excision of the original size or reduced size. That is the question always asked. If after neoadjuvant chemotherapy there's a good response, there's no need to go back and take the whole tumor size out. You just need to take what is the residual tumor left behind, or if there's no tumor left behind, you just take the clip out, marker clip out, with the surrounding of a centimeter of tissues. So it can reduce the volume of tissue you want to take out. At the same time, axillary sentinel lymph node biopsy, if the neoadjuvant chemotherapy is done, at the time of pre-assessment we found that one or two lymph nodes is actually involved, we can mark them. And after neoadjuvant therapy is finished, at the time of surgery, we remove only that one or two marked lymph node. That could be sentinel lymph node, or if it is that they are not the sentinel lymph node, we take another sentinel lymph node out as well. So maximum 3-4 samples of the lymph node has been taken out to see whether this is targeted axillary dissection we normally do. So one thing you have to remember, after neoadjuvant chemotherapy, if there is isolated tumor cells is found, or if there is a micrometastasis, it means the tumor is involved. They have to have axillary clearance. We are still doing that. This is the tumor size. You can see that big tumor sometimes is very impossible to do a wide local excision. So that patient would have gone for the sentinel lymph node biopsy, so gone for a wide local excision. Like this is the chart we're saying. Level of response. If you look at the level of response, if there's no response, size is exactly the same, mastectomy, no doubt about it. If there is slightly smaller size, we do oncoplastic surgery. If there is much smaller size, then we do wide local excision, the simple type 1 oncoplastic surgery. And if there is only clip left, only thing is left, that's just remove the clip, nothing more than that. It depends on what kind of response we have got from the neoadjuvant chemotherapy. From Von Macqua's trial, we know that impact on biological treatment of complete pathological response. So very clearly showing that chemotherapy with placebo, how much response you can get, and when they're added some pertuzumab, response is much better, definitely almost 40%. But one thing is very clear, you have to remember, whether neoadjuvant chemotherapy is given before surgery or adjuvant chemotherapy is given after surgery, the overall survival exactly the same. So don't think that neoadjuvant chemotherapy is given, that means that patient is going to survive more. We are not saying that. And we are just telling them the benefits we are getting as a surgeons to reduce the surgical morbidity. So no apparent difference of the overall survival for neo or adjuvant chemotherapy. So this is an example I'm just giving you. Pre-treatment imaging is very important. You can see there quite a wide area of lumpiness, and there is area we can easily resect out after neoadjuvant chemotherapy, but not before that. It looks quite 2 or 3 areas. Had chemotherapy, and you can see the size has been small, very small, and they're taken out the whole area as one piece, and you can see marker clips are already located, and the tumor shrunk and it's much smaller looking. And this is the patient 2013 operated and 2016 still having both breasts and absolutely fine, no problem at all. And there's no sign of any local recurrence or any distal metastasis. Now, obviously, why surgical incision and body image is important. As a surgeon, we always think about the surgical aspect, not to only remove the cancer, but how does it look like? And especially if you're working in the Western countries, we are very much interested about, especially patients are very interested to know how would it look like after the operation, after the radiotherapy. So that's what we have to do as best as possible. It has got psychological effect as well for the patients. So the surgical treatment of breast cancer has been associated with the negative consequences for patients' body image, sexual function, mental health, and social adjustment. I get surprised when I actually heard from my friends here, Bangladeshi people don't mind if we remove their breast. Have you actually asked them? We presume, and that is the problem. We have to find out, have we got any data from our Bangladeshi patients, whether they like to have their breast removed? Sometimes they get pressurized by their relatives, husband, or somebody else. So we need to have a data. If we can prove that, yes, Bangladeshi patients always love to have mastectomy, I'm in favor of it. Please do some data, and I welcome everybody to do that. Now, pre-neoadjuvant MDT is very important. Please, this is a new era. I'm just telling you again and again, neoadjuvant chemotherapy you are going to use, but it have to be specific MDT, where we are going to discuss about before starting neoadjuvant treatment, how you're going to involve that one, how many people are involved, and the involved imaging has to be very clearly known to the surgeon as well as the oncologist and pathologist and also the radiologist. And correct assessment of multicentric and multifocal disease needs to be done as well, whether this is possible to do breast cancer with surgery or not. At the same time, marking of the lesion is very important as well. So these are the new things. In lumpectomy, we don't need to do that, anything at all. But after neoadjuvant chemotherapy, you have to find out all these things in a multidisciplinary meeting. Surgery in neoadjuvant chemotherapy setting needs careful evaluation before and after the treatment. A multidisciplinary approach is needed in the scenario of achieving the best result, and good communication between the specialist in the meeting is very important. I know that we have started some MDT meeting in Bangladesh as well, not in every center, but at least encouraging that some of the centers actually started to do it. And I really encourage that is the main thing. In 1988, before that, the treatment facilities of United Kingdom, when the patients in London area or around the London area were surviving more compared to the northern area. What is the problem? Then they found out in 1988 when the MDT actually started to come in, then they found out that so many discrepancies between the treatment. Although they're getting everybody's similar treatment, similar money for the treatment, but the person is not talking to each other. So then MDT has been mandatory, and since then the mortality rate or the complication rates, everything has gone down dramatically. So multidisciplinary meeting is very important, and we would like to see in Bangladesh is going to establish very soon nationally, inshallah. Next thing, do all assessment as initial assessment like the way we normally do. The triple assessment like clinical, radiological, and pathological, exactly the same way. Doesn't matter whether they're going for adjuvant chemotherapy or adjuvant treatment. And mammogram is very important. For anybody above the age of 40, we normally recommend mammogram. But if they're symptomatic, even the below whenever it's diagnosed as a cancer, you have to do mammogram. There's a baseline mammogram has to be there. So very important. Like this mammogram, we can see a big lump in the left breast. So definitely, this is very important to find out. So mammogram has got different types of mammogram, digital mammogram nowadays, and also we have got something called a tomosynthesis. Which is tomosynthesis? This is just basically a mammogram, but in a different field, different angle. They are actually taking that pictures. That's why it's very clearly will show you exactly what's happening. Also, ultrasound is very important. At the same time, MRI scan is very important as well, especially for the neoadjuvant chemotherapy patients. You have to have a mammogram, not only mammogram surveillance, you have to have MRI so that you know exactly what is happening to the tumor. Another approach is actually coming out. It's not familiar, we are not familiar that much in England, but that is called technetium-99 system AB scan. Excuse me. This is promising, but we don't know what is the outcome going to be. But anyway, that also can monitor. If somebody cannot go for MRI scan, you can have this kind of study to see what's happening with the tumor after chemotherapy. It's a quite busy slide, but if you read that one, this all local radiological tests should be repeated after neoadjuvant chemotherapy for the clinical and radiological evaluation of response of neoadjuvant chemotherapy. This assessment before surgery must be done even when a radical mastectomy is planned. Why is that? Only reason because the imaging after neoadjuvant chemotherapy will help the pathologist to find out the tumor site. Sometimes it can completely vanish. Yes, we put marker clip, but pathologist needs to know exactly where this marker clip is sitting down. And also MRI scan with marker clip is very important to tell us exactly where the tumor was. Also, don't forget the effect of chemotherapy on the body. As a surgeon, we have got very little knowledge about the whole spectrum of different types of chemotherapy. So that is very important to know what is going to happen. As a surgeon, as a layman, I would say, sometimes this kind of video will help you to understand what is the main effect which is going to help me to decide when to operate. We can have a sound? Can I?
In healthy tissues, new cells are created during cell division, a process called mitosis. When cells become old, they self-destruct and die, a process called apoptosis. A delicate balance must exist between the rate at which new cells are created and the rate at which old cells die. Cancer develops when the balance is disrupted and cells grow out of control. Chemotherapy is a type of treatment that uses strong medicines to stop the growth of cancer cells. Chemotherapy can be administered in several ways. It can be administered as a pill, given as an injection, or given intravenously through a central line. Once the drugs enter the body, they destroy cancer cells by preventing them from growing or multiplying during mitosis. Depending on the stage of a patient's cancer, chemotherapy can be used to cure cancer, stop cancer from spreading, or relieve cancer symptoms. It can be used alone or in combination with other therapies, such as with surgery or radiation. Unfortunately, chemotherapy also harms healthy cells, especially cells that divide quickly. These include cells in the hair, blood, bone marrow, and reproductive organs. Harm to healthy cells is what causes side effects. Some side effects may include hair loss, nausea and vomiting, fatigue, suppression of the immune system, and anemia.
It's a very basic concept, but as a surgeon, you need to know these all 4 complications. When to operate. This is the right time to operate. It's very essential, especially for the neoadjuvant chemotherapy patients. We normally say about 3 to 4 weeks after the last dose of chemotherapy. The reason is because the immunosuppression for different drugs is completely different, and for different person as well. So we normally in the United Kingdom don't touch them immediately after neoadjuvant chemotherapy. So the surgeon, at least 3 to 4 weeks after that, then will get a better feel for healing, and better surgical technique as well will be better and outcome would be better as well. Now, what kind of surgery? As a surgeon, we always say, is it a level 1 oncoplastic surgery or is it a level 2 oncoplastic surgery? Dr. Joshi has already spoken to you about this level 1, level 2. So it's just a simple lumpectomy, or you need to do some breast molding surgery as well. There's same indication for mastectomy before neoadjuvant chemotherapy if these are the problems with the cancer. If they are inflammatory cancer, even if they have neoadjuvant chemotherapy, they need mastectomy. If multicentric disease, they need mastectomy. BRCA1, BRCA2 gene positive, mastectomy. Patient's preference, of course, mastectomy. These are the main indications we have to always remember. Now, reshaping the breast, we said that type 2 oncoplastic or stage, how can you do that? Type 1 is very simple. Just go to the area, take the lump out, take the clip out, and finish, close it off. I did show some wide local excision yesterday. But this is the one we call type level 2 oncoplastic. Like this patient, a young patient had a cancer on the left side of the breast. And of course, you can see it's quite a big cancer. Almost it was 7 centimeters or so. But after neoadjuvant chemotherapy, that shrunk to almost 2 centimeters or so. So you can do therapeutic mammoplasty for this kind of patients, which is a reduction mammoplasty with taking out of the cancer. So first, in the United Kingdom, we normally do therapeutic mammoplasty. I personally prefer to do one side first, complete the radiotherapy and everything, because after radiotherapy, it can shrink a little bit, and they reduce the other side subsequently for symmetrization. So that gives actually good results, and patient is actually normally happy if they can go through this kind of treatment and therapy as well, and also reduction mammoplasty. The main benefit of observing the patient with the operative large tumor was the de-escalating the surgery, actually allowing conservative treatment for almost 65% of the patients, but without neoadjuvant chemotherapy, only 49% patient would have gone for wide local excision. So almost 16% of the patient extra you can get out of neoadjuvant chemotherapy. At the same time, as the negative lymph nodes are frequently encountered in the patients after neoadjuvant chemotherapy, so we can de-escalate the axillary management as well. Instead of doing axillary clearance, we can easily do targeted axillary dissection. That's the benefit. So now, there are so many devices coming out. At the time of operation, for breast conserving surgery, we use some devices. I'm sure you have seen, we normally use marker clip, hydromarker before operation, and then some new devices have come out like mag seed, hologic seed. These are the radio frequency seeds or magnetic seeds. You can easily pick the signal up at the time of surgery, and you don't need to put wire. And the reason for not putting wire means because there's no need. Second thing is wire putting takes time. They have to come on the day to go to the radiologist, put the wire, and then wire might not be in the same place. So there's no way you can reduce the time for your operation. It might take a whole day to get the whole process done. So this kind of hologenic seed, you can see from the picture, it's a very small, tiny, few millimeter size. We put that hologenic seed or this kind of mag seed at the time of core biopsy, and we put that one in either before chemotherapy, although it is not licensed yet, but after chemotherapy with a marker clip already located there, and about a month before the surgery. The reason is that it will be active for at least 3 to 4 months. So you can actually put that one in and then go to the area and take the seed out with the lump as well, and very easily you can actually find out where the seed is. This video, if I get a sound, showing exactly how we do. Just like sentinel node biopsy.
Yeah, I don't think that's what I just don't know what
It's a mag seed or hologenic seed.
Marking that?
We normally locate it and find out the location exactly where it should be and make a cut. Very easy, simple. And you can see the specimen. I'm sure Bangladesh has got this one, faxitron machine as well, immediately in theater, and that will show you the seed is out, margin is clear, and everything is clear. So that is another development, especially after neoadjuvant chemotherapy. This is definitely helpful. So preliminary data suggests that nipple-sparing mastectomy now, if I talk about mastectomy after neoadjuvant chemotherapy, I've already talked about the wide local excision. So of course, this is possible to do mastectomy with preserving nipple areola complex. So there is no contraindication. If cancer is about a centimeter away from the nipple areola complex, we can easily do nipple-sparing mastectomy. So the result is no difference. Nipple is there. Absolutely everything is there. In United Kingdom, we try not to make cut over the breast tissue, either inframammary or maybe upper outer lateral part, so that the scar is not visible. There are various scar concerned in the United Kingdom, all these British people. So you have to hide that scar. This is the implant-based reconstruction you can see on the right side, and this looks absolutely fine. So conservative management is possible, even the patient with the pre-neoadjuvant chemotherapy involving the skin, if there is good response and no skin is involvement after neoadjuvant chemotherapy. Please remember, I've seen that most of us are actually taking skin out. Even sometimes we have got already said that core biopsy area have to be taken out. This is not right. I've been doing for 30 years in the United Kingdom, never been asked to take the core biopsy side. Cancer does not migrate there. They're getting radiotherapy. Unless we're using the same core needle here for 20 patients. That's a different thing. Please don't do that. It has to be sterile and single use, then you don't need to have to take it out. Any skin, if they are not involved. If skin is involved, they're T4. If they're T4, they go for mastectomy. So local skin excision is not actually what is happening in Western countries. Now, a few facts about neoadjuvant chemotherapy. Conservative surgical management after neoadjuvant chemotherapy is associated with an absolute increase in 15 years local recurrence of 5.5%. So slightly increase. If they are given neoadjuvant chemotherapy, it's been already 95% confidence interval, 2.4 to 8.6. And the local recurrence rate is 21.4% for neoadjuvant chemotherapy versus 15.9 for adjuvant chemotherapy. This is the published data. Of course, neoadjuvant chemotherapy is good, but at the same time, we have to understand it can cause a little bit of slightly increased local recurrence. The risk of local recurrence was significantly higher in the first 4 years in patients with neoadjuvant chemotherapy than in those with adjuvant treatment, with few local recurrence after 10 years, year 10. There are some possible explanation which should be taken into account by the multidisciplinary team and correctly explained to the patients before starting neoadjuvant chemotherapy. Tumor localization during surgery is more difficult, and marginal interpretation may be affected by the heterogeneous response pattern. So you have to consider all this kind of thing, how this neoadjuvant chemotherapy is going to affect your tumor. Is there any way you can avoid surgery after neoadjuvant chemotherapy? Because if complete pathological response we can see radiologically, yes, some trials are going on. It's a trial in America and other areas and Europe as well. They're just keeping these patients, not sending them for operation at all, but they're doing one thing. Interesting thing is they're taking some core biopsy from this complete response area of the radiologically. Every 2 months or 3 months they're doing some core biopsy in case there's some cancer coming back. So maybe in future, they don't need any surgeons. Probably neoadjuvant chemotherapy will kill everything. But until then, we have to practice and do it properly. Now, quickly talk about axillary surgery. As I said, that negative findings in the axillary ultrasound scan at the time of before neoadjuvant chemotherapy, we just do sentinel lymph node biopsy. But if it is more than 3 millimeter thickness, I'll request all the ultrasonography those are actually doing in this country, you mention about cortical thickness. Please measure what is the cortical thickness. If it is more than 2.5 to 3 millimeter, you need to do final aspiration cytology so that you know that there is no metastasis at all. I'm sure next time everybody will do that. And suspicious lymph node with negative and valid cytology defined by both presence of lymph cells and absence of malignant cells is the indication that you don't have to do any targeted axillary dissection. We know that sentinel lymph node biopsy and the targeted axillary dissection. What is targeted axillary dissection? In cases of inflammatory breast cancer, axillary node dissection is still indicated in spite of treatment. And otherwise, any positive finding in the sentinel lymph node metastasis, the micrometastasis, or isolated tumor cells is considered as positive. And then axillary lymph node dissection has to be done even after neoadjuvant chemotherapy. So sentinel lymph node biopsy, as I said, targeted axillary dissection, what do you do? I mentioned earlier that we just clip those involved lymph nodes. If there's 1 or 2 lymph nodes involved, not more than that, we clip them And at the time of surgery, we take out only these 2 lymph nodes. Initially, it was done with wire-guided excision of this clip lymph node. Nowadays, we can put this marker, either halogenic marker, or we can do radio frequency and take that lymph node out, and we take another 2 or 3, at least 4 lymph nodes out at the same time, because it's the initial stage we're doing. But always remember that the clip lymph node might not be the sentinel lymph node. So always do the sentinel lymph node die as well at the same time and take the sentinel lymph node out. Few slides before I finish. The patient satisfaction is dramatically has been changing. Those who are expecting that they need mastectomy, when neoadjuvant chemotherapy is working, they don't need any mastectomy. They can get their patients' breast back, their breast back, so they are really happy. So we'll get exactly the same result in Bangladesh. There's a study happened in the United Kingdom. As you know, there's the current practice and surgical outcomes of neoadjuvant chemotherapy for early breast cancer, which we used to call as NEST study, and we all participated in that NEST study. The conclusion is that the neoadjuvant chemotherapy in NEST study is demonstrated variation is used and decision making around the neoadjuvant chemotherapy, even in the United Kingdom. So with surgical downstaging more apparent in the breast than in the axilla, and variations account to disease subtypes. And also the other finding is, these findings highlight the need for clear guidance or guideline for decision making in terms of patient selection and both breast and axillary surgery to address treatment variations and optimize patient's outcome. So we need to do MDT. Again and again, if you think about neoadjuvant chemotherapy, MDT is very, 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 very important. So in my conclusion, the surgical management of patient in neoadjuvant setting requires a multidisciplinary approach with continuous evaluation of the procedures and the results, and tailored patient's management incorporates careful assessment previous to the neoadjuvant chemotherapy, after neoadjuvant chemotherapy, and after surgery. And finally, integration of all the information is needed and should be available before we take that decision. Thank you very much.
Thank you so much, Dr. Zakirullah sir, for your informative presentation. Now, I would like to invite our last speaker, Dr. Nicholas Zedenkowski, to give his speech on clinical implication of tissue biomarkers in breast cancer. Dr. Nicholas.
Wonderful. Thank you very much. To the organising committee for inviting me to come again. It's wonderful to be here. And I could go on about the previous presentation because I am a big advocate of the neoadjuvant approach for patients with breast cancer selected correctly. And I'll make one comment, if I may, that if patients receive surgery 3 to 4 weeks after they're finishing chemotherapy, it is very rare that the chemotherapy impairs the healing or the recovery, and patients generally have a good outcome at that point. And I would not leave them much longer than the 3 to 4 weeks. So I'm going to move on to my speech, which is about breast biomarkers. And there have been a few changes recently, and I'd like to just give an overview of what is happening in biomarkers in breast cancer over the last couple of years. And I'm going to bring the clinical implications into this biomarker talk because I think that we should be practicing medicine that is targeted as much as possible to the individual patient as our number of breast cancer subtypes expands. I have some disclosures and a brief agenda. And I'm going to cover these topics not sequentially, but all they'll be intercalated. So the times are changing, and there are a variety of implications to those changes. But I'm going to go back to the original target that we had in cancer, being the estrogen receptor. Now, this has been known about for quite some time. It remains the mainstay of our subtyping in breast cancer. And an estrogen receptor positive tumour of more than or equal to 1% staining of the number of cells on IHC is positive. However, as has been discussed before, 1 to 10% is actually closer in its behaviour to being negative. And it's the proportion of tumour cells that stain as well as the intensity score. And there's a variety of staining patterns. You might see some heterogeneity, you might see patches of estrogen receptor positivity and patches of negativity. When we do core biopsies initially with breast cancer, the analytic variability is less. And so I would suggest that a core biopsy is actually better for looking at these at the biomarkers. The progesterone receptor, again, 1% is, on IHC is considered positive. It's a companion to the estrogen receptor as it modulates estrogen receptor alpha expression. A value of less than 20% does correlate with a luminal B phenotype along with higher grade without necessarily looking at Ki67, which is quite variable, and I'll touch on that a little bit later. But you can see in the panel on the bottom right that in luminal B tumours, they're more likely to be progesterone receptor negative or low. A higher progesterone receptor expression is associated with a better prognosis. Now HER2, which is the third of the triple biomarker which we know and understand well, is, according to the ASCO-CAP guidelines, IHC 0 or 1 plus is negative. IHC of 3 plus is considered positive. And so an IHC can actually distinguish most of those breast cancer patients without the need for in situ hybridisation. Those that are 2 plus, considered equivocal, then proceed to ISH, and we can then determine if it's HER2 positive or not. Of course, we know about HER2 low now, and this is a revolution in breast cancer medicine, which has occurred this year. And at the ASCO plenary, there was a standing ovation for the Destiny Breast 04 trial results, and this has given us another option for many of these patients who did not have a targeted therapy if they were estrogen receptor negative. But now, if they have HER2 1 plus or 2 plus, if the 2 plus is ISH negative, that's considered to be HER2 low. But I think that we're going to have to do a lot more work in our determination of the HER2 status so that we can give most patients possible access to these new targeted agents. So there's a prognostic impact of these biomarkers, and it's worth knowing about that prognostic impact, but it's also most important to know about the predictive impact. So how are these patients going to do in response to therapy? And so we see on the right that the HER2 positive line is actually on the lower side. And this is prior to HER2-directed agents. And then on the left, the Oxford overview of HER2-directed therapy has seen a significant reduction in the proportion of patients who are experiencing recurrence with HER2-positive disease as a result of HER2-directed therapies, such as trastuzumab, and we now have a plethora of options for those HER2-positive patients. Ki67 is challenging. Ki67 is a prognostic marker. It shows us proliferation of breast cancer, and it distinguishes between luminal A and luminal B. Now, there have been various cut points. So the St. Gallen guidelines in around 2013, from memory, indicated a 14% cut point. However, I think that is too specific. The Lumina trial had a cut point of 13.25%. Oh, sorry, I'll just go back. And that's clearly highly specific. However, if you have a Ki67 of between 10 and 20%, that is probably intermediate. Less than 10% is probably low, and more than 20% would be considered to be high. There is substantial inter-observer variability in Ki67. And this makes it quite difficult to standardise and to compare between institutions and to say, okay, well, this value, this specific value, tells us that this patient has luminal B cancer and they require chemotherapy. And there have been some international efforts that have improved the standardisation of Ki67. So bringing those markers all together, we have the 4 major subtypes of breast cancer, and then we have gene expression profiles. And those gene expression profiles can then slice and dice a little bit differently in terms of the molecular type. And we've talked about luminal HER2 positive, and then we have normal-like and basal-like. Luminal androgen receptor, Claudin low, and then that can be split up into a range of triple negative types. And actually triple negative is defined by the absence of receptors, and that really doesn't help us a great deal because you've got perhaps 10, 20 different types of triple negative breast cancer. Some of them can be distinguished on routine immunohistochemistry. Some of those triple negative breast cancer types are actually very good prognostic, and they don't actually need chemotherapy. And I think that we are over-treating some of these patients. The difficulty there is that we need good tools to select them, and we need confidence in those tools, and we need confidence with our pathology colleagues. So the intrinsic subtype, Chuck Peru back in 2000 worked on these heat maps to determine the HER2 enriched basal-like, luminal A, luminal B, and that is actually different to what we see with the immunohistochemistry. So those intrinsic subtypes based on the genes within the cancer tell us more about how that patient is likely to respond or not respond to the respective therapies. When we include HER2 low, we can also see that there are some changes in the subtypes on a molecular basis. Now, I'll move on to what we've seen recently, and I think that Dr. Dizon and Professor Mannering's talks lead into this quite well. I'm not going to talk about this for too long because Professor Mannering will be talking about the antibody drug conjugates a little bit later on. So HER2 low, as I mentioned, is a target for trastuzumab deruxtecan, and that has a high antibody to drug ratio. So you've got one antibody with 8 approximately of the chemotherapy drugs attached to it. So this is a next generation antibody drug conjugate. It's got more of a payload and it's directed to that tumour cell, but then the fact that it's got a cleavable linker means that it releases the chemotherapy, and that chemotherapy can kill that cancer cell that exhibits the biomarker, but also distributes to the nearby cells for that bystander effect that was mentioned earlier. And this is quite important when you have tumour heterogeneity. The design of the Destiny Breast 04 trial was TDXD compared with treatment of physician's choice. But I actually think that treatment of physician's choice were some very reasonable options for this population of patients, and they were actually fairly heavily pre-treated. They were a group of patients who had a lot of visceral disease. Progression-free survival by blinded independent clinical review, central review, in the hormone receptor positive population was the primary endpoint. And here you can see on the left is the hormone receptor positive and all patients. Now, 10% of these patients were triple negative, hormone receptor negative, and HER2 positive by our traditional cutoffs were excluded from this trial. And the benefit is still there. Overall survival, again, so we see about a 6.5 month improvement in overall survival based on this HER2 low. And that means that it's changed our current paradigm where we have perhaps 65% of patients who are hormone receptor positive, HER2 negative, 15% of patients who are triple negative, and I understand that that percentage is higher in the Bangladeshi population, through to 50% of patients who have a HER2 low phenotype and who may benefit from trastuzumab deruxtecan and potentially a range of new antibody drug conjugates. So those metastatic patients do have benefits from this approach. And so we have a new algorithm for defining HER2 low, looking at IHC and then offering those patients with HER2 low who have an IHC 2+, ISH negative, or IHC 1+, the trastuzumab deruxtecan. Now this drug, of course, also works very well in the HER2 positive patients, and you can see a waterfall plot here, which is pretty much all of the patients experiencing tumour shrinkage or stability. We need to be aware of pneumonitis, and with awareness of pneumonitis, we do have, we can stop treatment early, manage it, and then it's less likely to lead to severe outcomes. In the HER2 positive population, the progression-free survival, overall survival is improved. On the HER2 positive, again, we have tucatinib. Now, tucatinib is a small molecule tyrosine kinase inhibitor and directed against HER2, inhibiting the downstream activation. It controls brain metastases, and this is a time when tucatinib, I think, really comes into its own, is in patients who have brain metastases, and we've seen trials demonstrating that patients with untreated brain metastases have durable control with tucatinib. Survival is increased, and the brain metastases are well controlled, as we've seen with the tucatinib studies. HER3 is another biomarker that's not yet ready for prime time, but there is overexpression in 30 to 50% of breast cancers associated with a poor prognosis. And patritumab deruxtecan, which you'll notice the deruxtecan is the same payload to trastuzumab deruxtecan, and it's a similar antibody drug conjugate where there is phase 1-2 data showing that there is a good response rate to those HER3 positive. And so this is giving us another group of patients who we can identify for targeted approaches. We talked about ESR1 as a resistance marker to aromatase inhibition and to tamoxifen, and this may be either de novo or acquired under selective pressure. It is unusual as a completely de novo change, but 20 to 40% of estrogen receptor positive breast cancer after first line will have ESR1 alterations. Fulvestrant is effective, as shown in the EFFECT and SOPHIA trial, and there are oral SERDs in development. We've seen some changes. We've seen that some of these SERDs have been pulled from the market and the companies aren't continuing with their development, but there are still some SERDs that are in active development. Adding everolimus to an aromatase inhibitor is another strategy that can overcome that ESR1 alteration. With the PADA-1 trial, the addition of fulvestrant, or change from an AI to fulvestrant on emergence of an ESR1 mutation, does lead to a progression-free survival advantage, although you are using up all of your agents earlier. And so I will wait to see the longer-term follow-up of the PADA-1 trial. PIK3CA is another one that, with the SOLAR-1 trial, has shown that there is an advantage to alpelisib for those 40% of patients with hormone receptor positive, HER2 negative metastatic breast cancer, and this contributes to endocrine resistance. If we look at the intent to treat PIK3CA altered population, we can see a benefit with alpelisib, whereas with the PIK3CA wild type there isn't. And this can be seen on circulating tumour DNA as well as with next generation sequencing. And that remains beneficial in patients with altered genes that suggest CDK4/6 inhibitor resistance. Moving on to the triple negative biomarkers. So in metastatic triple-negative breast cancer, we know that there's an advantage to pembrolizumab. In the Impassion 130, there was an advantage with atezolizumab, but that wasn't seen in Impassion 131. And there's conjecture about whether it's the chemotherapy backbone or not, whether it's the nab-paclitaxel versus paclitaxel. But PD-L1 must be positive for the metastatic first-line setting, and it should be given in the first line before the immune system has a chance to get exhausted. These are specific to the PD-L1 stain, and so the drug needs to be prescribed based on the right PD-L1 marker, whether it's SP142, CPS. They all need to be specific because they don't necessarily overlap. So SP142 with atezolizumab, 22C3 with pembrolizumab, and SP263 with durvalumab, and the cut points of these vary. The other thing to note with the biomarkers is that PD-L1 varies substantially by the tissue of origin. So if you're going to get a biopsy looking for PD-L1, liver and bone are low PD-L1 organs, whereas if you look at lymph nodes, lung, they're more likely to be PD-L1 positive. And there may be discrepancy between the primary tumour and the biopsy of a distant metastasis. PD-L1 in early stage triple-negative breast cancer does not predict for immunotherapy effect. So you don't actually need the PD-L1 for those patients who are receiving neoadjuvant pembrolizumab. And so here you can see the forest plots indicating that there's a benefit, whether they're PD-L1 positive or negative. A time when we're increasing the number of patients who are having genomic and genetic testing. So germline testing for BRCA1 and 2 is well worthwhile for patients in the metastatic setting to see whether they can access the PARP inhibitor olaparib, which does have an improvement in overall survival in patients in the first-line setting. Olympia is the early stage trial, and I think this is going to lead to more patients receiving neoadjuvant chemotherapy, particularly for hormone receptor positive disease, because there's a time there that you can test for the BRCA gene before they have surgery, because a BRCA gene alteration has the potential to alter the surgical decision making, as we've just heard, but it also has the potential to give additional options in the adjuvant setting with olaparib. And the Olympia trial shows improvement in invasive disease-free survival. 50% of patients on that trial had neoadjuvant chemotherapy, and there was no difference in quality of life. Another concern has been the long-term outcomes from these adjuvant agents. So if you've got olaparib, are they going to get myelodysplasia later? We haven't seen that in the longer-term follow-up of these patients. And we need to know more about fertility effects from these novel agents being used in the adjuvant and neoadjuvant setting. So the effects of immunotherapy, if they're given neoadjuvant and adjuvant, on the thyroid, on the pancreas, there can be some long-term effects that need to be borne in mind. So overall survival on Olympia at 3.5 years of median follow-up, there is a 3.8% absolute increase in survival. TROP2 for sacituzumab govitecan is the testing of TROP2 is not required as a predictive biomarker because it's almost ubiquitously expressed and the drug is effective in essentially all patients in the triple negative, and now we've seen patients who have hormone receptor positive disease also have a benefit there. And we've seen these Kaplan-Meier curves already. And the benefit is across subtypes, and so there's no significant differences there. And this is the TROPICS-02 compared to treatment of physician's choice that was presented at ASCO this year and followed up at ESMO. Tumour-infiltrating lymphocytes are a fairly simple prognostic biomarker that can be looked at on IHC. So I think tumour-infiltrating lymphocytes, and there's a website which trains pathologists called TILS in breast cancer that's been developed by Shireen Loy and Roberto Salgado, and that is aiming to prevent the problems that we've seen with the development of Ki67 in the heterogeneity of results, so that we can have standardisation of TILs. And so TILs may allow de-escalation of adjuvant therapy. We need trials to look further into that, and there is potential for greater immunotherapy impact. Genomic testing, we have seen some results last year with the RxPonder trial. In the postmenopausal population, it indicates that there are patients who can have chemotherapy omitted who are node positive, 1 to 3 nodes. In the premenopausal patients who had a oncotype test who were node positive, N1, there wasn't a group that they could identify that could have chemotherapy safely omitted. Does this mean that all patients who are premenopausal who have lymph node positive disease need adjuvant chemotherapy? No. It just means that the test wasn't good enough for them. And it makes sense because Oncotype wasn't trained on premenopausal patients. Hopefully the Optima trial will give us more information there, and that's currently in recruitment. Looking at circulating tumour DNA guided therapy in metastatic breast cancer, there is the plasma match study. Now this came up with a conclusion that we can use this to identify patients. But if you look at the numbers, there were 1,051 patients registered. There were 357 with a targetable alteration. 136 entered a treatment cohort, and of those, there was a 6% response rate in the ESR1 mutant, 25% response rate in the HER2 mutant, 22% response rate in AKT. So it's actually a fairly modest number of patients who are benefiting in the end for this. So I think that we need to get better at finding those targets. So in conclusion, the triplet of ER, PR and HER2 remain most clinically relevant actionable biomarkers, and having a good dialogue with our pathologists means that we're able to understand the nuances of this, and this comes into our MDT discussion, looking at the pathology and working out which treatment pathway these patients are best suited to. ESR1 mutation is relevant. PIK3CA may identify patients for alpelisib, the HER2 low for trastuzumab deruxtecan, BRCA1 and 2 relevant to the PARP inhibitors, and PDL1 in metastatic triple negative but is not needed for early stage. And so with that, I'll close. And I think we're running a little bit over time.
Thank you so much, Dr. Nicholas, for sharing your valuable knowledge. There is an announcement. Another parallel session is going to start at Shurma Hall. So dear audience, if you wish, you can join there. Now I would like to request our esteemed panel of experts to share their valuable insights on the addressed topics, starting from Professor Dr. Salma Sultana Madam.
Thank you. Thank you to the Society of Breast Cancer Studies, Bangladesh, for inviting me as a panelist in this session. And thank you. I want to congratulate all the speakers, all 3 speakers. Actually, I'm a surgeon. That's why I'm not going to comment on 2 papers. My learned panelists are there. I think they will comment on those. But I always enjoy the paper of presentation of Dr. Tabassum, and I really love her insight and love to her subject. I have attended many of your lectures in the webinars. So thank you for coming to Bangladesh. And Dr. Nicholas, actually these are really tough for us surgeons, these papers, but the last slide that concluded everything, thank you for that. And regarding Dr. Zakirullah, Actually, I want to thank you for coming, and we had a very nice pre-congress workshop at Dhaka Medical College, and I think it was very helpful for us and our trainees also. And regarding the neoadjuvant therapy and the surgical decision making, I think we are trying not in throughout the country, but in the main centers and in the capital city, we are actually trying for the MDTs and to give maximum benefit to our patients by the neoadjuvant chemotherapy, those who are candidates for the neoadjuvant chemotherapies. And we don't have we don't have the data or papers, but our personal experience is that the patients receiving the neoadjuvant chemotherapies, the surgical decisions are tremendously changed. And in many of the patients, we are able to give the conservative breast surgeries, and which increases the patient's outcome and overall, I would say, the quality of life and everything. But the data regarding the mastectomy and the breast conserving surgery, I think we have two parallel types of patients in the government sector and in the private sector. Actually, in the government sectors, we are getting patients, those who are of low socioeconomic status and are not that much aware of their disease or anything. So mostly they come in a very advanced stage, and that's why in those centers the rate of mastectomy is so high. But I think the scenario is different in the private practice, in private sectors, where the patients are coming from the affluent society and they are conscious, and we are the rate of breast conservation is much higher than the data you have shown in your paper. And I think this paper would give the surgeons the insight that the MDT is so important to give maximum benefit to our patients. So I'd like to thank you, Dr. Zakirullah, for presenting this paper, and thank you all the speakers. Thank you.
Now I would like to request Dr. Bhushan Zadeh.
Thank you. I'm Dr. Bhushan Zadeh, radiation oncologist from India. As Dr. Tabassum has nicely shown, the research going on in the field of radiation oncology in breast cancer, which is making overall treatment time in a shorter course, keeping oncologic outcome toxicity profile same, and reducing overall treatment time so that the logistically and for all the kind of finances spent on logistic, the logistic itself can be a barrier to receive radiation therapy can be taken care of. And in a country like India or Bangladesh, this is a major problem that the time required for radiation, if can be make it short, the acceptability for radiation can be increased. So apart from the research going on, the pandemic, the last pandemic posed a unique situation where we were pressed to reduce overall treatment time because of some other reason. And personally myself, I have treated more than 150 patients with this fast forward protocol at my center. And now we are in the process of collaborating with the TMH to collect all those data retrospectively and validate that data in Indian subcontinent so that we can have our own validation of Western data, how our set of population suit this kind of a fractionation, because prospectively the data is not available, it is getting matured, but retrospectively probably we have a data, it's just matter of time we'll validate. And last week only we got ethics committee approval from our local hospital so that we can now collaborate. And I'm sure whatever experience personally I had, and I can see the experience from TMH, in just few years down the line, this is going to be a new standard of care. We are pretty sure about that. Thank you.
Now I would request Professor Dr. Rajesh Balakrishnan sir to give his valuable opinion.
Good evening to all. What I'll do is I'll just comment upon only one paper from radiation oncology. It's an excellent talk on ultrafractionated radiotherapy for breast cancer by Dr. Tabassum, as usual. So the take-home message is, what I would like to reiterate is, it can be offered to treat all patients except when we need to treat the nodes. The evidence for treating the nodes is maturing. You might get some more data in a few years' time. And we need to use conformal techniques with good setup confirmation with image guidance. Whenever possible, try to use the motion management, that is very important. Quality assurance and 3D conformality is the most important thing. And you need to also follow the strict dose constraints for the OARs. So that is very important to follow the constraints to the heart and the lungs. And the last talk by the biomarkers, it is a very excellent talk, and it definitely gives a lot of insight to the oncologist about the markers which ERPR, HER2, Ki67, PD-L1, and a lot of other markers, like how we can incorporate them in our clinical practice. Thank you.
I would like to request our last panel of experts, Brigadier General Professor Dr. Mohammad Yusuf Ali, sir.
Good evening, Vice Presenter and audience. Three very educative presentation from the three brilliant speakers of advanced centers. Professor Tabassum presented regarding the ultra-hypofractionated radiotherapy in breast cancer. Of course, as she shown, it is practicable even in our country where there is the conformal radiotherapy facilities as well as the IGRT facilities. And in fact, at my experience, we introduced in limited scale this sorts of practice, namely in combined military hospital as well as the Labate Cancer Hospital. So it will be in more and more practice, but some limitations, as already mentioned by Professor Tabassum, that for the advanced, locally advanced cancer, it is yet to introduce. For early cancer, comfortably we can do practice, as well as in the reconstructed breast and bush therapy, it is some uncertainties. So probably it will be overcome in the near future. And of course, we are awaited for the level 1, category 1 recommendation from the international guidelines. Thank you, Professor Tabassum, for his brilliant presentation. Of course, regarding the impact of neoadjuvant chemotherapy on surgical decision, earlier we saw the surgeon decided their procedure, whether it is resectability or not. Nowadays, they are, even at our country, most of the surgeons, they are aware of the importance of the neoadjuvant chemotherapy, and they participate in the MDT, and day by day this standard practice is coming so that the patient benefit is maximized. And limitation, well, regarding the inflammatory breast cancer and locally inoperable breast cancer, question of the BCS, but still those patients who are very much responsive to the neoadjuvant chemotherapy, surgeon is still considering the conservative treatment. Regarding the thank you, Professor Zakarullah, for coming among us and give lesson to us. Thank you. Regarding third speaker, Professor Nicholas, implication of the biomarkers that has prognostic and therapeutic implications, and that guides targeted treatments. At our country, we are going little slow, but day by day we are adopting these biomarker facilities, and hopefully the lecture, brilliant lecture from Professor Nicholas will illuminate us. Thank you. Thank you very much.
Now I would like to request our Honorable Chairman of this session, Dr. Hassan Murshid sir, to give his valuable opinion regarding this session.
Thank you for inviting me to this session today. I seems to be an accidental chairman because Professor Sarawar was unable to attend. but I took copious notes towards the lectures of the excellent presentations. I congratulate all the speakers, and I thank you for all the panelists for giving their excellent opinions. I have few comments. Without going into details, breast cancer is a heterogeneous disease, and it is a systemic disease. So back in Halstead's days, they used to do radical mastectomy, and it didn't work for 100 years. It took 100 years to figure this thing out. The initial trial was NSAPP4 that showed radical mastectomy did not improve survival. Then came NSAPP6, showed the lumpectomy radiation as good as modified mastectomy. And now we are talking about genetic markers, which is over the next 100 years probably going to subclassify all the heterogeneous breast cancers appropriately. So targeted treatments with chemotherapy can be given before or after minimum resection. Chemotherapy before surgery was tested by NSAPP again many years back, and preoperative chemo did not impact the survival of the did not detrimentally impact the survival of the patients, so it became beneficial for many groups of patients back almost 20 years back. So you have markers, ERPR, HER2/neu, Ki-167, Oncotype DX, and many more new markers Dr. Nicholas presented to us, but those are the basic ones. PD-L1 are routinely done in many other countries. Hopefully in Bangladesh soon, many of these will be implemented to detect and diagnose the subclassified breast cancers as well for proper management. Then comes the chemotherapy before surgery nowadays, and HER2/neu positive patients requires preoperative chemotherapy. Large tumors needs preoperative chemotherapy. That has been shown not only benefits to reduce the size of the tumor, but it helps the surgery to have minimum dissection, which helps the patient to have lumpectomy as opposed to mastectomy, which is the idea of breast conservation management. Then comes radiation treatment. So as of now, for many years, 60 years, 50 years, we've been doing conventional fractionated radiation treatment. More recently, data is coming out that hypofractionated treatment for radiation for breast cancer patients, for early stage breast cancer patients, is non-inferior, and toxicity is not more than the conventional treatment. And the reason for that is alpha-beta ratio. For breast cancer, we are finding out now is around 4, where the breast tissue itself, alpha-beta is around 3. So for many years, we thought that giving radiation in fractionated form and protracted treatments would minimize the long-term side effects from radiation treatment. Well, for breast cancer patients, it appears to be that giving hypofractionated treatment and having a shorter course is not only non-inferior, it may also improve the late toxicity. More recently, the RTOG 1005 data came out last month in abstract form that definitely confirmed that not only we can do hypofrac treatments for the entire breast, we can also do concomitant hypofrac boost simultaneously with non-inferior outcomes and better side effects. So to summarize, markers we must implement. Chemotherapy before or after surgery is given because it's a systemic disease, and radiation can be shortened course with hypofrac with properly selected patients for radiation treatment as well. Thank you for all the speakers and the panelists. Thank you.
So we are at the end of this session. So thank you all for participating here and for patience hearing. Now I would like to request Dr. Latifa to start the crest giving ceremony.
Thank you all the speakers for the excellent talk. Now I'd like to announce that there is another session which is going on parallelly, one here at the ballroom and another one in Shurma. In the parallel session of Shurma, Dr. Neha Chowdhury and Professor Dr. Hassan Moshidza will deliver their speeches. If anyone is interested, they can attend over there too. Now, I'd like to request a little crest-giving ceremony now. And I would like to request Professor Dr. Manju Kadesar to hand over the crest to Professor Dr. Tabassum Wadasadawala. Now, I would like to request Professor Dr. Ehtashamul Haq to hand over the crest to Dr. Muhammad Zakirullah. Now, Professor Dr. Ehtashamul Haq to Dr. Muhammad Zakirullah. Now, I'd like to request Professor Dr. Alphonse Tagian to hand over the crest to Professor Dr. Nick Zenkowski. Professor Dr. Alphonse Tagian to Professor Dr. Nick Zenkowski. I'd like to request Professor A.F.M. Anwar Hussain Sir to hand over the crest to Professor Dr. Salma Sultana Madam. I'd like to request Professor Dr. Kamrujaman Chaudhary Sir to hand over the crest to Professor Dr. Salma Sultana Ma'am. Now, I would like to request Professor Major General Dr. Muhammad Ajizul Islam Sir to hand over the crest to Professor Brigadier General Dr. Muhammad Yusuf Ali Sir. Now, I would like to request Professor Dr. Parveen Shahida Akhtar Madam to hand over the crest to Professor Dr. Rajesh Balakrishnan. I'd like to request Professor Dr. Parveen Shahida Ma'am again to hand over the crest to Dr. Bhushan Jade. Now, I would like to request Dr. Muhammad Selim Raja Sir to hand over the crest to Dr. Faria Sharmin. I'd like to request Dr. Muhammad Selim Raja Sir to hand over the crest to Dr. Faria Sharmin, the moderator of this session. Thank you all. Now, I'd like to announce again that there is another parallel session going on in Shurma, where Dr. Neha Chaudhary and Professor Dr. Hassan Moshed will deliver their speeches. If anyone is interested, they can join over there too. Now, very soon we'll be able to start our fourth session, the discussions about radiotherapy and cardiac oncology, here at this ballroom. Thank you. Ladies and gentlemen, we are soon going to start the next session, that's the fourth session here, about radiotherapy and cardiac oncology. The panel of experts for this session will be Dr. Mohammad Roshidun Nobi, Senior Consultant, Department of Radiation Oncology, United Hospital Limited. Professor Dr. M. Nijamul Haq, Professor and Head, Department of Radiation Oncology, National Institute of Cancer Research and Hospital. Dr. Shuman Mollik, Senior Consultant and Head, Department of Radiation Oncology, Narayana Super Specialty Hospital, Howrah, Kolkata. The moderator for this session is Dr. Mohammad Estefsar Hussain, Assistant Professor, Department of Radiotherapy, Sylhet MAG, Osmani Medical College and Hospital, Sylhet. I request Chairman, panel of experts and moderator to take their seat in the dais. Thank you. I request the panel of experts of this session, Dr. Mohammad Roshidun Nobi, Professor Dr. M. Nizamul Haq and Dr. Shuman Mollik to please sit on the dais. And I'd request the moderator of this session, Dr. Mohammad Estefsar Hussain, to start the session.
Ladies and gentlemen, Assalamu alaikum and good afternoon to all of you. Welcome to this session. I am Dr. Mohammad Estefsar Hussain, working in the Department of Radiotherapy, Sylhet MAG Osmani Medical College Hospital as Assistant Professor. We have two back-to-back presentations in this session. Moving on to the session, we will be hearing a presentation from Dr. Grace Kusuma Ujjaja. She will be talking on digital neural radiotherapy in breast cancer. She is a radiation oncologist from National Cancer Center, Singapore. May I request the speaker to come to the dais? Please welcome.
Good afternoon, everyone. I am Dr. Grace from Singapore. Thank you for the organizing team. Thank you, everyone, for inviting me to speak here today. So our topic is regional nodal irradiation in breast cancer. We all know about ALND, where historically it's used to maintain regional control for clinically or SLNB positive axillary lymph node. But now more and more it is actually recognized more as a staging and prognostic tool instead of therapeutic intervention. And we are familiar with SLNB alone when in patient with just N0. But now it comes the question about regional nodal irradiation versus ALND. Are they actually non-inferior to ALND? And we are also well aware about the morbidity about ALND, which is more than RNI and more than SLNB, especially the lymphedema, where ALND is about 49% at 20 years, and another study shown actually how lymphedema is worse among ALND patients compared to axillary RT patients. And we know if SLN positive and ALND will be done, these are the radiotherapy that we normally do. But now we have so many new trials, Z11, IBCSG, MROS. So what do we do about all that? What if the sentinel lymph node is just a micromets? Or even if it's a macromets, can we just stop at SLNB and decrease the morbidity of our patients? We have to remember that our patient survival are increasing, are actually getting better and better. Hence, we need to be mindful of the toxicities of the treatment that we give them. So let's start with the early stage breast cancer with positive sentinel lymph node positive, either macromets or micromets. How shall we manage the axilla? So the first trial is Z11, when they evaluate the patients with 1 to 2 macros, metastatic and sentinel lymph node positive. They check whether SLNB alone is enough. They have published 5 years and 10 years results. Both are consistent. Both shows no significant difference in overall survival, disease-free survival, regional recurrence rate, even after 10 years. They do note, though, that the patients undergoing ALND had increased surgical morbidity for wound infection, seroma, and lymphedema. But let's look a bit deeper to the trial itself. So in total, there are about 900 patients. The population, the median age is about 56 years old. So are they applicable with younger women? Yes, they do stratify actually according to the age. And majority is IDC, mainly stage 1 tumors. 1/3 of the cohort is T2 tumors. Median tumor size about 1.7 cm. And yes, again, the trial did stratify based on the tumor size. And what about the hormone receptor positive status, which, may have late recurrences? Again, there is stratification for that. And even in high-risk women, the ER negative, PR negative, prelim analysis actually suggests there's no effect of elimination of ALND on the survival. And what about the type of surgery? In Z11 only allows lumpectomy, breast conserving surgery. No mastectomy is allowed. And second thing is about the radiotherapy itself. Only whole breast radiotherapy is actually allowed. And what about the quality of the SLNB? Is it a truly N1 positive with macromets? About half of the SLNB only group had micromets. In the ALND group, about 27% had additional mets in lymph nodes removed by the ALND actually. And 10% of these patients with SLN micromets initially and then had macroscopically involved non-sentinel lymph node. Under-enrollment should not be a problem because they discussed the increased enrollment actually may not lead to meaningful detection in significance. So now I would like to go back to the RT aspect when they say in the trial that it's supposed to be just the whole breast RT alone. The team by Jaxi et al. Actually published a paper as a study criticism of the Z11 about the RT aspect. So Jackson et al. Reconstructed the radiation fields. So the team evaluated case reports forms that are completed 18 months after the enrollment, and yes, 89% received whole breast RT. Of these, 15% received treatment actually to the supraclavicular fossa, which was actually a protocol violation, and detailed RT records were obtained for 228 patients, and of those, 81% received tangent-only treatment, yes, but they checked further. 19% received a directed regional nodal RT using at least 3 fields, and they select the patients, which is usually in patients with greater nodal involvement. And among records that are sufficient enough to be evaluated, they even check the height of the tangent, and half of the ALND patient actually use a high tangent. Similarly, in the SLNB group, they increase the height of the tangent field, the superior border, which means it includes more of the low axillary field, more than just not high tangent fields. So since there's no quality assurance of the radiotherapy, it is unclear then whether and to what extent axillary lymph node stations were included in the irradiation. Could actually the low rate of the axillary recurrences be due to unplanned irradiation of the axilla? That is always the question. So now let's move on to the second trial, AMAROS. This trial evaluated SLN positive patients and compared its axillary RT non-inferior compared to ALND. Again, they include T122 tumors. In this trial, BCS and mastectomy are both allowed. Primary endpoint is axillary recurrence rate. Majority of the cohort similar, age is 55, size is 1.7 cm, postmenopausal woman. Yes, majority are micromets in SLN. Mainly is IDC, mainly lumpectomy patient, and patient completed systemic treatment. So they noticed that there is no significant difference in terms of range of motion. However, there is significant lymphedema difference at 5 years among the 2 cohorts. So, however, the ALND is a bit higher than the axillary RT. So even though both have increased lymphedema compared to no axillary treatment at all, but the axillary RT has lower chance, lower potential to get lymphedema compared to patients undergoing the ALND. After a follow-up of 10 years, survival, there's no difference between 2 arms. Second, cancer risk, expectedly, the ART is a bit higher compared to the ALND, but absolute number is actually still very low. Hence, yes, conclusion of the trial is that axillary recurrence after 10 years with SLN positive treated with ART is extremely rare and not significantly different from patients treated with ALND. Survival rate, local recurrence rate are comparable. Again, second primaries are more frequent in the ART cohort, but still low in absolute numbers. Thus, ART is a safe treatment for breast cancer patients with SLN positive. Third trial that specifically addressed micromets in sentinel lymph node biopsy. Do they really need to go back and undergo ALND, or can we just leave it at that? This is a non-inferiority RCT. Again, inclusion criteria, both BCS and mastectomy are allowed. Tumor size up to 5 cm, so T1 and T2 again. Endpoints is DFS. From the RT aspect, if BCS, only RT to the whole breast is allowed. In mastectomy patient, local regional RT is not allowed. IMN RT is only allowed only if any of these lymph nodes were met. There is a bit of protocol violation among the mastectomy group. So it only comprised 9% of the whole cohort, and 6% of this whole mastectomy cohort had a post-mastec RT. And 5% of the cohort of each arm received RT to the axillary lymph node. Similarly, majority of the cohort's median age is also about 54 years old, tumor size less than 2 cm, majority ERPR positive, postmenopausal, size of the METS focus is 1 mm at most, mainly is BCS patient, and the method to detect is the lymphoscintigraphy at the SLN, and patient completed systemic treatment. Here you can see that after 5 years and even 10 years follow-up, the survival is very similar between two arms, are comparable. Breast CA-related event survival rate are really equivalent. So yes, at the conclusions that 5 years ALND could be avoided in early breast cancer with limited sentinel lymph node positive, provided patient then receive the tangent fields and systemic treatment. 10 years findings are consistent with the 5 years findings. So now that we have these 3 trials, then the question is, we don't know anymore. If we do not do the ALND, we do not know exactly anymore how many more are there in the axillary lymph node, the non-sentinel lymph node that actually are positive. So perhaps then we would like to have something that can estimate that risk so that we can advise our patient better whether we should just give 2 fields, tangent field RT, or we need to give a more comprehensive radiation, which means including SCF and axilla. So we can use this nomogram from Memorial Sloan Kettering or this MD Anderson nomogram. Then based on this, based on the percentage of the risk of the spread to the non-SLN nodes, then we can guide our patients better. Another trial coming in UK, this POSNOP. So this one actually to address the Z11. The key differences from Z11 is that mastectomy is allowed. If you remember, just now Z11 is only including BCS, mastectomy is excluded. And axillary treatment here, they assess both ALND or ART. And here there will be stringent RT quality assurances. But result is not out yet. Meanwhile, let's move on to the high-risk breast cancer. The first trial I would like to speak about is MA20. So this is a multi-center RCT for women with BCS only and SLNB, and if the SLN is positive, ALND will be done. So RNI is defined by SCF and IMNRT. If there are only less than 10 axillary lymph node removed, axillary RT shall be included. So inclusion criteria is N positive, tumor size up to 5 centimeters. The study showed that actually overall survival, not significant. Breast cancer mortality also not significant. However, the DFS, yes. So RNI improved the DFS, improved the isolated local regional DFS, and even the distant mets-free survival rate. And even more so among ER negative or PR negative group. Toxicity-wise, actually acceptable. Mainly just grade 2, no grade 4. Grade 3, very, very rare. Pneumonitis, yes, very, very low in absolute numbers. Radiation dermatitis and the skin and lymphedema. Majority of the cohort, again, the age group is very similar to previous trials, about 53, 54 years old. Again, T2 tumors mainly, N1 ER positive, and patient received systemic treatment. Hence, the trial concluded among women with N positive or high risk N0, the addition of regional nodal irradiation on top of the whole breast radiation did not improve overall survival, but it does reduce the rate of breast cancer recurrence. So second trial that's very similar is EORTC 22922. This is early breast cancer. Again, testing whether the addition of RNI actually benefits. This trial includes mastectomy. So the previous one is BCS only. This one is BCS and mastectomy are allowed. Again, RNA is SCF and IMN. Inclusion criteria is stage 1 to 3 with centrally or medially located primary or externally located but with a positive axillary lymph node. Here the endpoint is overall survival. So after median follow-up of almost 11 years, so the 10-year overall survival is similar, nearly statistically significant difference, 80.7 versus 82.3. DFS is significant, again, breast CA mortality also. DMFS similarly also statistically significant difference. And the 10-year rate until any first recurrence is also different. Majority of the cohort similar age, also tumor is up to 5 cm, PN0 and 1, majority is BCS. Long-term side effects, acceptable, 3% lung fibrosis, so it's 1.7% versus 4.4% in the group that received RNI. Cardiac fibrosis, very low, 1%. Cardiac disease, 6%. In the conclusion, in the early breast CA, RNI had marginal effect only on OS, but yes, it has effect in increasing the DFS and DMFS, and also in reducing the mortality from the breast cancer. So now the last trial, DBCG, the Danish one. So the background is that the previous two trials actually did not discern the IMNI benefit alone on the survival in early stage and positive breast cancer. So, and the MA20, the majority is PN1. So what about if the patient is more advanced, PN23? Here they evaluated those patients with right-sided, and they give IMN irradiation, and the left-sided, they did not give IMN irradiation. The cohort, they include both BCS mastectomy. So survival rate, 8-year overall survival, hits the 0.05, significant difference, and breast CA mortality also. 8-year risk of developing distant recurrences, not statistically significant, just near significant. There are also equal numbers in each group died of ischemic heart disease, because we do worry that if we give IMN irradiation to the left side, then whether there is a increased effect on the heart. And in the subgroup analysis, particularly in the medially centrally tumor where they are more prone to have a spread in the IMN, the adjusted hazard ratio here for mortality were in favor of IMNI for this particular group. So in here, particularly in this group, the 8-year overall survival even is significantly different. So the caveats of this trial, IMNI was avoided in the left side, hence no conclusion can be made on the potential cause of IMNI in terms of the cardiotoxicity. And there is lack of evaluation in the RT-induced morbidity. Performance status, for example, were not systematically reported. The HER2 status also not reported in this study. However, despite all these caveats, the trial can safely conclude that IMNI increased overall survival in patients with early stage and positive breast cancer. As the previous speakers also mentioned about neoadjuvant chemotherapy, I think more and more patients now go for neoadjuvant chemotherapy. What shall we do with them? Can we just extrapolate the result from the previous studies that actually exclude all neoadjuvant patients? I don't think so. So that's why we shall wait for this trial, NSABP 51, which exactly addressed the question that we have. Okay, in summary, SLNB, yes, is very essential. And to determine accident management for our patients, we need to assess the SLNB results, the surgical procedure, the surgical type, go into the detail of the histopathology report, and whether patient completes the systemic therapy also. And the 2 nomograms can be helpful to guide us further. And yes, comprehensive RNI, which is SCF and IMN, is advisable for the high-risk breast cancer. Thank you.
Thank you. I'd like to add a little announcement at this moment. This session will be chaired by Professor Dr. Devnarayan Datto, Head of Radiation Oncology, Amrita Institute of Medical Science, Kochi, Kerala, India.
Thank you, Dr. Grace, for your highly informative talk. Now, moving on to the session. Moving on to our next speaker, Dr. Vivek Agarwala. He is the Director and Senior Consultant, Department of Medical Oncology and Hemato-Oncology at Narayana Specialty Hospital, Kolkata, India. May I request him to present the topic?
A very good evening to all of you. At the outset, I must thank the organizers, Professor Kamaruzzaman and my dear friend Arun Anshu, for inviting me over here and giving me this opportunity to talk to you all about cardio-oncology and its application in breast cancer. So the organizers really didn't want me to, bomb you all with study data and clinical trial data, But my basic aim would be to, make it simple and try to generate some interest in cardio-oncology and introduce this concept of cardio-oncology to all of you. So I would start with introducing cardio-oncology and Asian Cardio-Oncology Society, our endeavor. Talk about the relation between breast cancer and cardiovascular diseases, some basics of cardio-oncology before treatment, during treatment, and after treatment, the concept of cardiovascular evaluation and risk stratification, preventive measures, and CTCRD identification and management. We'll go to individual toxic therapies like anthracyclines, anti-HER2 agents, RT in the perspective of cardio-oncology, and talk about long-term follow-up. So, why are we talking about cardio-oncology? Why are we not talking about pulmonary oncology or nephro-oncology or dermato-oncology? Because the cardiac diseases and cancer are really closely related. Now, cancer and cardiovascular diseases are the two most common causes of death and morbidity worldwide as well as in Asia. And the trend is only increasing day by day. We have increasing life expectancy and age, and because of it, more and more cardiovascular diseases and more cancer diagnosis. And because of better cancer treatment, we have better cures nowadays, and hence we have more cancer survivors and more cardiovascular diseases because of the anti-cancer treatments. Now, when we look at any cancer clinic, we see that many of the patients are already having cardiovascular diseases, or they are going to have cardiovascular diseases as a result of treatment. And we are already talking about the concept of reverse cardio-oncology. That is the increased incidence of cancer being found in cardiovascular diseases. And this is already emerging concept. When you look at the different anti-cancer treatments, now every anti-cancer treatment you talk about, there is one or the other cardiac side effect that are going to there. And with the explosion of newer and newer anti-cancer treatments, we are going to see this more often. So, what is cardio-oncology? So that is what the need of the moment is, that we need a coordinated care and a team effort from the treating oncologist as well as cardiologist in order to have a better outcome for all of our cancer patients, in order to prevent and to treat cardiotoxicities which are there during and after treatment, and to ensure that we have a healthy heart and continued cardiac care while we are continuing a potentially cardiotoxic treatment which is life-prolonging and uncompromised treatment of that life-prolonging treatment, taking care of the heart. So the problem is that in the Western countries, cardio-oncology is already an established branch, and you have cardio-oncology clinics in every cancer institute. But when you talk about the Southeastern Asian region, India, Bangladesh, and most of the Asian countries, we lack this cardio-oncology team in most institutes. And when you look at this problem from an oncologist perspective, now we are not confident of our cardiologists actually understanding the scope of cardiotoxicities of the modern anti-cancer treatment. Now the other day, one of my patients whom I gave pembrolizumab presented with myocardial infarction. And I was debating with my cardiologist that, look, this is an immune-related event. But my cardiologist was saying, no, this is a classical myocardial infarction. And when he did an angiography, he did not find any clot, any blockage. So, you don't find your cardiologist, even the experienced one, understanding the scope of anti-cancer treatments in this part of the world. Also, when you talk about echocardiography, according to a survey that we did, what we found is 30% of the echocardiograms are actually not done by cardiologists themselves. It is either an MBBS person who is trained in some has received some training in cardiology, or some technician even doing echocardiography at several centers. And when you talk about cardio-oncology, you probably have only 2 or 3 centers in India and in this Southeastern Asian region actually having a proper cardio-oncology clinic. So our cardiologists are hardly interested in oncology. They are more interested in putting stents and intervention. And when we talk to a cardiologist and try to understand this problem from a cardiologist's perspective, what we understand is most of the oncologists, we are not really concerned about the long-term cardiovascular effects. Now, when a patient comes to our clinic, we hardly look at the blood pressure, we hardly look at the cardiac symptoms. We are only concerned whether they are having neutropenia or not, whether they are having nausea, vomiting or not. And we focus only on the cancer and the oncological outcomes. The long-term cardiovascular toxicities don't really matter to us. The cardiologists, we do consult them, but only for acute events. But rarely do we consult them during the treatment or for a follow-up treatment. And during the cancer treatment, what we see is that the cardiovascular care decreases, and most grade 1 or grade 2 cardiotoxicities are rather ignored. So the solution is that, from an oncologist, as I am an oncologist, I feel that we all must make ourselves aware of basic cardio-oncology ourselves, and we must have some effort to engage the cardiologists into this discussion so that we have achieved best outcomes for our patients. So with this aim, we started this Asian Cardio-Oncology Society 2 years back. It is already a running society. We have activities every 1 month or 2 months. And we already have multiple representatives from many Asian countries, including Bangladesh. We already have Dr. Amran Reza Chaudhry and Dr. Syed Muhammad Akram Hussain being members of Asian Cardio-Oncology Society. And I would want all of you, all oncologists in Bangladesh to, actively participate, take membership in Asian Cardio-Oncology Society. We already have collaborations, including with the Bangladesh Society of Breast Cancer Study. Now let us talk about breast cancer and cardiovascular disease. So breast cancer is the most common malignancy in females, and we have multiple cardiotoxic treatments, including anthracyclines, HER2 treatment, and radiotherapy. The cumulative incidence of major cardiac events, what we call as MACE, is around 4 to 5% at 5 years. And when the incidence of heart failure, when you are giving multiple cardiotoxic treatments like anthracyclines, trastuzumab, radiotherapy, is almost up to 20% at 5 years. So for many of our early breast cancer patients, the breast cancer related mortality is much less than the cardiovascular mortality, which is around 15 to 18% at 10 years. And that is the reason why we need to look at it. Further, those patients who are diagnosed with cardiovascular diseases, they have a higher 4-fold mortality risk than those who do not have. And obviously, we all look at the clinical trial data, but hardly we see that patients who are having active cardiovascular diseases are taken in clinical trials. So the real world cardiovascular disease incidence is probably much, much higher than this. And we need more data from our region in order to document our actual cardiovascular disease and cardiotoxicity rates. Now let us take an example of a breast cancer patient. Now, this is the typical patient that may present to our clinic, a 64-year-old female, postmenopausal, known case of diabetes and hypertension, and has underwent an upfront left modified radical mastectomy, but diagnosed with a T2N1M0 disease, which is ERPR positive as well as HER2 positive. This patient on routine evaluation is normal, doesn't have any active symptoms, and her 2D echocardiography shows a 55% left ventricular ejection fraction. Now, the plan of treatment for most of us is quite clear that we would go ahead with 4 cycles of anthracycline-based chemotherapy, followed by 4 cycles of taxanes and trastuzumab, followed by local radiotherapy, as well as trastuzumab maintenance and aromatase inhibitors. But then, if we really evaluate this patient from cardio-oncology concept, we would first be doing a cardiovascular risk assessment and then start the appropriate oncological management as per the risk. And during the treatment, we would be monitoring and doing surveillance for diagnosing any cardiovascular disease that develops as a result of treatment, and continue the oncological management with cardiovascular disease management. And post-treatment, we would look for long-term cardiotoxicities. Now, this is what a goal of any cardio-oncology clinic is. That is, before the treatment, we are more towards recognition of cardiovascular risks and their mitigation. During the treatment, the focus is on early recognition and treatment of cardiovascular disease and toxicities, whereas post-treatment, the idea of cardio-oncology clinic is mainly on surveillance and mitigation of the late cardiovascular complications. Now, in a routine cardiac evaluation, obviously we need a good history which is focused on cardiovascular risk factors and symptoms, a good clinical examination looking at blood pressure, pulse, saturation, BMI, JVP, pedal edema, and chest and cardiac auscultation, and investigations which will be focusing on ECG, echocardiography, and cardiac imagings and biochemistry. Now, these are the most important, cardiovascular risk factors that we would be needing to. For example, the age of the patient, the family history of premature cardiovascular disease, hypertension, diabetes, lipid profile, as well as the lifestyle risk factors of smoking, obesity, alcohol, as a sedentary habit and lack of exercises. Now, these are all classic cardiovascular risk factors that are there in our patients, and these need to be taken into account in a good history in order to understand the cardiovascular risk of the patient. Now, it is very important to manage these traditional cardiovascular risk factors. Now, for example, hypertension is a multiplicative risk in the presence of other risks. So, if hypertension is there over radiation therapy, the risk of acquiring coronary artery disease is 24 times. And in addition to anthracycline toxicity, hypertension contributes to heart failure 44 times. So, controlling hypertension, controlling lipid profile, controlling your diabetes, all these are very important factors even during cancer treatment. Now, talking about cardiac evaluation, we always talk about echocardiography. Now, echocardiography, many of us may believe that the ejection fraction that is given is not objective enough. And I must tell you that with the modern two-dimensional echocardiography using the planimetry method, if we are able to outline the heart and have a good echo window, 2D echo is a good method in order to assess the left ventricular ejection fraction as well as the structure of the heart. Now, a 2D echo which has a good software for GLS, that is the global longitudinal strain, will give you this strain pattern. And this is very important because this is one investigation that can give you an idea about an early cardiotoxicity which develops without even drop of the ejection fraction. So, this is very important in echocardiography. Now, many of us had this belief that a MUGA scan is very objective and gives you an objective left ventricular ejection fraction. But a MUGA scan gives you radiation toxicity, and a MUGA scan hardly gives you any idea about the cardiac structure. So, MUGA is something that is hardly recommended, and if you are not having a good cardiologist doing a 2D echocardiography, go for a 3D echocardiography which is reproducible, as well as you can go for a cardiac MRI which can give you a good and very reliable ejection fraction instead of a MUGA. Talking about cardiac biomarkers, now troponin are important biomarkers which gives you about idea about myocardial injury, whereas the natriuretic peptides, the BNP, gives you a good idea about the congestion in the chest as well as the strain on the heart. Now, these are important investigations that you need to look into. For example, the baseline global longitudinal strain and cardiac biomarkers are very essential to diagnose subclinical cardiotoxicity and instituting cardioprotective measures early for maximum cardio safety, which is the crux of cardio-oncology. Also, ischemic heart disease is something that often can come and confuse you about the cardiotoxicity, and in order to rule out coronary artery disease, you need to have a good suspicion. And if the pre-test susceptibility or the probability of having coronary artery disease is low, you can utilize non-invasive CT angiography in order to diagnose that. So, just as I said that the baseline measurement of natriuretic peptides and troponin is something which has a class 1 recommendation as per the ESC guidelines in order to detect CTCRD and in high-risk patients. And echocardiography, 3D echocardiography, GLS, they are all class 1 recommendations. So what we learned now is that the baseline cardiovascular risk assessment is very important, and we need to look at the previous cardiotoxic therapies, previous cardiovascular disease, the age, the genetic factors, the medical risk factors the patient has, the lifestyle risk factors, as well as the ECG, echocardiography, and cardiac biomarkers. So based on this, we already have an European Society of Cardiology recommended risk stratification. Now, this is a very easy and simple risk stratification pro forma that is being recommended by the ESC for patients on anthracycline chemotherapy, whereby you can score the patients on what is their risk factor for having a cardiotoxicity, and similar one is also available for trastuzumab. So, if the patients are having one risk factor, they are low risk. If they have 2 or more risk factors up till 4, they are medium risk. If the score becomes 5, or if they have one risk factor, they are high risk. And if they have at least one very high risk factor, they become very high risk. And the risk of having cardiotoxicity increases from 2% to 20% when you grow from the low risk to the very high risk. Now coming back to the approach, so if we diagnose our patient with low risk, we can safely go ahead with the potential cardiotoxic treatment without much intervention. But if we have a patient who has moderate risk, we generally want to increase the surveillance a more stringent way, whereas patients who are high risk or very high risk, you need to relook at your treatment, try to institute more cardio-safe treatment rather than the cardiotoxic treatment, and institute cardioprotective strategies if you are actually going ahead with the cardiotoxic treatment. So if you come back to our case, what we see is that this patient, being a 65-year-old patient with diabetes, hypertension, already is a moderate risk category for receiving anthracyclines. And if this patient is obese or has baseline biomarkers or GLS elevated, they are going to become a high risk. If it is the patient is moderate risk, I would probably go ahead with my anthracycline treatment under strict surveillance, and cardiology referral is not absolutely essential right at the start of the treatment. But if this patient becomes high risk, instead of the anthracyclines, probably I would go to TCH regimen, which is a non-anthracycline based regimen. And if anthracyclines are used, I would make sure that I get a cardiology referral. I optimize the patient in all cardiovascular risk factors, and I would go for a strict surveillance of biomarkers and GLS, so that if there is any subclinical toxicity, I withdraw early and I start cardioprotective measures as soon as possible. And thus you see that if you do this risk stratification, it matters because your management changes. Similarly, for trastuzumab, again, if this patient received anthracyclines, the patient would become a high risk. But if the patient did not receive anthracycline, then patient can still be a moderate risk, and our plan of management is going to change based on whether the patient is high risk or a moderate risk. Now regarding preventive measures, ABCDE tool is very simple that we all can remember, and this is what is generally used in patients of cancer. So for A, you have to be aware of the heart risks. Aspirin if you are suspecting any ischemic disease. B for blood pressure and biomarkers. C for cholesterol and cigarette cessation. D for diet and weight management, dose management as well as diabetes management, and E for exercise and echocardiography. Now once we have started treatment, one of the most important aspects is to define and to catch a CT-RCD, that is a cancer therapy related cardiovascular disease. So cancer therapy related cardiovascular disease is something which is defined as a decline in ejection fraction by 10% to a value of less than 50%, or in the setting of new signs and symptoms of heart failure with elevated cardiac biomarkers. So there are multiple definitions and grading of CT-RCD, and we must note that the CTCAE grading does take care of the symptomatic heart failure, but the asymptomatic heart diseases and asymptomatic cardiovascular dysfunction, even the CTCAE doesn't have grading for it. And then there are multiple definitions, but more or less what we agree is that less than 50% ejection fraction with a 10% decline is something that we would define as CTCRD. Also, we have the European Society of Cardiology definition of both asymptomatic as well as symptomatic heart failure. And for management purpose, we may define heart failure as type A, B, C. Now, type A is something which is asymptomatic and only has preclinical lab abnormalities for something which doesn't require active management but only surveillance, and maybe starting cardioprotective medications once you are sure of it. And type C is something where patients are in symptomatic heart failure, where you have to stop the cardiotoxic treatment and start heart failure treatment. Now, type B is something which is tricky, where the patient has significant reduction in left ventricular ejection fraction but is asymptomatic. And it is proven that in type B heart failure, if you do cardiology consultation, it improves the overall survival. If you institute ACE inhibitors and beta blockers, it improves 50% recovery in your left ventricular dysfunction, and this treatment improves cardiac event-free survival. Again, early intervention improves survival over a delayed intervention. And again, statins, exercise, diet, all these are again measures which improve the survival if you are instituting these measures early. Talking about medications, so for ACE inhibitors and ARBs, in first line we have evidence for enalapril, we have evidence for candesartan, and we have evidence for sacubitril/valsartan. And among beta blockers, carvedilol is something which has more antioxidant properties, so it is preferred as compared to metoprolol, which is less preferred, and bisoprolol is something that is preferred if you have bronchospasm or hypotension. For vasodilators, again, it is an important treatment. Sometimes you want to use as a second line for blood pressure management, as well as when you are instituting fluoropyrimidines and you want to keep your patient safe from cardiac events. And here also the dihydropyrimidine calcium channel blockers are more preferred, and you don't want to prefer the non-dihydropyrimidine ones, that is the verapamil, diltiazem, because they have drug interactions. Among the aldosterone antagonists, eplerenone is preferred as compared to spironolactone, because spironolactone is known to have pro-estrogenic effects and can affect your management in breast cancer. Talking about diet, again, saturated fats, no. Red meat and processed meat, no. Smoked food, no. And eating sufficient fruits, vegetables and fiber is a big plus, and we need to discuss this with our patients. Exercise is something that is very important. Peak exercise capacity, which is measured by the peak oxygen consumption, is something which is reduced in our patients of cancer, and patients can benefit from interventions which improve this exercise capacity. It is proven in research that patients with non-metastatic breast cancer have lesser cardiovascular events with increasing exercise, and exercise has been shown to reduce breast cancer related death as well as mortality. So, again, another concept of primary and secondary cardioprotective measures. So, primary prevention is something that again we start in a patient who doesn't have cardiovascular disease yet but has risk factors, whereas secondary prevention is something where the patient already has a baseline cardiovascular disease or is being diagnosed with a cardiotoxicity during treatment, and there we institute a secondary, and the measures are same, that is the ACE inhibitors and beta blockers and the statins, and of course we need to discuss about the liposomal variations as well as the dextrazoxone. Now, coming to individual cardiotoxic treatments, that is anthracyclines. So, anthracyclines, they have DNA damage by topoisomerase suppression. They cause iron incorporation in the mitochondrial respiratory pathway, causing cell membrane damage in the myocytes, and they also generate reactive oxygen species. The cardiotoxicity by anthracycline is a continuous dose-dependent phenomena. It starts from the first dose itself, and it is much higher when there is concurrent anti-HER2 treatment, taxanes and radiotherapy. It can be acute, where we may have some arrhythmia because of anthracycline. It is rare, and usually most of the toxicities are seen late onset chronic, but with concurrent cardiotoxic treatment it can be early onset also. When you talk about the different anthracyclines, of course doxorubicin as a rapid infusion is probably the most cardiotoxic, but it's the most widely used, and the cardiotoxicity is 5% of more when the cumulative dose rises to 400 milligram per meter square. And as the dose increases, it increases almost up to 50% of your patients at 700 milligram per meter square. Regarding anthracyclines, again, when we are using anthracyclines, if we limit the dose beyond a cumulative dose of 250 to 300 milligram per meter square, we are going to prevent a lot of cardiovascular disease. We should give it as a slow infusion rather than bolus, because slow infusion is shown to decrease cardiovascular diseases. Liposomal formulations should be used wherever feasible as per the data. Dexrazoxone as an iron chelating antioxidant is something that has been shown to reduce the incidence of cardiovascular disease with anthracyclines to almost 4 times. But availability of dexrazoxone is an issue, and there is ample evidence to suggest that dexrazoxone does not interfere with treatment and does not impair survival if you use them. Again, with beta blockers, carvedilol is preferred. ACE inhibitors and ARBs, statins and exercise, they are all shown to decrease the incidence of cardiovascular disease with anthracyclines. So, what if your patient develops a symptomatic CT-CRD with anthracyclines? So obviously, if it is a severe or a moderate, you want to stop it and you discuss in your MDT for alternative treatments. Whereas if it is asymptomatic and mild, we can continue the anthracyclines with cardiovascular monitoring and instituting cardioprotective measures. Regarding the outcome of anthracycline based cardiotoxicity, traditionally it is considered irreversible, but there have been recent reports and studies which showed that with early institution of heart failure treatment and early detection, anthracycline based cardiovascular disease can be reversible. And cardiopulmonary stress testing, where you measure the peak oxygen consumption. So a reduced VO2 is something that can be used as a predictor for survival and to monitor the recovery of cardio function in anthracycline based cardiotoxicity. This is the monitoring schedule that is recommended by ESC for cardiovascular monitoring during anthracyclines, and we see that for low risk patients we don't need much monitoring except a baseline ECG and echocardiography, whereas the biomarkers, the cardiac biomarkers, are also not having a strong recommendation. But for a moderate risk patient as well as a high risk patient, ECG, echocardiography and cardiac biomarkers, they are all important, and we need to repeat them even every 2 cycles in order to be very vigilant about the cardiotoxicity. Talking about HER2 agents, so HER2 is an important component in cardiac tissue, and it is important for cardiac stress response and repair, and HER2 toxicity is usually reversible. Trastuzumab is the most toxic anti-HER2 drug, whereas the toxicity with pertuzumab, lapatinib, TDM1, TDXD, neratinib are all less. So the main cardiovascular effect is an asymptomatic left ventricular dysfunction, which may be up to 10% at 5 years and 20% in combination with anthracyclines. And for heart failure, the data says that it is 2% with anthracycline combination, but the retrospective data, which is outside clinical data, which shows that the incidence of heart failure with anti-HER2 and anthracyclines can be up to 12% at 5 years. Now this toxicity is usually reversible on withholding and starting heart failure treatment. So similarly, the monitoring of cardiovascular toxicities in HER2 treatment in a low risk patient only starts with an echocardiography and ECG, which we need to do every 3 months, and at 12 months we can stop this monitoring and then can only do a 6 monthly echocardiography in patients who have not had any toxicity if they are low risk. But in case of high risk and very high risk patients, we need to do cardiac biomarkers as well as an echocardiography every 3 months, which should be continued.
Excuse me, you have 2 more minutes remaining.
Regarding management of HER2 based cardiac dysfunction, this is actually a bit tricky because it is reversible. So if there is asymptomatic decline in the heart function, we can continue the anti-HER2 drug under cardiovascular monitoring, and this is a class 1 recommendation, but we need to monitor the cardiac biomarkers and GLS. Whereas if the patient is symptomatic, then we need to interrupt the anti-HER2 treatment, give a heart failure treatment, and reassess the patient after 6 weeks to see whether the heart function is recovering or not. Also, I want to discuss these 2 studies, that is the SAFE Heart study, which looked at the prospective evaluation of cardiac safety in cardiac compromised patients for using HER2 targeted therapy. So this was a small study of 31 patients where patients who had a baseline ejection fraction of less than 50%, that is 40 to 49% without any symptoms of heart failure were taken. Now these patients went to cardiologists, they started beta blockers and ACE inhibitors, and they went on to receive the anti-HER2 agents, that is trastuzumab, pertuzumab and edotrastuzumab. And what was found is that 90% of these patients tolerated the treatment well without any major cardiovascular event, whereas only 3 patients suffered a cardiovascular event or asymptomatic worsening in ejection fraction. Similarly, the SCHOLAR study also showed that in patients who had mild cardiotoxicity on trastuzumab, there also we can safely continue trastuzumab. So in this study, again, it was only 20 patients where patients who had an ejection fraction decline below 50% to up to 40% or decline of more than 15% below baseline were continued on trastuzumab, where heart failure therapy was instituted and cardiology follow-up was done. And here too, 90% of the patients continued to receive all planned trastuzumab doses, whereas only 10% of the patients had cardiac events or interruptions. So, trastuzumab therapy is something that despite left ventricular ejection fraction decline we can use, but we need to discuss regarding the risk and the benefit, and we need to institute aggressive cardiac interventions. Talking about radiation, radiation of course has multiple toxicities, and we already have breath hold techniques, prone position techniques, IMRT and proton in order to prevent radiotherapy induced long-term cardiovascular side effects, and we have these cardiac sparing mechanisms. Obviously for radiotherapy also you need to see what is the mean heart dose, and you need to risk stratify the patients whether they are high risk, very high risk, moderate or low risk, and there is a recommendation in order to look at the scores, cardiovascular scores, in order to understand what is the toxicity. Also there are other treatments in breast cancer like immunotherapy agents, taxanes, platinums, the CDK4/6 inhibitors which cause QT prolongation, tamoxifen which it can cause thrombotic disorders, aromatase inhibitors which can cause hyperlipidemia, and PIK3-mTOR inhibitors which increase hypertension, hyperglycemia, hypercholesterolemia, hypertriglyceridemia. So most of the treatments that we see in breast cancer, they already have multiple high risk factors. Regarding the long-term side effects, again there is class 1 recommendation that we need to monitor these patients with echocardiography, with ECG and with cardiology follow-up, and there also we need to risk stratify the patients as to whether they are high risk for long-term toxicities or not. So with this, we understand that cardio-oncology is a complex area with emerging data. There is emerging evidence for cardioprotection. Many patients can complete cancer treatment with asymptomatic falls in left ventricular ejection fraction. Patient issues are definitely more pills, but oncologist issues are less now in practice, and with imaging and biomarkers, we are more likely to pick up changes between the groups and how significant these are. With this, I thank you all for patient listening, and would be happy to receive questions or any communications from any of you. Thank you.
Thank you so much, Dr. Vivek, for your excellent presentation. Now it is the time to hear from our esteemed panel of experts. I'd like to request our panel of experts, Professor Shubham Maulik, to share his valuable opinion regarding these topics. In short, due to time constraint.
Yeah. Thank you very much. I must congratulate both the speakers, Dr. Grace and Dr. Vivek Agarwala, for nicely summarizing the aspects. Dr. Grace has nicely summarized the various aspects of regional nodal irradiation, especially when to irradiate axilla. and the issues of internal mammary nodal radiotherapy, because we know that practice is heterogeneous. Many centers, they do internal mammary nodal radiation regularly. Few centers, they do not until unless they have a gross disease in the internal mammary nodal chain. So she has summarized both the aspects very nicely. One another aspect is there in the era of extreme hypofractionation treatment, whether it is safe. It's probably the next trial we should look at, that whether it is safe to give extreme hypofraction to nodal for nodal radiotherapy. And we know that radiotherapy and other aspects like chemo and baseline patients' health, there are issues of cardio-oncology, and Dr. Vivek has elaborated all the aspects of cardio-oncology, and I thanks to both the speakers.
Thanks to both of the speakers. And we know about the lymph node radiation in the axilla. Actually, the previously we go for radiation therapy in the axilla if there is the axillary lymph node more than 3. Then come to, if it is 1, then treat it to for the irradiation in the axilla. And in the hyperfractionation schedule, the axillary irradiation is very complex and troublesome. So we are going for the future for this thing. And the cardio-oncology is a very important thing. And so that in my center at United Hospital, in mastectomy patient in the left side, we are going for DIVH, deep breath inspire technique to minimize the dose of the heart. So thank you both of these speakers again.
Honorable President of BSBCS, Professor Kamruzzaman Chaudhuri sir, and dear audience, Assalamu alaikum. We know that breast cancer is a systemic disease. Its management is multifactorial, multidisciplinary, and also individualized for each patient. For modalities like surgery, radiotherapy, chemotherapy, or immunotherapy, more or less required for all of the invasive breast cancer. Axillary lymph node dissection has a long tradition in breast cancer therapy and was reported as early as 1907 by Hasselt. Axillary lymph node dissection usually the removal of 10 or more lymph nodes located mainly in level 1 and 2, and has the advantage of reliably identifying nodal metastasis, nonetheless is associated with significant morbidity. The impact of axillary lymph node dissection on survival has long been disputed. The 25 years finding of NSAB B04 trial failed to show a significant survival advantage from removing occult positive node at the time of initial surgery, but meta-analysis demonstrated a benefit. Thus, axillary lymph node a long time standard for positive lymph nodes. This changed with the publication of Z0011 trial, where no distance were found between axillary lymph node dissection and no axillary lymph node dissection observed after positive sentinel node. On the other hand, differences were found between axillary lymph node and no axillary lymph node after positive sentinel node. On this basis, regional node irradiation is a crucial part of adjuvant therapy in patients with lymph node positive early breast cancer. Data from MA20 and EORTC 2922 trial have been proven that the addition of supraclavicular and internal mammary lymph node region is effective in improving regional and distant control as well as disease-specific mortality compared to the whole-breast radiation or the sexual irradiation anal. Furthermore, result from the URTC 10981 MROS trial revealed that the axillary radiotherapy to level 1 to 3 after positive sentinel node biopsy provide excellent axillary control for patient with T1 to primary positive sentinel node positive tumor, even when axillary node is omitted. In the last decade, tremendous changes occurring in the radiation oncology, with several new radiation techniques being employed, routinely used to breast cancer patients. However, with the establishment of city-based treatment planning and precise radiation techniques, definition of nodal target volume has nowadays become the weakest part of the quality chain in lymph node radiotherapy. In order to minimize these uncertainties, contouring atlases were published in 2009 by RTOZ. On the other hand, cardiology-oncology focuses on the detection, contouring, and treatment of cardiovascular disease occurring as a side effect of chemotherapy and radiotherapy. Both the treatment modalities can cause cardiac dysfunction, a major cause of mortality and morbidity to the oncology population. It is necessary to periodically monitor cancer patients under the treatment, especially those receiving anthracyclines and trastuzumab, using mainly 3D echocardiography to calculate the ejection fraction and to estimate the myocardial dysfunction. Additionally, measuring the appropriate response to potential cardiotoxicity. In this regard, cardiological assessment before starting cancer treatment essential and should be continued throughout, and since cardiac dysfunction can occur anytime, even after years after the therapy onset. High-risk individual, in particular, should receive a detailed management plan in the collaboration between an oncology and a cardiology specialist. In these perspectives, both the speaker delivered their lecture on their related topics. Thanks the both of the speaker for their excellent presentation, and thanks the moderator, and thanks to audience.
Finally, I would like to request our Honorable Chairperson, Professor Debnarayan Dutta, to share his valuable opinion regarding these topics.
I thank both the speakers for their excellent presentation, and thanks the panelists for their opinion as well. Thank you.
With this, we are at the end of this session. Thank to all for your active participations and patience hearing.
Thank you, Dr. Mohammad Estefsar Hussain. Now there would be a little crest giving ceremony. I'd like to request Dr. Paul Mainwaring to give the crest to Dr. Grace Kusuma with Jaja. Thank you. I'd like Dr. Paul Mainwaring to remain on the stage to give the crest to Dr. Vivek Agarwala. I would like to request Dr. Paul Mainwaring again to remain on stage to give the crest to Professor Dr. Debnarayan Dutta. Thank you. Now I would like to request Professor Dr. Parveen Akhtar Banu ma'am to give the crest to Dr. Muhammad Rashidun Nabi sir. Thank you. I would like to request the Professor Dr. Parveen Akhtar Banu ma'am again to give the crest to Professor Dr. M. Nijamul Haq. Now, thank you. Now I would like to request Professor Dr. Mofajul Hossain sir to give the crest to Dr. Shumon Mollik. Now I would like to request Professor Dr. Debnarayan Dutta to give the crest to Dr. Mohammad Estefsar Hussain, moderator of this session. So that concludes the session, and we are requesting the audience for a 20-minute short tea break. After sharp at 6:15, we hope to start the next session. Thank you.
I would like to request all of you to having seat here and for our current to join our current session. The session is based on precision oncology. You know, precision oncology is the most in thing today for the last couple of years. It has been taking a major role for making decision and tailoring the treatment options for the management of breast cancer also, particularly for the advanced breast cancer management. Now, I would like to request Professor Parveen Akhtar Banu, being a chairman of this session, and Professor Kaji Munju Kader, Professor Syed Muhammad Akram Hussain, Professor Abul Ahsan Didar, Professor Estashamul Haq for being expert of panel in this session. I'm requesting them, having seat, please come to the dais. Now I would like to request Professor Dr. Paul Mainwaring. He will discuss about the role of antibody drug conjugate ADC in breast cancer management. He is the co-founder, CEO and chairman of Jing Technologies. Also, he is serving as associate professor in University of Queensland, consultant medical oncologist, Icon Cancer Care. I'm earnestly requesting him to come to the dais and deliver his session.
Good afternoon, everyone. Thank you to the organising committee for inviting me to give the graveyard talk. We have been here for 6 hours. We have been fed and we have been watered. And I'm going to talk about a topic for which the financial toxicity is unacceptable for a country like Bangladesh. But that doesn't mean that we shouldn't understand the principles behind these new drugs, because competition is going to allow more drugs to be available and to drive the price down. So you have already heard today some of the data about Enhertu, sacituzumab govitecan. So I'm just going to focus on some of the elements that are slightly outside the clinical realm and give you some hope that there are more drugs coming to bring for our patients. So you can understand that given the excitement of the clinical results, that the pharmaceutical industry is on full steam ahead to deliver not one, not two, but dozens of these new drugs. So in breast cancer, I'm just going to focus on the ones that are clinically relevant now, but also the ones that are coming in 2023 and 2024. So you're all familiar with their structure, so let me just focus on a few points you may not be familiar with. And if you're interested, there is a terrific review. The first author is Colombo in Cancer Cell several months ago. So as you can see here, the linkers between the antibody, which is typically an IgG1, and the cytotoxic, which is typically a myoansitoid or an irinotecan derivative, this is where the patent lies. This is where the different pharmaceutical companies are arguing still in court about who owns what. And the reason that that's important is that the cleavage of the drug predicts A, the sensitivity in the tissue, B, the longevity of the drug in the circulation, and C, the toxicity. So when we look at how the payloads are displayed, you must think, yes, there are 3 or 4 or 8 cytotoxic molecules there, but are they all going to be released in the tumour? Or, as one of the drugs, 90% of it is released in the circulation before it gets to the tumour. So this is going to predict where there will be battles between the pharmaceutical companies for supremacy in efficacy, but also the troubles that we face in terms of managing toxicity. So there are only a handful that are currently approved and in the clinic. But be aware that these are serving as the diving board for the future drugs. Now, one of the naughty stories that you're going to hear from the drug companies is that the number of molecules of chemotherapy agent attached to the drug matters. Unfortunately, that is a simple marketing tool that is not borne out by science. If you look at how these molecules are designed and you do some very clever pharmacology that we all learn at university, you can actually see that the amount of drug delivered per molecule is equivalent to what if you were giving the drug intravenously. But it's that linker sequence and how quickly it is released and where it is released that has all the importance. And why is it important? Because of the bystander effect. Enhertu lasts in the blood for over 7 days with its alpha half-life. And that is because it is attached to albumin and only very slowly turned over. So these elegant diagrams, which Nick presented earlier, and you've seen multiple times before at meetings, talk about a theoretical concept developed by Paul Ehrlich in the 1910s about the magic bullet, the silver bullet. But these drugs are metabolized not only in the tumour, but also in the blood, in the high volume tissues like the liver, giving you your liver toxicity, in the lung, giving you macrophage stimulation to cause pneumonitis, in the kidneys, giving you potential renal toxicity. So as you start hearing about these drugs, please inquire more about the mechanism of action, the construction, and arm yourself, pun intended, with that information. So we've heard a little bit about HER2 biology today, but HER2 biology is much more complex than we have been trained to know. It was originally described by Dennis Slayman in the New England Journal of Medicine because they found an abnormal protein, and then Roche bought the drug off Genentech, and the only way that they could describe, hello, we've lost, oh there we are, describe the amplification of this segment of chromosome 17 was using FISH and then KISH and then DISH. But there is much more complexity in the amplification and the different types of HER2 overexpression through enhancers, super enhancers, short cis and trans or nearby and long range control of expression of the mRNA that leads to the protein production. And indeed, post-translational modification, such as phosphorylation and glycosylation of this molecule, has a profound effect on its activity and its druggability. Nick was talking about the complexities of HER2 biology and how even when you have a panel of international experts, there's only 70% agreement on immunohistochemistry. Hopefully, pattern recognition by artificial intelligence has shown extraordinary 98% correlation, and that may remove some of it. But the group from Boston have been publishing enormous number of publications in the last 12 months about HER2 low. HER2 low is a convenient expression because Daiichi AstraZeneca have not found a better companion diagnostic that could meet the timeline for approval of the drug in the clinic. And so we must be very, very cynical about the activity of this drug and correlating it with HER2 low. What we do know is in the laboratory, in the mice models, as well as in vitro, they saw activity irrespective of the HER2 expression, and that's why they're trying to increase the market size. So TDM1 is what we'll call generation 2 of these molecules. You can see that there are 4 of the cytotoxic moieties attached, most on the constant domain, with 1 on the variable light chain domain, and they have this highly patented linker sequence. And Catherine was a revolutionary study looking at the benefit of TDM1 versus trastuzumab after neoadjuvant therapy. The survival curves separate early, they separate well, and there is a meaningful reduction in distant recurrence, local regional recurrence. And indeed, somewhat surprisingly, it's the HER2 negative patients after treatment who continue to get benefit. So this is a much more complex story about understanding the internalization of the overexpression of this protein, then we're led to believe in the clinic, us reasonably simple medical oncologists. Trastuzumab deruxtecan, or Enhertu, is our favourite molecule at the moment. It has demonstrated extraordinary clinical activity. It has a really interesting 4-peptide, tetrapeptide cleavable linker that is going to keep Daiichi in good money for many, many years. It has a high level of payload, but not all of those cytotoxic moieties are released evenly. Indeed, you can clearly demonstrate 1, 2, all the way up to 8 from the same dose in a mouse model into the cells. So it's quite challenging to say it's a higher payload when that's not what the data shows. So why are we excited? Because in the phase 1b study, heavily pretreated patients, 60% response rate. And in the updated analysis for duration of response, it was 18 months. Median progression-free for survival in these heavily pretreated patients was 18 months. And more impressive was the waterfall plot. In a waterfall plot, the baseline, the middle line is 0. There's no progression of the disease. And you can see even the patients who don't meet formal criteria for a partial remission all did well by having stabilisation of their disease, and that's what's most important in the clinic. And as Shinu showed in her JCO paper, even the patients expressing low levels of HER2 immunohistochemistry expression received benefit, and that drove the next paradigm of clinical trials. So, Destiny 3, head-to-head comparison. Big pharmaceutical companies, mano a mano. And what happened? A very early separation of survival curves. A highly, highly, highly clinically meaningful benefit. In fact, if you look at responses, PR and CR, plus 6 months stabilisation of disease, so-called clinical benefit ratio, something that we're used to talking about with ER-positive disease, 97% of patients received benefit. Now, the overall survival benefit is too small to demonstrate because of the statistics, but you can see clearly that if I can get my laser line between those two graphs, then it's going to be clinically meaningful. And if you look at the forest plot here, you can see clearly the benefit is across all the subtypes examined in the predefined criteria. Is this a miracle drug? Is this a cure for breast cancer? Well, it's not without its toxicities. And it's the interstitial changes in the lung that concern us most. And we need less expensive technologies to guide whether you're developing ILD rather than having repeat CT scans every 6 weeks. This drug is so important, or this class of drugs is so important, that this is the list of the top 10 abstracts presented at San Antonio in a couple of weeks' time. 3 are the Destiny trials out of the top 10. Pretty exciting. So if you are fortunate enough to find a patient who can afford to pay for this drug and you can get access to it, what are the toxicities you're going to manage? This is a highly emetogenic molecule. It hangs around in the blood for a long time. So you need all the anti-nausea drugs you've got access to up front, and please don't hold back on olanzapine if the others are not controlling it. Interstitial lung disease. You've heard this discussion before. It needs to be screened for aggressively. The patients need to be warned about it. They need to do incentive spirometry at home. And if you are at all doubt, stop. I'll say it once again. If you're at all doubt that the patient is developing signs and symptoms of pneumonitis, stop. Which is really tricky in the era of COVID and the recurrence of RSV, adenovirus, influenza in our community as we travel. For those of you who are interested about this, there was a brilliant review in The Oncologist just a couple of weeks ago. And it clearly details what to do, when to do, and how to do it. And the drug company has spent a lot of money with all of us working up on patient and doctor information leaflets. So why was Nick talking about HER2 before? Why was Don mentioning it earlier today? Because as you can see from these 3 papers looking at how HER2 biology changes under the influence of therapy, whether it be with endocrine-sensitive disease or without endocrine-sensitive disease, whether it's with high-level amplification and protein expression or high level of amplification and low level of protein expression, whether it's some of the complex biology of the amplification mechanisms. So it's quite a muddle that needs to be teased out. But having seen that activity in HER2 low, the Destiny group have designed a series of ongoing clinical trials trying to push the envelope, increase the utility of this drug and improve patient benefit. So Destiny 4 was very, very exciting. We heard some of the data earlier today, randomized Enhertu versus physician's choice. Most of the patients were on eribulin, which is an active drug against EMT. Capecitabine, nab-paclitaxel. Not a big fan of single-agent gemcitabine in this setting, but be that as it may, that's what was used by the physicians. And again, in HR-positive disease and in all patients, there was a clinically meaningful improvement in progression-free survival. The more controversial data, here's your overall survival data, is the exploratory analysis in HER2-negative disease. Please do not think this drug works fabulously well in HER2-negative disease. We need to understand what that definition was, what made up those patients in that group, because it defies definition. If you're triple negative or HER2 very low, why are you getting such dramatic results? Look at the numbers on the bottom of the table. Oh, in order to make it easier, I've taken away. There's only 40 patients. Okay, this is a tiny amount of evidence. This is hypothesis generating, yada, yada, yada. So keep your eye out on Destiny 6. This could change breast cancer management forever. Chemotherapy naive patients, increasing the proportion of patients amenable to therapy to over 70 or maybe up to 85%, depending on the population you're dealing with. The principal investigator for this study, who's a close personal friend, is under enormous pressure to make sure we get it right. So what about resistance? What do we know about these drugs? Well, we can see that cancers are clever. They upregulate other mechanisms of escape. We know topoisomerase 2 and RAD21 are on the same amplicon as amplification of HER2, just down the road from TP53. We know they can change their zinc fingers, which are transcriptional regulators, to upregulate for survival. So the question is whether you can add a DNA repair enzyme inhibitor called an ATR inhibitor. Preclinical evidence suggests that you can. You can lose your HER2 gene amplification. How? Taking out those clones but leaving some maybe triple negatives behind. So you also saw some data on the breast cancer with metastases. So these patients had inactive, stable brain metastases, and we saw responses in Camilla and in Destiny 03 in the comparison. But this was retrospective subgroup analysis, hypothesis generating, not ready for prime time. So Tuxedo. And Nancy was overwhelmed. Every patient that they treated had stable disease or responded. So much so that the Twitter sphere went crazy the night that she presented this data. It's a revolution for these poor women suffering the terrible trauma of cerebral metastatic disease and potentially leptomeningeal disease. So the Begonia study started exploring the next generation. Well, we've got PD-L1, PD-1 inhibitors. Why not throw them in with a TDXD? We're going to have the unbridled problems of the early 90s when it's soup, throw it all in together. But the efficacy showed that these two drugs work well. There's no new toxicities, and it worked irrespective of PD-L1 status. Tulip, this is one of the other new drugs that's coming along, again showed a modest improvement in progression-free survival, but has significant retroorbital eye toxicity, and I don't think it will last in the clinic compared to the drugs we've got. Anti-HER3 drugs are coming. Patritumab deruxtecan is a very, very powerful drug. So we now have an arms race. We'll quickly go to look at TROP2, just to mention that it's a transmembrane protein, just a bit like HER1 and HER2, but it's more involved in epithelial mesenchymal transition and talking to the stroma. It's broadly expressed across all molecular subtypes that you heard from Nick. You've seen the ASCENT trial, you've seen the data, you've heard Hope Rugo talk about the survival benefit, modest as it is. Tropics 2 will read out very soon in full format at San Antonio, but they too are looking at combining sacituzumab with immunotherapy in a variety of settings, and indeed presented the data of the NeoStar in patients with neoadjuvant treated, had 4 cycles of sacituzumab. I wasn't impressed by the results, but it was a pretty brave clinical trial, and I think when Don talks about them being volunteers, they certainly were powerful volunteers. Dato-DXd, another TROP2, but now with the Daiichi AZ linker sequence. It too, in Tropion-1, showed dramatic improvements in results with long, what we call swimmer's plots. So it will go head-to-head against sacituzumab. LIV-1 is another target that you may not be familiar with, heavily expressed across the spectrum of breast cancer in over 90%. It has a very powerful role interacting with Vimentin and some of the other powerful molecules that drive epithelial plasticity. And in the initial phase 1 study, it showed activity. So ladies and gentlemen, we're looking at a new era of the magic bullet therapy predicted by Paul Ehrlich over 100 years ago. It will be a complex biology to get our head around. It will be a complex toxicity for us to manage the patients, but hopefully they will all benefit. Thank you for your attention.
Thank you very much, Professor Paul, for your vibrant presentation. We are really delighted. Now I would like to request Dr. Sevanti Limai for her next presentation. The topic is Precision Oncology Application, the future is now. Dr. Sevanti is currently positioned as Director, Medical and Precision Oncology, Sir H.N. Reliance Foundation Hospital and Research Center, Mumbai, India. Please have a nice speech.
So while they're connecting, I'll just start off in the interest of time. So I'm Sevanti Limai, and a big thank you to Dr. Arif Rahman, Dr. Arunangshu, Professor Chaudhary for inviting me for this talk. And it's a huge honor today to be speaking to the Bangladesh. It's my maiden visit, and right after Dr. Mainwaring, I am completely in awe of his talk, and it was an enlightening talk. I am at best a community oncologist, so far removed. My talk is going to be far removed from what we just heard. So I'm here today to talk about precision oncology application. The future is now. And we just heard the talk, and you have ample message coming through that talk that we have to learn and apply. And even though I'm wearing pink, I am not going to talk about breast cancer. So that's going to be a little bit of a switch from what you are attending. And hopefully I will be able to retain your attention, because this crowd may be seeking breast cancer discussions, and I'm actually going to pull in all kinds of cancers here because of what I said. I practice precision oncology And I identify myself as a solid tumor oncologist. In my previous life, I used to be early drug development person, a phase 1 person, head and neck, lung, upper GI. But prior to that, during my fellowship, very much a breast follower. So, you know, this man is leaping from past to future. It could have been a woman, because I identify with that. So I put up this picture because I feel we need to, in the community, and this is, I'm appealing to the general oncologist who practices in the community, who feels the limitation of the subject. But that's how we have to go about it. And I say this often, probably the science of precision is not going to be perfected in my lifetime, but what we could do today with an imperfect science and imperfect testing and imperfect application of therapy is what we are setting out to do, and that's what we have to achieve. All right, so this is me, and these are my disclosures. Just pressing that. Okay, I think I'll just go with this because we don't have time. So very recently, I wrote an article to the same effect in the Times of India. And in this article, I said the future of cancer care. But as we look at the applications that were just discussed, if you miss out on that, you really are missing it in real time. So the future is actually now. You have to really watch out and look at the application. So I also have a HER2 story, and I thought I must say that. When I was a resident at Sloan Kettering Cancer Center way back in 2002, 2003, my first project, which was totally bewitching, was a 2,000 patient data collection on HER2 positive patients, where this drug was really transforming the end result outcomes of these patients, and that was trastuzumab. Fast forward to my first faculty position at Dana-Farber in Boston, where my first project that was given out to me was HER2 positivity in salivary duct cancers. And this is a small publication, one of my seminal ones, where we looked at HER2 positivity in salivary duct cancers, and those salivary duct cancers that are HER2 amplified actually have similar results as breast cancer and have patients who are with advanced disease who are surviving the disease on trastuzumab or HER2-directed therapy. And then this, one of my seminal cases where an advanced head and neck patient with oropharyngeal cancer was found to have HER2 positive disease or HER2 amplification, and we gave trastuzumab to this head and neck patient in 2009 when a 40-gene panel had just come out as a part of a research initiative at the center. And it was transformative because you changed the outcomes of the patient by giving a drug that was never thought of in that particular disease. And you see the outcomes really revolutionizing cancer care. And this wasn't just one case. Through the Early Drug Development Center, things were happening in lung cancer. ALK was coming through, ROS was coming through. You saw these patients heavily pretreated with disease everywhere, brain, bone, liver, what have you, and the disease transformed by giving these drugs that were very, very pathway specific. Then comes fast forward into NCI match, and I was selected to be one of the chairs of one of the arms of this study. That was arm B, where again the HER2 pathway, HER2 mutants other than breast cancer. So we're not talking HER2 amplification, we're talking HER2 mutation, and how a drug that was till then thought to be a lung cancer drug was utilized, afatinib was utilized in this particular arm to see if HER2 mutation would respond to afatinib. And NCI match, as you know, is one of the most ambitious seminal efforts in precision. I don't say that it was actually foolproof, and today you have many a criticism for how it was designed and how it should be done and things like that, but it was one of the most ambitious efforts in the precision world, where you saw pathway-directed therapy in heavily pretreated patients, where you did not expect the pathway and you utilized a drug outside of a particular organ system in another organ system, many, many times organ agnostic. So why hasn't precision come into focus? Why hasn't precision made it into frontline therapy? Why isn't precision the only thing that all of us are practicing? That's because I think, and this is a known fact, and this is actually a slide from Accenture presentation, unfortunately, it is one of the areas where we get highest therapy failures. 80% of oncologists believe precision will be an important clinical environment within 5 years, but if you really look at the representation, only 14% of physicians come to molecular tumor boards. 18% are actually routinely used in clinical trial decision-making, and 40% of therapies are actually leading to failures due to genomic alterations. So what is happening in India, and I can probably equate it to what may be happening in Bangladesh, we are just learning to organize ourselves. We are just learning what is the pathway-directed therapy, what are the guidelines. So this pile is now becoming this pile. And then precision wants to bring it all together, because you're learning from breast and bringing into GI, and you're learning from breast and bringing into lung, and you're learning from lung and bringing into head and neck, and it's all a hodgepodge. So you don't know where to wear the sock. You got to wear it in the foot, or you're going to wear it on the head. And that's a challenge I face every day. What about the organ-agnostic pathways? You talk about RET, you talk about NTERK, you look at MSI high, you look at TMB. Where are you going to apply that? Are you going to keep the TMB for where it was initially described, like the colorectal cancer, or are you going to bring it in a sarcoma patient, or are you going to use it in a lung cancer patient? You know, the pathways are intermingling, and it becomes very confusing for most of us who are trying to do simple oncology application of these pathways and these techniques. And then comes this whole thought process from 2020, the cancer moonshot, and the avalanche of immunotherapy and the biomarkers. And I put up this slide because this is one of my patients, one of my initial patients who was treated with immunotherapy way back in early 2000s. This patient, when I was beginning to take over this patient, refused chemotherapy, advanced squamous lung cancer with a Christmas tree pattern of metastasis. The patient refused chemotherapy. Now, we all talked about a year and a half of survival. This patient went all across Yale, Columbia, MSKCC, Dana-Farber, saw everyone, and then came back to me for treatment, said, I am only going to take immunotherapy. I got a call from one of the leaders at Columbia. I said, Sivanti, this patient is not going to respond to immunotherapy because it has no biomarkers for immunotherapy response. The patient got 4 doses of immunotherapy drug, developed pneumonitis, almost got admitted, we didn't have to, recovered from that, remains disease-free even today. So imperfection of biomarker accountability is also a reality, and that really shakes us up. What are we really following? What are the biomarkers that we are supposed to pursue? And then, of course, there's lack of data. Is the data, or all the data that we are getting from the West, can we apply that here? Do we have our local data? Are our patients going to respond the same way as we expect the responses and the results coming out from the West? And then, of course, this is a slide from my guru, I say Dr. Razel Kurzrock, where it is, genomics is just the tip of the iceberg, because we are still discovering many, many layers to cancer behavior. When we talk about the layers, I'm just beginning to understand a lot of these terminologies. leave alone the application. Then I go back to the precision trials and also the heterogeneity of these trials. Some trials are using some kind of biomarkers, the other trials are using other kinds of biomarkers, and there are trials that are evolving. None of these trials appear to be using all of them. Then there is a seminal trial from India that comes in and looks at all these put in together, which I'm going to show in a second, sorry. And then there is this iPredict study, which I follow a lot, where they used another type of calculation, something called a matching score, and showed that if the patients had a match to 2 pathways or more and got 2 pathway-directed therapies, they did better. So this is just one example of how precision is being understood and applied by some of us. And this field appears to be still evolving, where we are trying to understand how to really apply the pathways that we discover in the multitudinal tests that we are doing in our patients. When we get into each patient is special, and we know that in precision. When we get into the results of each patient, are we catering to that particular patient? What about that one patient? What about N of 1 application? And that's what, if precision is being practiced to its reality, is it N of 1 that we are pursuing? Then comes in drug sensitivity and the fact of tumor heterogeneity. All of us deal with tumor heterogeneity all the time. I have been a part of certain studies. In Colombia, there was a master regulator gene by Andrea Califano, and then there was this reverse engineering with mouse avatars and cell cultures, and where are these today? Do we have the PDX models? Are they ready? Does it address tumor heterogeneity that we see all the time in our patients? How do we address these issues? Is there a trial, and this is the trial that I was talking about, multi-analyte testing, chemosensitivity included, genomics, transcriptomics, and proteomics, all of that within India, 150 patient trial. And if you see here, this is a patient who received chemosensitivity-based chemotherapy. Pemetrexed is never given in head and neck cancer, and 2 pathway-driven drugs. And you can see the result, a picture's worth 1,000 words. Lastly, the message that came out in one of the recent publications by the leaders in precision oncology, cancer, an ever-evolving disease, a 9-headed hydra. And the group that published this also published this, where blind man and the elephant, where each of us, when we assess a cancer, we may actually be studying that patient from what we looked at, from what we got, and not actually what the patient is. And when we have such a big heterogeneous presentation, how do we put it all together? And that's why I said imperfect science, and probably not going to really become perfect in my lifetime, but what am I doing to try and get a control of this? So this is the structure that I follow. I've established a precision oncology center where, as a community oncologist, I'm trying to really piece it together for myself and the people who work with me. So we have a precision clinic. We have genomic tests that we do with lab partners. We have rare tumor clinics where we understand the rare tumors a little better. We have pediatric precision clinic. We have clinical data gathering. We do our own molecular pathway curation, hereditary genetic counseling, and then we discuss our cases in multiple different tumor boards. I have weekly molecular tumor boards where the young leaders from Bangladesh have participated. Dr. Arif has joined in to present his cases. Impact India International, I run a national, international level molecular tumor board, and I also am a co-founder of a company called ILON Precision Oncology with my good friend, Dr. Sendurai Mani from MD Anderson Cancer Center, which is a concierge service in trying to get more light onto certain very, very tough to treat cases in precision oncology. So the bottom line is we have to try and put it all together in this very, very complicated times. Not every pathway is HER2. And it's really heart-wrenching to see a lot of these patients coming in with truckloads of genomic information already done. I see patients in 3rd, 4th, 5th line, a lot of genomic reporting already done, but people haven't really applied because we don't know how to apply. And that's where I think it is time for us to come together and put our minds in unison for the application of precision oncology. Now I'll ask how much time I have.
Oh, you have remaining 2 minutes.
2 minutes. So I'll just show you some of my cases because I had plenty, but I don't think I will be able to show that. So this is a 50-year-old rhabdomyosarcoma, advanced rhabdomyosarcoma patient. Rhabdomyosarcomas are actually cases that we see in pediatric and young adults. So a 50-plus-year-old doctor in India, a general practitioner, sees 200 patients a day, if not more. Comes in, advanced disease, and this is the sequence that has been brought in. I don't know. I presented this case, multiple tumor boards, couldn't really get an answer. While researching, I found an article by Vivek Subbiah and the same group, Razelkar's Rock, and similar pathways. You have CDK4 and you have FRS2. And if you go back to the previous slide, you have the same thing. And so this patient, their patient responded to lenvatinib and palbociclib for 51 months. I didn't give my patient immediately the therapy, but after 3 lines of chemotherapy failure, the patient comes back to me right now responding to both lenvatinib and palbociclib titrated together. This is a patient, multiple lines of therapy failure, triple-negative breast cancer, everything given, including immunotherapy and chemotherapy, which you know only 1% of developing country gets. But this patient found to be EGFR amplified, 46 copy numbers, and treated with EGFR inhibitor, a mAb. Nimbutuzumab is available in India at lesser cost, and gefitinib. And you can see that now it's completely dried out, even better than how this picture is looking. And this is a case of an advanced adenocarcinoma stomach that came to me on workup, and hearing the story, it appeared she was BRCA positive. And she came with multitudinal nodules, inflammatory nodules all across the body. On examination, she presented to me as her recurrence of breast cancer was presented as triple-negative breast cancer, but she had a low hemoglobin test, advanced gastric, and BRCA positive, MSI high. Treated her with chemotherapy, immunotherapy, but then in maintenance, do you give an olaparib or do you give an immunotherapy drug? Continue the immunotherapy for maintenance. And what do we find? MSI high, irrespective of what caused it, you could still respond to immunotherapy. This patient, 2 years later, is completely fine. And so this is how she looks now. 2 years later, all of disease gone. The BRCA was definitely contributing to the MSI high status, and the patient responded to maintenance immunotherapy and now off therapy as well. So what I wanted to tell you at the very end, and actually that is the message that I would want to leave you with, and for that I think I'll have to scoot over some of the slides. This is my last patient. So this is an oral cavity case with locally advanced disease, progressed through primary treatment. So surgery, progression while waiting to get radiation, started neoadjuvant chemoimmunotherapy, responded initially, progressed, sequenced him. If you see here, he has HRAS, he has EGFR, he has PDGFR-A overexpression, so not just genomics, but transcriptomics, proteomics, all of that utilized, including chemosensitivity. Drug was changed, the chemotherapy drug was changed, immunotherapy was continued, and a trametinib, lenvatinib was added at a low dosage. This patient had complete response, and this is post second surgery and prior to starting the radiation. A curative resection was able to be possible in this patient with precision management. So, what do we have to do? As practicing precision oncologists, we have to really build the basics. We have to think beyond the routine. We have to reimagine the medical education so that our teams that are coming up, the young generation that is coming up, really is motivated to detail analysis of our molecular pathways, is armed, is empowered to do that as we go along. Minimizing complexity, coming in together, look at each patient as a special case and piece it all together. Targetable mutations, other biomarkers, consider drug sensitivity testing, reverse engineering, because future is now. And at the end, I would say, are we slaying the Hydra yet? And in this, I just point out that this picture is gender balanced. There is a woman in there. So I started out with a picture of future is now with just a man, but you have, and that's actually a publication by Dr. Razel Kurzrock, and you see that the man and the woman are fighting it shoulder to shoulder to slay the Hydra. And that's what we have to do. I see many, many women here and more power and force to all of us. And with that, thank you very much for helping me share my story, and I hope I'll be able to motivate the crowd out here to practice precision as a science that is not perfect, is developing, but it could really help save lives, as we learned from the talk before me. If we don't really figure it out and apply, all the application is going to fall short, and we are going to lose out on lives that we could save. Thank you so much, and it's an honor to be here this evening.
Thank you, Dr. Sevanti, for your superb and lively presentation. I wish all of us enjoyed it a lot, and we are really motivated. Now, I would like to solicit Professor Dr. Devnarayan Datta for his next presentation. His topic is initiating a dedicated radiosurgery unit, lesson to share. Doctor, please come to the dais. Dr. Devnarayan Datta is chaired as head of the Radiation Oncology, Amrita Institute of Medical Science, Kochi, Kerala, India.
It is the last talk, so I will not take much time. But I thank Dr. Lime for giving the introduction for precision oncology, because that is the future, and I also agree with that. Where radiotherapy also is going to come and play a very important role, because precision radiation is also going to come. Now, actually, can you, how many people are young radiation oncologists here? Can you just raise your hand, please? Before anyway, how many are young radiation oncologists here? 5 years pass out is a young, 10 years pass out is also young. I'm still young. So, see, now how many wants to do radiosurgery? How many wants to do radiosurgery? Means precision radiation therapy wants to do. How many people want to do? Now, if you really want to do precision radiation therapy, first thing we need to do is leave treating breast, head and neck, gynae, GU/GI. Then you will have time for doing a precision radiosurgery, because it takes a lot of time. So first you have to have that passion to leave conventional radiation to some extent, so that you can focus on something really nice. And I think I'm going to talk about my experience, how we can start a precision radiation therapy unit. Now, before I joined Amrita Institute, I was in Apollo, and I have done radiosurgeries since 2006, and almost 2,000 patients were treated. Then I shifted to Amrita Institute and started the radiosurgery unit with that. And so we have seen the both side of the story, that when you start a radiosurgery unit without a proper backup and start a radiosurgery unit with a appropriate format, then how the difference in terms of your approach, in terms of outcome, in terms of patient selection, and in terms of response you get. Now, when I was there, when I joined Amrita Institute and started the dedicated radiosurgery unit, there is not many dedicated radiosurgery unit in India, especially from linear accelerator based. There's a lot of criticism that what people say that if you have a specialized units for radiosurgery, for breast and gynae, for head and neck, for GI, you may lose patients because then the referral patterns is going to change and you may not get that many numbers. People who are doing very specialized work may not have that many number of patients to treat. And these are the concerns the management also had and all our radiation oncologists had, because they didn't want to leave a lot of their conventional radiation part to get involved in high precision radiations. Now, but interestingly, I joined in 2017 Jan, and when we did the analysis for first 3 years, we saw that actually the new patient numbers are increasing. Though we have made a specialized unit, head and neck, GI, breast, radiosurgery another unit, but the numbers are increasing, not decreasing. In the first 2 years, we have treated around 500 patients with CyberKnife, but first 3 years, and then next 2 years, we have treated around 1,200 patients with CyberKnife. So actually, the patient numbers increase because the outcome is shown, and when you're doing in a prospective setting, then actually it helps to get. So the concept that if you focus your work, you may lose patients, that is not true. Now, when we analyze the number of patients coming from different places, we saw that 85% of our patients are coming within 100-kilometer radius, and that should be the practice. So it is not that patients from Bangladesh, from Oman, or people are coming for treatment. It should not be the right approach. Right approach should be that within 100 kilometers, they should constitute around 70-80% of the patients. The best thing is, if there is something like COVID, still your numbers is not going to go down, and it is going to work. And only the patient is going to refer more patients because of they had got the response for the treatment, not because of a promotion work. So we don't need to have any kind of promotion work if you concise that on the 100 kilometers patients are coming, and only 5% of our patients are international patients. That is something new and interesting, and that is very sustainable model. Now, this is the state-wise, and most of the patients were coming from Kerala, and when we did the treatment, and very small proportion of patients were coming from outside. Now, when we saw our radiosurgery numbers, from 2017 we started the dedicated radiosurgery unit, every year the numbers are increasing, and that is increasing because the confidence of our referral doctors who are in our own in-house, they actually are increasing, and so we are able to perform, and that has to be the concept of having any kind of dedicated unit. Now, interesting thing is that if you see in 2020, there's a dip in neuro patients because the benign tumors we didn't treat that time. So benign tumors, we had an option of postponing for 6 months, a year. We did that, and that is why there's only a dip, but extracranial side there's not much dip. So still those patients were very aggressive, and we treated that time even in the COVID period. So our numbers didn't decrease during the COVID period as well. Now, interestingly, we have done an audit of all our brain metastasis patients treated in our hospital from 2017 onwards. And we have seen that number of patients treated with brain metastasis, whole brain radiations, SRS, hippocampus sparing, all together, you see that numbers actually increased over the period of time. And there is a significant surge when we had a radiosurgery unit. So they were evaluating more number of patients, and the number of patients, because we have the facility, they are getting treatment. Both in whole brain radiation and both in radiosurgery, numbers were increasing. Now, when we saw the number of patients treated with radiosurgery and whole brain radiations, see, if you see the last 2 years, in 2018, still more number of patients were treated with whole brain RT compared to SRS. But in 2021, you can see actually it is almost same or a little more. The SRS numbers are more. So the practice is becoming like a West where the radiosurgery is the norm in brain metastasis, it has been practiced in our facility because we have the radiosurgery facility available. So when the patient comes for the treatment, we are able to provide them the treatment in a very short time, not a long waiting time. And we are seeing those patients early. So this is something really interesting, and 25% of our patients are brain metastasis. In abroad, all the publications in any radiosurgery unit, 30% of the patients are brain metastasis patients. So that is almost similar. So we are slowly going towards a Western type of treatment approach, which is happening in a more standard approach. Now, how we streamlined the department? We had a site-specific unit. We had made it all consecutive patients we put in a protocol setting so that we have the outcome data for all our patients. We have a protocol-based treatment, so all patients are getting same dose, same PTB volume, so that we can evaluate those patients properly. We have a new innovative research questions, and we have made a protocol for that. There are some randomized studies, we are going to talk about it. We have an outcome of all our patients. And it's not that we have done always right. There are so many times we have done mistakes as well, and we have taken the corrective steps when we saw that there is an issue and some patients having little more reactions, or maybe this patient should not have been treated with radiosurgery. We have taken to the tumor board, discussed, and we have not hidden those patients under the carpet and taken all the patients who had complications as well. And we had documented in the publications all our records. So what is the result of taking those measures? Our clinical outcome-based approach has happened. We have increased expertise and acceptance for the treatment for our referral doctors, and we have increased improved in patient numbers because the acceptance is better. Always, we put a multidisciplinary approach. All patients are discussed in the tumor board. We put gastro people, we put medical oncology people, neurosurgery people into the loop, and they are also part of our radiosurgery treatment team because that is important. They also see the results. Sometimes if the patient is not doing well, they don't come to us, they go there. So we may not know the toxicity, but they will know. So once we see it together, we all can see the outcome and the toxicity together and take measures if it is required. So this is our team. It's a big team of med-onc, neuro-oncology, GEI, radiology, urology. So we have a team, and we actually drive the program, but everyone is part of the team, and that has to be there if a radiosurgery program has to be successful. This is our team. It is not only the doctors. Technologists are important, physicists are important, residents are important to document what you are doing and document and ensuring that treatment is done in right time, patient is not waiting for long, and contouring is done on right time. So they are also important part of the treatment approach. As we have sorted the team and sorted the approach, we are now treating around 30 to 35 patients in a month, around 400 to 500 radiosurgery in a month. 50% are intracranial, 50% of the intracranial are benign brain tumors, and 50% are metastasis. In extracranial, 30% of our patients are liver tumors, SCCs, and I'm going to talk about it, why it is 30%. 20% are oligometastasis, and a group of patients are from breast primary, and only 10% are extracranial, and you just will see the 3% is from prostate. So the prostate people are still not convinced with the SBRT for the prostate, and are doing robotic surgery for those patients, and there is still a scope of improvement in these areas as well. So we have a lot of academic activities done. We have 3 PhD students doing a randomized study. We have few ICMR projects. Randomized studies are happening. And that is how it is not only academics. We should have a cost-benefit analysis as well. We have done 2 cost-benefit analysis for the liver tumors, comparing tomotherapy versus CyberKnife. In tomotherapy, it's not only the treatment cost, it is the patient waiting time, the food cost, the revenue loss because they have to take leave. Considering that, we have seen that 30 gray in 10 fractions, in 10 days of treatment versus 1 day of radiosurgery for the brain metastasis, the cost is equivalent. So, as we discussed yesterday, that why we treat 24 gray single fractions for most of our brain metastasis to make the cost same. So, for the patient, the cost is not different, and we can deliver radiosurgery, and our cost for the treatment actually is been planned keeping the cost cost estimate same. We have a randomized study on different approaches. It is the brain metastasis, radiosurgery, only, not whole brain RT, and we have our own prognostication protocol, and which evaluated that Western patients and Indian patients, there is not much difference in terms of prognostications parameters. In single patients, we have seen that retreatment is possible in 80% of the times if you are able to do that. And our outcome is almost similar, and toxicity is almost similar, whole brain RT versus in our patient population compared to the Western patients. So the acceptance is improving, and we are seeing that we have our own fiducial placement criteria, and because the fiducial is required for the liver, and that is there. So we have our own Amrita criteria. We have put it so that we use, and that actually has done our acceptance. We have an excellent program on hepatocellular carcinoma with portal vein thrombosis, a prospective study base with 116 patients required. We have completed the study and also published it. And this actually gave us 30% of liver tumors for reduced surgery because the acceptance is more. We have seen that responders, the outcome is almost double than the non-responders. It is around 16 months versus 8 months in this group of patients. So it has given us some idea that you can have some novel ideas. We have a quality of life study happening in benign brain tumors, and memantine study, randomized study in brain metastasis to see the cognitive function assessment, and that is going to give us some idea on how we can do that. So to conclude, dedicated reduced surgery facility is possible in Indian subcontinent, but we need a team. We need to have an outcome-based approach. Research and prospective database collection approach has to be there. That should be the base for any kind of dedicated unit. And you need our own data. We cannot just follow the Western data always. So this is our team. And I welcome all of you for ISRS conference, which is going to happen next year, August, in Kochi, 24 to 26th August. Thank you.
Thank you, Dr. Devnaran, for your state-of-the-art presentation with real-time experience. Due to very time constraint, I am requesting all of the audience only to raise 1 or 2 questions. If there is any further queries, then you can contact with the resource person after completion of the session. Only 1 or 2 questions.
So it was a blast, Dr. Sionti. I want your attention. So your lecture was a blast. Thank you so much. You claim you as a community oncologist, but I know you do lung a lot.
Yes.
So I was just wondering, lung, a very dismal prognosis, but if you see lung cancer in the last decade, there are enormous development in the molecular targeting or biomarker testing, and the plethora of agents got approved. Okay. But in this contrast, breast cancer being the topmost malignancy in female, so the 50 years of ER&PR, 30 years of HER2, and the last decade, the ESR1, PIK3CA, PDL1, or BRCA. So do you think this molecular testing or targeting agent finding is quite under-evaluated for breast cancer?
Well, that's a great question, actually. So first of all, I went into precision because of lung. Because, you know, you see so many pathways and exploding that you have to really do something about it. Coming to breast cancer, I agree with you that the application of precision is still very limited in breast cancer, but the precision that you're able to apply actually has a larger bearing in breast cancer because the markers and the biomarkers are much better tested and validated, and as we saw just this evening. And also I feel a lot of pathways that are really not discovered that well because breast cancer has had such great biomarkers and such great outcomes that there hasn't really been a drive into what if and exploratory. But now I think a lot of work is happening in that area where I see other biomarkers emerging and TMBs and FGFR amplifications and rarer pathways that you would never think in breast cancer. So I would say where you have the marker, you really don't need to go into broad panel sequencing or beyond genomics. But where you don't have the marker and where you are struggling in a patient, In today's times, I actually wouldn't think. I would just do the testing because I think that's the most initial step. And I tell patients it's exploratory, which means our expectations should be low. But if you don't look, you won't find. And so a lot of discovery still needs to be done, especially in triple negative and especially in different ethnicities. I think we are really not, we are very limited with that. I mean, is triple negative cohort, large population, sequencing and beyond routine genomics in India and Bangladesh, is it the same as what we see in the US? Do we have that roadmap? Do we have that landscape? I don't think we do. So we absolutely need to apply and understand better, even in breast cancer.
Thank you
Thank
so
you.
much.
Thank you. And thank you for your question.
Thank you so much. Okay, have you? Huh? Okay.
We see cohort of patients, 200 patients, 100 patients. We have a sample size, and then we see the outcome, not a 1 or 2 patients. But unfortunately, in precision oncology with these targeted therapies, we see each and every patient differently. So it is very difficult to predict. You can only tell that may work. How you do that? Because is it not possible to do a similar kind of patient cohort with amplification, some kind of amplifications, and that cohort, how many patients are responding, how many are not responding? Then only we will be able to see that whether it is worth treating that patient, because 1 or 2 patients responding or non-responding does not make too much of a clinical.
So I agree with you. Actually, it is my limitation because I am practicing in a country, in a site where I don't have access to such cohort-driven clinical trial-related treatment where I could study these patients more. But I have, over a period of time, followed for my patients, I have followed the trials that I feel are most meaningful, and that's why I quoted iPredict and I quoted Resilient trial, where multi-omics has been applied, pathway-directed treatment has been applied, and there is a method to the madness. How did they do it in iPredict? They looked at each patient, but they presented each patient in a large molecular tumor board, which was run by experienced precision oncologists, medical oncologists who practice precision, as well as molecular scientists. And everybody got together to give out that verdict. So yes, I wish that this could be scaled very, very quickly and that there was a real homogeneous way to approach that we say right patient, right drug to the right patient at the right time every time. But where is that every time? Yeah, so that is a very big challenge in precision. But I, as an oncologist, I say even if that one application helps that one life, like the one that we were discussing, the EGFR amplification case, that's a single mother and the husband died of advanced head and neck. So the son is paying for therapy. For him, that mom is very critical and she has lived on. So that's how right now I'm touching lives, but I wish in the future, in the near future, we'll have much more.
Thank you, Shravanti, for a wonderful discussion. Now, I would like to request Professor Dr. Kaji Manju Kader sir to put on some valuable comments.
Thank you so much to the moderator, very honored chairperson, very learned speakers, my colleagues, dignitaries, ladies and gentlemen. Very good evening to everyone. So this session was really, really so fantastic that I could not express. As because Professor Dr. Paul, he has nicely delivered and shown us the antibody treatment in cancer management. And he also shown us the mechanism of action, and always we should keep in mind the toxicities and side effects of these molecules. Pulmonary toxicity, cardiac toxicity, and renal toxicity. So this is very good message for we people. And with trial based, he also cited the all molecules and recent molecules. But the future is ongoing. Thank you so much, Professor Paul, with humble submission. Second speaker, Dr. Sevanti Lima. Yes, precision oncology. After treatment, when patients there is recurrence, or when patient affected, on that situation, oncologist, what he or she will do. So there should be a precision oncology. And we should search the more and more pathways, genical expression, how can we get the remedy from such type of killing disease. So precision oncology is the very hot topic. Third speaker, Professor Dr. Devanayan Datta is known to us, and he has given his speech towards stereotactic radiosurgery, SRS and SBRT. Yes, on radiation therapy, we always want the treatment of the affected tissues, not to the surrounding normal tissues or critical organ. So, in the advancement of radiotherapy, nowadays radiosurgery is the best option. And nowadays we know that artificial intelligence, emotional intelligence, these are coming up. But oncologists should have think regarding the patient's situation and treatment precision and treatment effect. Thank you so much.
Thank you, sir. Now I would like to request Professor Dr. Syed Mohammad Akram Hussain, sir, to make some remarks of the
Thank you, Dr. Ruman. Honorable Chair, distinguished faculties and guests, good evening. Just this is a wonderful session. First thing, the precision oncology, the time is the era of precision oncology. And we listen almost 3 external presentations from the Professor Paul one, from ADC, particularly in the breast cancer. We know that actually ADC has a great role, and particularly he showed all of this to us. And particularly I want to add something for PRAP, for the breast one, as well as CDK4 and CDK6 inhibitors. These all also coming into the precision oncology. So coming up many other molecules in the coming days. So particularly one is sacituzumab for the triple negative breast cancer. It is one of the best one. 2 other molecules is particularly the trastuzumab deruxtecan and HER2. This is a wonderful molecule recently approved by the FDA. And we have already in our country one is Kersila, is supplied by the Roche in our country. So this is wonderful. Just thank you so much, Paul. Another Dr. Shivanti Limaya, she's wonderful, just wonderful. Her presentation is wonderful. Her discussion and experience for the Sloan catering, everything is so wonderful. Just amazing. So thank you for all your presentation. Just I go for another thing for the Dr. Devnarayan. Particularly, Devnarayan is really important because today is actually genomic adjusted radiation therapy time. So this is the time actually precision oncology with the genomic adjusted radiation therapy, because this is a new concept coming up. We have many trials actually international level, and this trial giving us some information regarding the genomic adjusted radiation therapy. Nowadays, we are regularly doing one thing in maybe 2 gray per fraction, like other fractions. But they have already some trial, and this is the LQ models and genomic adjusted radiation therapy. They have selected 10 genes for radiation therapy, and they already tried in the breast in other cases. So how much radiation is really required? So thank you, Devnaran, everybody. Thank you so much. Thank you.
Thank you, sir. Now I would like to request Professor Dr. Abul Ahsan Didar to make a small statement.
Thank you, Chairman, for this session. Thank you all the presenters. First, thank you, Professor Paul. He firstly uttered the word that when the people of Bangladesh will hear the price of this ADC, antibody conjugate drug, it is very toxic to the patient. But Mr. Paul, the scenario is changing. With the people is going to earn MDG. So inshallah we'll be able to use this drug. But the problem is that our oncologist or service provider should know about the drugs or its effects and other molecules. For the audience, it is a kind of a molecule where the three things, antibody, then linker, and then cytotoxic molecules or antibiotic molecules. This combination can make easier to penetrate a cell, to kill the cell previously which was not sensitized to that drug. Say HER2 positive, we are giving trastuzumab, but in case of negative, we cannot give any drug. But if we use ADC, then we can get a very good result. Number two, Professor Shayant, she said about the precision oncology. Precision medicine is a subject where the information from a patient's own gene or protein can analysis and get it used for the best option for prevention and disease control or management. And precision oncology is the part that from that tumor we can get the information of the genetics or NGS, and then we can treat more particularly to the patient. But one or two constraints, because the service providers have to know, have very good knowledge about the drug or this drug, precision medicine. Number two, the result, the laboratory facilities and the man behind the laboratory, behind the test should be very, very efficient, because if he give a wrong result, then the scenario of the treatment will be changed and it will be another disaster. Third, our radiation oncologist, Professor Dotto, he prescribed all the scenario of his institution. So I will request him to invite our radiation oncologist to his center and to give the update knowledge. So thank you all audiences and my professors and my respected teachers. Assalamu alaikum.
I'm requesting now Professor Dr. Mohammad Shamul Haq to add something, being panelist.
Respected chairperson of this session, learned speakers, faculties, and great audience, I should say, because at the end of the day, they are very engaging with us. So thank you all. I really wonder with the presentation of Dr. Paul Sevanti and Devanarayan Datta. So I will not go in details of their presentation, but I want to thank the organizing committee to include the personalized or precision medicine session in this year's event, because we are in the challenge with the generalized management of the cancer patient, but we have to think about the personalized manage of the cancer patient, and the obstacle we have, the laboratory facilities and the management of the drug, availability of the different resource, as well as the radiation availability resource here. So we have with us in the morning our Director General Health representative and Director of Cancer Hospital was also there. So I will request the organizer, they should actually tell the authority or the policy makers that for personalized as well as the generalized oncology management, we need much more government and public support, and I will request all of them to work to get success in the generalized as well as personalized medicine in oncology. We should work together. Thank you.
Thank you, sir. Dear audiences, now we are almost near to conclude our session. Before conclusion, I would like to request Professor Dr. Parveen Akhtar Banu ma'am to put some remarks about the three presentations and conclude the session.
Assalamu alaikum. Good evening, respected, eminent foreign and national speakers, guests, my junior and senior colleagues. Thanks for coming to this session. Thanks to the organizer for giving me the opportunity to chair this session. Thanks all the speakers, renowned speakers, for their very illuminating speeches. First, Dr. Paul Manwaring. His talk was on the role of antibody-drug conjugate in breast cancer. As you know, nowadays it has, come to the light more after, especially the Destiny trial, Destiny Breast 04 trial. And as we know that this is antibody-drug conjugate is a special class of therapeutics, and it is antigen-specific, carrying a monoclonal, carrying an antibody backbone with a drug payloads. That is antibody, some immunoglobulins, that is the linkers carrying the drugs, cytotoxic drugs, and the antibody to the cancer cells. And it also has some local bystander effects, as Dr. Paul has mentioned, and it initiates also immune reaction. So multiple activities initiates with this antibody-drug conjugate therapy. So nowadays, especially after this Destiny trial, everybody is, really thinking that previously we did not know what and how we should treat our low HER2 positive breast cancer patients, and especially FISH or D-dish negative and equivocal cases. So after this trial, we know there are drugs which can give very good, excellent response to this kind of, this group of patients. And there are other trials he showed with many novel ADC also. So this is a really hope in the horizon that we can treat more patients with not only HER2 positive, but also ER positive patients, and in all advanced breast cancer patients, there are response with ADC. So thank Dr. Paul for showing us all the details and many other trials. Next presenter was Dr. Sevanti Limaye, and his talk was very excellent. And as we know, the precision oncology, it is actually revolutionizing the cancer care, and that is the time demanded topic. And precision oncology, especially genomics and biomarkers and molecular pathways, we have to find out this for proper treatment and best outcome of our cancer patients. But we don't have the facility yet, like NGS and molecular lab. So we have to focus on that, and we have to wait for that. But we can take the help of our neighboring countries to have that molecular genomics study, and also guidelines about the further therapy and how to treat our patients where we don't get about 75% of cancer patients fails standard care therapies, as she has mentioned. So precision oncology is one of the very interesting subject, interesting area we have to focus, and we have to wait for the future of the, precision oncology and personalized medicine. And she also mentioned that cancer is an ever-evolving disease. Actually, it is. And in our lifetime, for the last 40 years, we have seen the evolution. So we are hoping for future. We are, looking for the better future, of course. So thank you very much, Dr. Sevanti, for your time-demanding presentation. And last, Dr. Devnarayan Datto. He's an eminent radio oncologist, and he has long time experience in treating the benign and malignant brain tumors and also other tumors, brain metastasis. This kind of treatment usually he is more focused, and he has treated a lot of patients in his previous center, as he has mentioned, and with CyberKnife, which we don't have, but in future we expect to have also that kind of opportunity and therapy in our country. And it is interesting to know that radio surgery, 1 fraction and 10 fraction, usually cost is same. Is it not, you mentioned? So I was thinking, if it is that, it is very good for the patient, that other costs of staying in near the center and all other costs also he or she can save, the patient can save. So it is very interesting, and he is doing his focused work in the neuro-oncology field. So thank you very much, Dr. Datto, for your nice presentation. Thank you very much for being here with us, and thank you all for this session. Thank you.
Thank you, madam. Thank you, all of you, for patience hearing. Now it's time for crest giving ceremony. So I would like to request the, okay.
Thank you, Dr. Rumma. Now is a little crest giving ceremony. I would like to request Professor Dr. Sheikh Ghulam Mustafa to hand over the crest to Professor Dr. Paul Mainwaring. Thank you. Now, I would like to request Professor Dr. Mofajul Hussain to hand over the crest to Dr. Sevanti Limai. Thank you. Now, I'd like to request Professor Dr. Nick Zednowski to hand over the crest to Professor Dr. Devnarayan Datto. Thank you. I would like to request Professor Dr. Nick again to stay at the stage to give the next crest to Professor Dr. Parveen Akhtar Banu. I request Professor Dr. Nick to stay, please, to hand over the crest to Professor Dr. Parveen Akhtar Banu, ma'am. Thank you. Now, I would like to request Professor Dr. Kamrujaman Chaudhary, sir, to hand over the crest to Professor Dr. Kaji Monju Kadir, sir. Okay, I would like to request Dr. Selim Raja, sir, to hand over the crest to Professor Dr. Kaji Monju Kadir, sir. Thank you. Now, I would like to request Professor Dr. Parveen Shahida Akhtar, ma'am, to hand over the crest to Professor Dr. Said Muhammad Akram Hussain, sir. Now, I would like to request Professor Dr. Parveen Shahida, ma'am, to stay on the stage and give the next crest to Professor Dr. Muhammad Ehtashamul Haq, sir. Thank you. Now, I would like to request Professor Dr. Devnarayan Datto to hand over the crest to Professor Dr. Abul Ahsan Didar. Thank you. Now, I would like to request Professor Dr. Said Mohammad Akram Hussain sir to hand over the crest to Dr. Mohammad Kamrujaman Rumman. So that ends our beautiful ceremony today. We hope you have all thoroughly enjoyed the informative and lovely discussions of the Bangladesh Breast Cancer Conference 2022 here at Pan Pacific Sonargaon Hotel. Please now join us for our cultural program followed by gala dinner. But now I would like to request the whole audience to wait for some moments before for the preparation of the cultural program. Thank you. Now I would like to invite on stage eminent singer Ajgor Alim, the son of eminent singer of Bangladesh, Abdul Alim, of whom no introduction is required. So we are inviting singer Ajgor Alim. Thank you.
হলুদিয়া পাখি সোনারি বরণ পাখিটি ছাড়িল কে হলুদিয়া পাখি সোনারি বরণ পাখিটি ছাড়িল কে কেউ না জানিল কেউ না দেখিল কেমনে পাখি উইড়া গেল হাই চোখের পলকে পাখিটি ছাড়িল কে হলুদিয়া পাখি সোনারি বরণ পাখিটি ছাড়িল কে পিঞ্জিরা শূন্য করিয়া কোন বনে পাখি গেল যে উড়িয়া সোনার পিঞ্জিরা শূন্য করিয়া কোন বনে পাখি আসে না পাখির শোকে পাখিটি ছাড়িল কে হলুদিয়া পাখি সোনারি বরণ পাখিটি ছাড়িল কে যদি ভুলে যাবি রে পাখি কেন তবে হায় দিলি রে আশা উইরা যদি যাবি ওরে ও পাখি কেন বাঁধা ছিলে বুকেতে বাসা কত না মধুর গান শোনায়া গেলি রে শেষে কেন কান্দাইয়া কত না মধুর গান শোনায়া গেলি রে শেষে কেন কান্দাইয়া তোমারে সরিয়া দুঃখের দরিয়া তোমারে সরিয়া দুঃখের দরিয়া উথলি ওঠে হায় স্বজনের চোখে পাখিটি ছাড়িল কে হলুদিয়া পাখি সোনারি বরণ পাখিটি ছাড়িল কে পাখিটি ছাড়িল কে রে আমার পাখিটি ছাড়িল কে হলুদিয়া পাখি সোনারি বরণ পাখিটি ছাড়িল কে পাখিটি ছাড়িল কে দোল দোল দোলনি রাঙা মাথার চিরনি এনে দেব হাট থেকে মান তুমি করো না দোল দোল দোলনি রাঙা মাথার চিরনি এনে দেব হাট থেকে মান তুমি করো না নতুন নতুন খোপাটি তুলে এনে দোপাটি রাঙা পিতায় বেঁধে দেব মান তুমি করো না দোল দোল দোলনি রাঙা মাথার চিরনি এনে দেব হাট থেকে মান তুমি করো না দেখো ডালিম ফুলে ওই জমেছে মন বউ কথা কও ডাকছে পাখি কয় না কথা বউ দেখো ডালিম ফুলে ওই জমেছে মন বউ কথা কও ডাকছে পাখি কয় না কথা বউ ঝুমঝুমে মল পায়েতে গয়না সোনার গায়েতে আরো দেব নাকের নলক মান তুমি করো না দোল দোল দোলনি রাঙা মাথার চিরনি এনে দেব হাট থেকে মান তুমি করো না তাদের সাথে নিত্য রাতে তারাই কথা কয় আপন জনা পর হইলে তাও কি প্রাণে সয় চাঁদের সাথে নিত্য রাতে তারাই কথা কয়, আপন জনা পর হইলে তাও কি প্রাণে সয়। একটুখানি হাসো না, কাছে এসে বসো না, আরো দেব রেশমি চুড়ি মান তুমি করো না। দোল দোল দোলনি রাঙা মাথার চিরনি, এনে দেব হাট থেকে মান তুমি করো না। নতুন নতুন খোপাটি তুলে এনে দোপাটি, রাঙা ফিতায় বেঁধে দেব মান তুমি করো না। দোল দোল দোলনি রাঙা মাথার চিরনি, এনে দেব হাট থেকে মান তুমি করো না। এনে দেব হাট থেকে মান তুমি করো না। এনে দেব হাট থেকে মান তুমি করো না। ও পদ্মা নদী রে সর্বনাশা পদ্মা নদী, তোর কাছে সুধাই বলা মারে তোর কি রে আর কুল কিনারা নাই, কুল কিনারা নাই, কোনো দিন কুল কিনারা নাই। সর্বনাশা পদ্মা নদী, তোর কাছে সুধাই বলা মারে তোর কি রে আর কুল কিনারা নাই, কুল কিনারা নাই, কোনো দিন কুল কিনারা নাই। পাড়ির আশায় তাড়াতাড়ি সকাল বেলায় ধরলাম পাড়ি, পাড়ির আশায় তাড়াতাড়ি সকাল বেলায় ধরলাম পাড়ি। আমার দিন যে গেল সন্ধ্যা হলো, আমার দিন যে গেল সন্ধ্যা হলো, তবু না কুল পাই, কুল কিনারা নাই, কোনো দিন কুল কিনারা নাই। সর্বনাশা পদ্মা নদী, তোর কাছে সুধাই বলা মারে তোর কি রে আর কুল কিনারা নাই, কুল কিনারা নাই, কোনো দিন কুল কিনারা নাই। পদ্মারে তোর তুফান দেখা পরাণ কাঁপে ডরে, ফেলায় আমায় মারিস না তোর সর্বনাশা আমার নায়ে দিল কুড়াল মারে কেমনে পারে যায় কুল কিনারা নাই কোনো দীর কুল কিনারা নাই সর্বনাশা পদ্মা নদী তোর কাছে সুধাই বলা মারে তোর তীরে আর কুল কিনারা নাই কুল কিনারা নাই কোনো দিন কুল কিনারা নাই কোনো দিন কুল কিনারা নাই কোনো দিন কুল কিনারা নাই
শুধু দর্শক মণ্ডলী সবাইকে আমার সালাম এবং ভালোবাসা। আমি কনক চাপা আপনাদের জন্য গাইতে এসেছি। আমি খুবই সম্মানিত বোধ করেছি আমাকে আপনারা আমন্ত্রণ জানিয়েছেন। প্রথমে আমি আমার ছবির গান ভালোবাসি তোমাকে এই গান দিয়ে শুরু করছি। গানের গীতিকার ও সুরকার আহমেদ ইমতিয়াজ বুলবুল। সবাই জানেন যে হেমন্তকাল, শীত আর গরমের একটা মাঝামাঝি সময়। তো হঠাৎ করে কালকে বিকেলবেলা দেখি মানে একটু ঠান্ডা লেগে গেল। মানুষ তো সবাই একটু ক্ষমা সুন্দর দৃষ্টিতে দেখবেন যদি কোথাও গলা ভেঙে টেঙে যায়।
প্রথম প্রেমে ছোঁয়া তুমি, তুমি যে মান অভিমান, সব কবিতার ছন্দ তুমি, দুঃখ সুখের বেলা, তুমি মোর জীবনের ভাবনা, হৃদয়ে সুখের দোলা, তুমি মোর জীবনের ভাবনা, হৃদয়ে সুখের দোলা। নিজেকে আমি ভুলতে পারি, তোমাকে যাবে না ভোলা, তুমি মোর জীবনের ভাবনা, হৃদয়ে সুখের দোলা। লা 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 লা, হৃদয়ে সুখের দোলা, হৃদয়ে সুখের দোলা, হৃদয়ে সুখের এই বুকে বইছে যমুনা, নিয়ে অথই প্রেমের জল, তার তীরে গড়ব আমি আমার প্রেমের তাজমহল। এই বুকে বইছে যমুনা, নিয়ে অথই প্রেমের জল, তার তীরে গড়ব আমি আমার প্রেমের তাজমহল, আমার প্রেমের তাজমহল, আমার প্রেমের তাজমহল, আমার প্রেমের তাজমহল, আমার প্রেমের তাজমহল। জানে ঈশ্বর, জানে আল্লাহ, তোমার প্রেমের কত মূল্য, কিছু সৃষ্টি হয়নি ধরায় তোমার প্রেমের সমতুল্য। জানে ঈশ্বর, জানে আল্লাহ, তোমার প্রেমের কত মূল্য, কিছু সৃষ্টি হয়নি ধরায় তোমার প্রেমের সমতুল্য। এই প্রেমে যে কত গভীর, খুঁজে পাই না কোনো তল, তারে তীরে গড়ব আমি আমার প্রেমের তাজমহল, আমার প্রেমের তাজমহল, আমার প্রেমের তাজমহল। যে পূর্ণ তোমার সত্য ভালোবাসা ছুটে পারে মহাশূন্য আছে মসজিদ আছে গির্জা যেথা গেলে হয় যে পূর্ণ তোমার সত্য ভালোবাসা ছুটে পারে মহাশূন্য এই প্রেমে যে কত গভীর খুঁজে পাই না কোনো তল তারে তীরে ঘুরবো আমি আমার প্রেমের তাজমহল আমার প্রেমের তাজমহল আমার প্রেমের তাজমহল এই বুকে বইছে যমুনা নিয়ে অথই প্রেমের জল তারে তীরে ঘুরবো আমি আমার প্রেমের তাজমহল 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 সবাইকে অনেক অনেক ধন্যবাদ সবাই ভালো থাকবেন যার যার জায়গায় সবাই অনেক ভালো থাকুন সবার জন্য শুভকামনা আসসালামু আলাইকুম
আইলারে নয়া দামান আসমানেরও তারা বিছানা বিছাইয়া দিলাম শাল ধানের নাড়া দমনবো দমনবো ও দমনবো দমনবো আইলারে নয়া দামান আসমানেরও তারা বিছানা বিছাইয়া দিলাম শাল ধানের নাড়া দমনবো দমনবো ও দমনবো দমনবো দমন কৌরে কথা খাওরে বাটার ফান দাইবার কথা কও যদি কাটটা রাখুম কান দমন বো দমন ও দমন বো দমন বো আইলারে নয়া দামান আসমানেরও তারা বিছানা বিছাইয়া দিলাম শাল ধানের নাড়া দমন বো দমন বো ও দমন বো দমন বো
ও সুন্দরী বলো আমি কি করি আরে ও সুন্দরী বলো আমি কি করি এই বৈরাগী মন পীড়িত কইরা টাটুমা ডুম্বা চাহি ডুগডুগি সোহাগ সাঁত ও সোহাগ সাঁত বদনি ধনি নাচো তো দেখি সোহাগ সাঁত বদনি ধনি নাচো তো দেখি বালা নাচো তো দেখি বালা নাচো তো দেখি বালা নাচো তো দেখি সোহাগ সাঁত বদনি ধনি নাচো তো দেখি ধিতাং ধিতাং বলে যে তোমার কোমর দোলে ওই আকাশ জুড়ে খুশির লহর আনসান আনসান বুকে আমি কেমনে থাকি সুখে যেন কাঁচা পাশে বসেছে ভ্রমণ এই বৈরাগী মন পীড়িত কইরা এই বৈরাগী মন পীড়িত কইরা টাক ডুমা ডুম্বা চাহি ডুগডুগি সোহাগ সাঁত ও সোহাগ সাঁত বদনি ধনি নাচো তো দেখি সোহাগ সাঁত বদনি ধনি নাচো তো দেখি
সোনা বন্ধে আমারে দেবানা বানাইলো সোনা বন্ধে আমারে পাগল করিল
সোনা বন্দে আমারে দিওয়ানা বানাইলো সোনা বন্দে আমারে পাগল করিল
না জানি কি মন্ত্র পড়ি আরে না জানি কি মন্ত্র পড়ি জাদু করিল সোনা বন্ধে বন্দে
ও সোনা বন্দে আমারে দিওয়ানা বানাইলো সোনা বন্দে আমারে পাগল করিল
রূপের ঝলক দেখিয়া তার আমি হইলাম ফানা
সেই অবধি লাগলো আমার শান্তির গানা সোনা বন্দে
ও সোনা বন্দে
ও সোনা বন্দে আমারে দিওয়ানা বানাইলো সোনা বন্দে আমারে পাগল করিল
ও সোনা বন্দে আমারে দেবানা বানাইলো সোনা বন্দে আমারে পাগল করিল
না জানি কি মন্ত্র করে আরে না জানি কি মন্ত্র করে জাদু করিল সোনা বন্দে
ও সোনা বন্দে আমারে দেবানা বানাইলো সোনা বন্দে আমারে পাগল করিল
সোনা বন্দে আমারে দিওয়ানা বানাইলো সোনা বন্দে আমারে পাগল করিল
In between, we are going to arrange a raffle draw program for just fun. Okay, in the raffle draw, we have 4 gifts for the winners, and to give the gifts or to pick the tokens, I would like to call up on stage our international faculties. আমি আমাদের বিএসবিসিএস এর আমাদের প্রেসিডেন্ট এবং ভাইস প্রেসিডেন্ট প্রফেসর কামরুজ্জামান চৌধুরী স্যার এবং ডক্টর সেলিম রেজা স্যার, প্লিজ আপনাদের দুজনকে স্টেজে ডাকছি আমাদের উইনারদেরকে প্রাইজ দেওয়ার জন্য। প্লিজ কাম টু ডায়াস প্লিজ। আরেকটা মাইক দিলে ভালো হতো, ভাইয়াকে একটা মাইক দিলে ভালো হতো, আরেকটা মাইক দেন। So this time the coupon number is BBCC 22791. Please check your coupons. BBCC 22791. Yes, we got the winner. The 4th prize for the winner, the raffle draw. We got the winner for the 4th prize. 791. হ্যাঁ ঠিক আছে, নামটা
মালিহা রাইসা, বার্ন অ্যান্ড প্লাস্টিক সার্জারি প্রেসিডেন্ট।
ওকে, মালিহা রাইসা, বার্ন অ্যান্ড প্লাস্টিক সার্জারির প্রেসিডেন্ট রেসিডেন্ট ফেজ। প্লিজ সবাই আমরা তালি দেই। So this time, this is BBCC 22037. 037. Oh. So we got the winner for the 3rd prize. আমরা পরিচয়টা জানি।
ফাহিম মুর্শেদ, আসানিয়া মিশন, মেডিসিন ডিপার্টমেন্ট।
ওকে, from Asania Mission, Fahim Morshed, Medicine Department. To check করে নিই, 037, right. Please take the prize. অনেক জোরে তালি দেই। This time number is 707. 707. Anyone? পাওয়া গেছে। So we got the winner for the 2nd prize. পরিচয়টা।
ডক্টর অ্যানা সোফিয়া, আসানিয়া মিশন ক্যান্সার অ্যান্ড জেনারেল হসপিটাল।
গুড, সব আসানিয়া মিশন নিয়ে যাচ্ছে। ঠিক আছে, এদিকে চলে আসো সেলিম স্যারের কাছে। আমরা অনেক জোরে হাততালি দেই, 2nd প্রাইজ পেয়েছে। লাস্ট টোকেন, 1st প্রাইজ 753. 753. Oh, পেয়ে গেছে। 753. So we got the winner for the 1st prize of today's raffle draw. This is an iPad for the winner. Let's introduce him first.
I am Dr. Mohammed Hassan. I am Assistant Professor of General Surgery, Sheikh Hasina National Institute of Burn and Plastic Surgery.
অনেক জোরে তালি হবে সজল ভাইয়া থ্যাংক ইউ এখানে শেষ করছি রাইফেল ড্র থ্যাংক ইউ কামরুজ্জামান স্যার এবং থ্যাংক ইউ সেলিম স্যার এবং থ্যাংক ইউ আমাদের বিউটি কুইন শ্রীনন্দিতা